Boreda. Good morning, namaskar. It's a great pleasure to welcome you to the 22nd Annual Conference of the British Indian Orthopaedic Society. I am Amit Chandratre, orthopedic consultant based at the Princess of Wales Hospital at Bijayendra. This virtual BIOSCon is being broadcast from the Mercure Cardiff North Hotel with expert management from Clockwork Medical. It's a real shame that we could not meet up face-to-face in beautiful Wales for this conference. In fact, this is only the second time the conference has been held in Wales, previously held in North Wales by Amit Sinha. I would like to thank the BIOS Central Committee for trusting us in these difficult times and giving us the opportunity to hold this conference in Cardiff. I would also like to thank my local organizing team for helping out for the past 2 years. We have had over 150 abstracts for the scientific submission, and the Education Committee have narrowed it down to the best of the podium and poster presentations. These will be presented over the next 2 days, and the remaining talks you can see on the platform. Please make this an interactive conference and put up your questions online, and we'll endeavor to answer these questions either live or through the platform. The conference will be available to view free of cost after the conference for a number of weeks. We are also very happy that with collaboration with OrthoTV, this is being streamed live globally. 11 CPD points have been awarded by the Royal College of Surgeons, and therefore evaluation forms will need to be completed for us to make the future events much better. These forms will be either emailed to you later on, or you could click the button on the platform. 2 days of virtual sitting down in a desk is tiring, so we have got video of exercises and yoga on the platform, so please watch this as and when you can. There's also a yoga session conducted by actress Samhita Joshi tomorrow morning to start the day. Global problems have been increased by COVID, unfortunately, and therefore we are going to hold a moment of silence tomorrow before lunch for the loved lost ones. That's it from me. Really enjoy the conference for the next 2 days. I hand over to my co-organizer, Keshav Singhal. Diok. Thank you.
Boreda, and good morning. It is indeed a pleasure to welcome you to this virtual conference for 2 days. It is a pity that we are holding it virtually because the weather in sunny Wales is absolutely brilliant today. And I understand it's going to be very good tomorrow as well, which is a rare thing for us. This is going to be an absolutely great event, I have no doubt about it. It is the first time in the history of BIOS that we have had 800 registrations. This is an absolutely amazing feat, and I'm really very grateful to our organizing committee who have pulled out all stops in making sure that this is one of the most memorable conferences ever. And it's not just orthopedic surgeons, it's a whole team. It's a team of our allied health professionals who are also going to be taking part. And really, just us as surgeons are no good unless we've got that team working of all allied health professionals. You know, obviously, from the timetable that we've got a very good international faculty. And of course, one of the advantages of having this virtually is that people sitting across the globe are much easier to find it much easier to attend. This whole organization is very dependent on the sponsors' support, the industry support. So please do visit the virtual exhibitions, and there will be a number of talks and demonstrations during the breaks. So please support them so that they can support us in the future also. We are fortunate that we will have the Health Minister of Wales, Baroness Eluned Morgan, talking to us today virtually. And moreover, we have the First Minister of Wales, Right Honourable Mark Drakeford, addressing the conference tomorrow. And we in Wales actually do benefit from having a very close working relationships with our government, which is always beneficial. We've got a couple of inspirational talks from Dr. Hitendra Mahajan of the famous Mahajan brothers. And for those of you who don't know, he's an anesthetist from Nashik who has actually climbed Mount Everest and also finished the most strenuous bicycle race across North America. I believe it's over 4,000 kilometers. We then have a Wing Commander Gora Pathak, who is actually in the UK and is a brilliant painter. You will get to see some of his paintings, hopefully, during the course of this conference. Our charity partner is the World Orthopedic Concern, which does some absolutely wonderful work across the globe in developing countries. Please do feel free to donate generously and support our charitable endeavors. For those of you who are actually members of the BIOS, our annual general meeting will be at 1600 hours today. And I will now hand over to Mr. Yogesh Nadwarwala, consultant orthopedic surgeon, to take you through the brilliant first session on chronic pain and rehabilitation. Thank you very much.
Namaskar and very warm welcome to beautiful Wales. I am Yogesh Nadwarwala, a consultant orthopedic foot and ankle surgeon here in Newport, along with my colleague Mr. Mukesh Humadi, who is an arthroplasty surgeon in Wrightington. We got a pleasure of chairing this first session of what is going to be a very educationally enriching and enjoyable 2 days of the conference. As orthopedic surgeons, we all know the value of a good rehabilitation. The success of majority of our operations depends on having a good rehabilitation, and therefore we have allocated a session for that. Now one might say that the rehab comes after the operation, but as the new research suggests, eating your dessert first makes you healthier. I got a pleasure of introducing our first speaker, Dr. Sharmila Khot, who is a consultant in anesthesia, intensive care, and pain medicine here in Cardiff. She is currently an honorary senior lecturer into the clinical research fellow in Cardiff University Brain Research Imaging Center. She has published a number of papers and using advanced imaging techniques. And she has got a very impressive list of publications. Behind this very intellectual scientist lies a passionate lover of poetry and music. With her husband Umesh, she has created a beautiful masterpiece called Lyrics of Legacy Jagjit Singh. A very warm welcome, Sharmila, and over to you.
Good morning, everyone. I'm Dr. Sharmila Khot. I'm a consultant in anesthesia and pain medicine at the University Hospital Wales, Cardiff and Vale Health Board, and a clinical researcher at the Cardiff University Brain Research and Imaging Centre in Cardiff. I'm going to speak on chronic pain after total knee replacement today and reflect to some extent on knee OA and severity of knee OA that leads to total knee replacement. My learning objectives for today's talk is to define pain, to look at the pathophysiology of chronic post-surgical, particularly post-total knee replacement pain, risk factors for developing this pain, and prevention and management. Pain, as we all know, is a biopsychosocial problem. It is what it is, especially the more chronic it gets. And therefore, it's really important to assess pain within a biopsychosocial context. Nociception is relatively simple. Somatosensory afferents convey information from the periphery, from the knee joint, up the spinal cord, up to the brain via the spinothalamic tracts. These are the A delta and C fibers that start in the periphery and converge via the spinothalamic pathways up into the somatosensory cortex for projections. However, pain isn't quite so straightforward. Pain is subjective and unpleasant, but it's a physical and an emotional experience that may be associated with actual and potential tissue damage. When we look at the pain system in humans, we can see that there are lots of changes that occur secondary to pain in an area of the body, such as the knee. There is reduction in pressure pain thresholds at the knee, which occur due to constant aggravated pain, leading to changes within the spinal cord, where there can be crosstalk between the mechanoreceptors as well as the nociceptors, leading to upward changes in the brain, causing reduction in gray matter of the cortex. These thereafter affect the descending facilitatory networks, causing increased pain facilitation and worsening pain of the knee. So what starts as a peripheral problem rapidly becomes a problem of central sensitization and central mechanism changes. The second figure is about the number of areas in the brain that are responsible for facilitating or inhibiting pain. And as we can see, the pain matrix tends to be a large matrix in the brain, and potentially, therefore, the interactions can be enormous. The patterns of nociception in knee osteoarthritis begin with early, sharp, predictable acute episodes which tend to resolve. Later on, this becomes a constant, dull background pain with acute intermittent episodes which are unpredictable and sometimes remain unresolved. This therefore leads to loss of ability of function, can't walk well, change in gait, change in posture, and therefore further inability to control pain, which significantly reduces function, eventually leading to a total knee replacement. In knee OA, we see that there are bone remodeling changes, and these profoundly change the biochemical structure within the joint, causing an effect directly on the joint mechanics, causing knee pain. But there's also, in addition, tissue remodeling that occurs, which involves changes both in the joint innervation as well as the inflammatory changes within the joint, which affect pain pathways directly. Pain, therefore, as we said, is not just a sensory, but also an emotional experience. Therefore, it's personal. It changes depending on the biological, psychological, and the social constructs. It is different from nociception, and therefore the degree of pain cannot be inferred solely from activity within the sensory neurons. Throughout their life, people experience different types of pain, and they learn about the concept of pain and what's bearable and unbearable. And this leads further to how they manage their pain, and especially the chronic pain of knee OA. The only way we know a person is in pain is by their own self-report, and what pain they tell us they have is the pain that we report they have. Pain serves an adaptive role, but the longer it lasts, the more it impacts function, psychological, as well as social well-being. The experience of pain depends on three systems that are interacting. The sensory system, which is discriminative, and so it tells us about the strength, the intensity, the quality of pain. Is it when I walk? The temporal and the spatial aspects of pain. The motivational is about how we approach pain, how much we avoid it, or what we do to avoid it, and how it may impact on our ability to manage pain. The cognitive experience of pain is more evaluative. It's based on our learned behavior and our previous experience of pain, and teaches us how to either upregulate or downregulate pain in the long term. When we see knee pain following surgery, it is a complex process and it involves several mechanisms. And this cloud or word cloud that I've generated is based on the referral letters that I get and the number of terms that are used within those referral letters when these patients are referred to the pain clinic. So we have inflammation, scar pain, sensitization, peripheral sensitization, complex regional pain, mechanical pain, central pain, neurogenic pain, and all of these essentially are describing people with chronic post-surgical knee pain. A paper that was elegantly described by Esgard et al. In 2015 applied a cluster analysis to 216 patients with osteoarthritis with joint pain and described 4 distinct knee pain profiles based on different variables that they used in order to analyze people with OA pain. And they've used variables such as the WOMAC scores, the Lequesne index, the EQ5D quality of life index, but also psychological questionnaires such as catastrophizing, but psychophysics measurements such as pressure pain thresholds, temporal summation, conditioned pain modulation, and serum measurements such as the C1M, C2M, C3M, CRP, and CRPM. Based on a combination of unique measures such as biochemical, pain biomarkers, physical impairment, and psychological measures, they came up with these 4 profiles, which give us some idea of factors that lead to resilience or susceptibility to developing chronic pain. And some of these are high condition pain modulation with high pain thresholds. These are likely to recover with no chronic pain, for example, versus profile C, which is low pressure pain thresholds at the knee, increased temporal sensitization, low condition pain modulation, suggesting a lot of peripheral and central sensitization, suggesting that these people may be at a high risk for chronic post-TKR pain. And using some form of stratification preoperatively that can be further developed would certainly give us an indication of which of your patients are likely to progress to post-surgical knee pain. The other piece of work that was done by Shipton and Tate in 2005 reports factors leading to susceptibility to chronic pain, including infection, bleeding, resurgery, and presence of compartment syndrome. Patients who report this are almost likely to develop chronic post-surgical pain post-surgically. There's also the element of psychological vulnerability, such as expectation of chronicity, pain-related beliefs, attitudes that patients have towards surgery, and environmental factors such as low self-rated health. Preoperatively, it has been seen that younger female patients who have pain prior to surgery for at least 1 month continuously, or preoperatively other chronic pain conditions, are more likely to develop chronic post-TKR pain. There's also a genetic predisposition and people with previously unrelieved pain and history of severe pain that would have increased susceptibility to developing chronic post-surgical pain. So we now have this state where there's peripheral activity due to tissue damage or nerve damage during surgery, which leads to this process of central sensitization that then further leads to increased sensitivity to pain or hyperalgesia, spontaneous pain, allodynia or pain on touch, reduced thresholds to peripheral stimuli, pain in areas of the body where they haven't felt pain before outside of the knee, and increased spontaneous activity. So what we want to do realistically is to look at how we can prevent chronic post-surgical pain, because that would be the best way of managing it. And what is it exactly that we want to prevent here? And we want to look at central neuroplastic changes and change those, maybe prevent those from happening. We want to prevent transition of acute to chronic pain by managing acute pain and pain around surgery better. We want to change the focus from treatment of pain afterwards to preventing wind-up, as well as preventing ongoing pain. Therefore, the concept of preventative analgesia, which supports prevention of central sensitization, was born. And the aim of it is to prevent pain facilitation. However, the mechanisms by which central sensitization develops in OA is currently really unclear. Preemptive analgesia or preventative analgesia includes any analgesic regime that reduces pain-induced sensitization, and therefore realistically includes multimodal analgesic techniques with analgesics that exceed the expected duration of action and act both on central and peripheral mechanisms of pain. There have been a couple of PRISMA-compliant meta-analyses of RCTs that have been published by Chauhan et al. For gabapentin and pregabalin, which have been used preoperatively in a bid to reduce chronic post-surgical pain. Pregabalin and gabapentin both inhibit the calcium influx via voltage-gated calcium channels, have central as well as peripheral analgesic effect, but also have a potential for dependency and black market value and are controlled drugs currently. Both of these studies, unfortunately, showed no change in visual analog pain at 12, 24, or 48 hours postoperatively between the drug group and the placebo group. However, they both suggested that there was a reduced cumulative consumption of morphine, improved passive knee flexion range in the pregabalin group, but not in the gabapentin study. The disadvantage of a number of studies that were involved in this meta-analysis is that there were variable doses and a big range of doses of pregabalin or gabapentin that were included in the studies. And it indicates that a lot of work needs to be done in this area. Again, a lot of these studies were anesthetically led and surgical details were not included. There has been some work that has been presented by Kurian et al. In 2018, particularly looking at neuropathic versus nociceptive knee pain preoperatively. And this suggests that the pain detect questionnaire can be used preoperatively to identify neuropathic pain-like symptoms in people with knee OA. Additionally, people with knee OA that presents with neuropathic symptoms increasingly are likely to present with chronic post-surgical knee pain. Patients with pre-op high PDQ scores also had high postoperative pain scores in this study. This was extended by Soni et al. In their publication in 2019, where they combined use of pain detect questionnaire scores with brain neuroimaging and demonstrated that high PDQ scores and high neural activity in the rostroventral medulla developed moderate to severe long-term pain after total knee replacement. When these people are referred to the pain clinic, we tend to assess for neuropathic elements and treat neuropathic pain with medications such as amitriptyline, gabapentin, pregabalin, opioids, or other drugs as indicated based on the mechanisms. There are also other non-neuropathic or nociceptive elements to the pain, and we can recommend complementary therapies, but also injections such as trigger point injections. Referral to physiotherapy following injections tends to help extend the life of any injections that we may try in the pain clinic. For the elements of chronicity and the psychosocial aspects of chronic pain, we may refer these patients onwards to one-to-one counseling or to a multidisciplinary pain management program. There are also treatments for OA based on underlying pain mechanisms that are now available, such as anti-NGF antibodies, because we are aware that NGF plays a role in peripheral sensitization and is therefore thought to cause a direct effect on peripheral nerves and therefore be beneficial in reducing this direct peripheral effect. TRPV1 receptors demonstrate activity with capsaicin, and we now have 8% capsaicin patches which help reduce peripheral sensitization and alter nociceptive changes that take place with peripheral sensitization. There's also lignocaine plasters that work on the NaV 1.7 and 1.8 receptors on the nociceptors and calm these receptors down. Injections such as genicular nerve block, diagnostic injections, as well as radiofrequency are now available and are thought to be quite effective, particularly in patients who cannot undergo total knee replacement or prefer not to. They have reasonable efficacy both in nociceptive as well as neuropathic knee pain. And post-procedure, it is really important to introduce physiotherapy in order to improve efficacy following these injections. Genicular nerve branches can be easily approached with needles under fluoroscopic guidance or using ultrasound. Patients who have genicular nerve blocks tend to be people with chronic knee pain secondary to OA, people with failed knee replacement, patients unfit for knee replacements, or those who want to avoid surgery. There has been a paper published, albeit with small number of patients, 26 subjects, looking at genicular nerve block and kinematics, and it is thought that the gait kinematics of people has been seen to have improved immediately an hour after genicular nerve block. And this study particularly looked at walking at 10 meters at self-selected speed, higher speed, climbing upstairs, climbing downstairs, and walking freely for 6 minutes. Of course, we can't forget that there's a genetic basis for individual variations in pain perception, in development of chronic pain conditions. And given the wide range of variability in pain sensitivity among humans, at least some of this variability is inherited, and clinicians and others therefore should try not to stigmatize pain-sensitive individuals. These patients may indeed be feeling more pain than others do, even with the same objective stimulus. These are the references that I've used for the talk. And it's perfectly possible to lie on a bed of nails, given how our brain works. I'm open to questions. Thank you.
Thank you so much, Sharmila, for a wonderful presentation with this combination of the practical tips and a lot of science and theory behind it. And I think it has generated a number of questions, and if I may present them to you. The first question is, how do we prevent the patient from developing a chronic pain after the total knee replacement? Do we have any practical tip for our surgeons?
I think being able to stratify preoperatively who is more likely to identify people who are more likely to develop chronic pain would be the best prevention, really, because you can then refer them onwards to your pain clinic colleagues and ask for them to be treated preoperatively, perhaps with neuropathic pain medications if they are indicated, or other ways of managing pain. And in order to do that, as in the XCARD study, using different combinations of questionnaires and tests, objective tests, we may be able to perhaps develop a way of rehabilitating the more sensitive patients, the patients who are more likely. There isn't a huge pool of them, I don't think, but the ones that can be identified can then be potentially undergo successful surgery and a successful rehabilitation postoperatively.
Thank you. Thank you very much. The question which has come from Harvinder Pal Singh actually sounds quite odd to me, because he said that does the pain sensitization depend on the personality? And I'm being a regular meditator for 14 years. I think he asked the question I would have asked is, does meditation have any role in management of pain?
Does it depend on personality? Well, we know that people who tend to catastrophize or pain-related catastrophizing and people with high levels of anxiety can certainly develop this sort of wind-up phenomena where their nociceptors are more sensitive, if you like, to develop or feel pain at lower thresholds sometimes. So certainly meditation has a role. I would not argue against that at all. And there are some studies looking at mindfulness meditative techniques. There may be some on Vipassana as well, but there are certainly studies that have been done looking at mindfulness and pain and brain changes. And there has been some evidence that suggests that meditators have slightly different connectivity of their brain networks as compared to non-meditators. Now, I couldn't tell you exactly what the difference was, but there are definitely publications out there looking at meditation and pain network changes.
Thank you so much. And one of the questions which I may ask, which has been sort of puzzling me for many years, doing the knee replacement for years and years, when we do the second knee replacement, patient come back and say, this is more painful than the first one. Now, I always warn them with the experience that, look, this is more like you feel more pain, probably something to do with your conditioning or impression in the mind, because we normally do the worst knee first, so that should be more painful. And if I tell them in advance, they'd worry less. I mean, I give them examples that some women say the second delivery is more painful than the first, but I don't know. What is your view on that? Why would the second side feel more painful than the first one? Because normally we do the worst side first.
Okay, so one of the reasons, I suppose, could be this effect known as conditioned pain modulation. So when we have two competing pains in our body, if you like, the one that is stronger always wins out. So it is almost impossible, I think, to feel two pains at exactly the same intensity, because that's the way our pain mechanisms work. And I wonder whether, so you're talking about redo this is, or whether
no,
this is
second
a
side.
new knee?
Second
side.
This is the second side. We do the left knee replacement first, and then 2 years later we do the right one. And they say, that was more painful. So now I warn them that you might feel more pain on this one, because they forget what was it 2 years ago. Well,
but that is the other thing, isn't it? As you said earlier, you forget how much pain you've had because you've been pain-free for a little while afterwards. So when you've got two knees, both severely painful, both have affected your gait, and then you have one knee that's sorted out, potentially well, and you're now walking better and your gait is hopefully better as well. And then you go in and you have your second knee and you've had 2 years gap in which to forget how it has been previously. It's quite possible that the changes have reverted back. So your brain, and there has been brain imaging studies that have looked at pre and post knee replacement brain changes, and they've shown that they revert back after a knee replacement as well. So, which is why I think knee pain is, or joint pains, I think, are just so different from other neuropathic or other chronic pains, because of the potential for reversal of the nociceptive and neuroplastic changes. And so they've started classifying them as nociplastic or neuropathic-like rather than neuropathic. They don't just fit into the same box somehow.
Thank you. One more question, because I know you got a great interest in the imaging. And one of the questions is that, is there any advancing in imaging where we can assess something is improving or deterioration, or means, from orthopedic point of view, we could say we can genuinely differentiate between the whingers and complainers?
So that would be the ultimate holy grail, I think. But there are so many changes that occur within the pain networks, and they are all affected by not just nociception, but also by, as you mentioned, psychological impact as well. And it is quite difficult to identify or stratify exactly what it is that might be winding up your pain system. So I think we are a little bit way away from saying that we can use neuroimaging to say with a degree of certainty that, here you go, Yogesh, this patient will definitely give you a fantastic outcome. I mean, we might be able to, in a certain type of patient, be able to say, well, absolutely go ahead and do this because I've done a biophysical examination as well, but not completely.
Not yet. Okay. And I got a question coming. So the Sanjeev Anand wants to know, what is the role of spinal cord stimulator and how do you sort of in relation to the GNB you mentioned, when do you use spinal cord stimulators or GNBs in relation to each other?
Okay, so the genicular nerve block is a peripheral block, right? So it's at the joint itself. Whereas a spinal cord stimulator is within the epidural space, and it is a much more complex procedure than the genicular nerve block. So they're two separate, absolutely separate procedures with completely different indications. A spinal cord stimulator we would tend to use at sort of an end of the road, almost in conditions such as complex regional pain syndrome. If your patient develops that, there is some evidence to suggest that it may benefit patients such as those developing a chronic peripheral pain may benefit from spinal cord stimulator use. It is in our setup. These are inserted by the neurosurgeons they have a process by which they come in and they are assessed. They have a multidisciplinary team assessing suitability for spinal cord stimulators before the patients undergo these. And the success rate can be pretty high if you have chosen your patients well. They are usually used for nerve pain, and they tend to be more helpful for a neuralgic or a nerve pain situation rather than muscle pain.
Thank you. Thank you so much, Sharmila. You know, we as an orthopedic surgeon sometimes are a bit of a pain for the anesthetists, but you have clarified so many concepts for us. And on behalf of the BIOS and all my colleagues and all the delegates, I would really like to give you a big thank you and joining us for a wonderful, wonderful presentation. Thank you so much.
Thank you.
Hello, friends. My good friend Ashish Babhulkar is just finished operating in Pune, India. So what we're going to do is take a coffee break now. Just a couple of announcements. On the platform, there are additional talks which you should view during the breaks. One is by Dr. Sanjay Deshpande, consultant anesthetist, who's going to talk about Indo-UK collaboration and how BIOS can work with them regarding the fellowships. Another talk is by Vinay Takwale, who's a CD of NHSEI, who's going to talk about medical force challenges in the UK. So as usual, there's small interruptions, but we'll break to coffee break now. Thank you.
Hi, I'm Nick, BodyCAD Product Manager at Hospital Innovations. BodyCAD's fine osteotomy system is a new and innovative way of looking at osteotomy around the knee, offering a level of precision and personalisation in osteotomy, planning and execution not seen before. With 3D planning, 3D printed custom cutting guides and a patient-specific manufactured plate, fine osteotomy offers a unique solution to achieve the planned correction safely and precisely. Please enjoy our software demonstration of the planning stage.
So the first step is to load the case. So here what we are seeing is the CT scan of the patient. So we have all the bone anatomy in 3D model. So we have the tibia, femur and fibula, and we can rotate it and see all the anatomy of the patient. The next step is to, the software is superimposing the bone model over the X-ray. So it's a long-standing X-ray. So it's for it serves to have the bone model in a weight-bearing position. So now the tibia and femur has been superimposed perfectly to match the X-ray. So we have the CT now in load condition. Next step then is the software is positioning some landmarks. So all the dots we are seeing at the screen are specific anatomic landmarks. So some are for the epicondyle example, or the other are for the plateau point, the tuberosity, etc. So with all those dots, the software is able to draw the line for the mechanical axis and the anatomical axis. So we have all this information in 3 dimensions, and there's also the disc we are seeing here are representing the plateau, the tibial plateau. So with all this information gathering, the software is able to calculate all the measurement. So now we are seeing the landmarks also overlapping on the X-ray. So with all these landmarks and mechanical axis, the software is able to calculate specific measurements. So for example, the MLDFA or the MPTA. The software is able to show or hide every measurement. So we have more than 50 measurements in total. But here on the screen we can see a resume of the knee measurement used for a osteotomy case. So for example, here we will see the medial tibial slope angle, and since we are in 3 dimensions, we have also the lateral tibial slope angle. So also on the screen we can see cadran that are showing if the measurements are in the green acceptable range or in the red non-acceptable range, so we can see where is the deformity of the patient. For example, this patient is in varus. So we can have all access of the information of the measurement. So we have a description of the measurement, and we have description of who publish what standard are published where. So this provide the prep tech, the technician, the ability to see what is the initial situation of the patient, and then on the next step, planning the osteotomy according with this measurement to know what exactly will be the best opening or closing wedge angle for correcting the patient. So as we can see now, we are seeing the red line is defining the cutting plane of an open wedge. The green dot is representing the hinge axis of the cut. So we can see that the software is positioning the hinge axis at 10 millimeters from the lateral plateau and 10 millimeters from the lateral cortex and 15 millimeters from the lateral plateau for an ideal opening wedge as written in a reference book. So we can see that the osteotomy is represented all in 3 dimensions, and the hinge axis is also represented in 3 dimensions. We can adjust the cutting angle and adjust the correction also. So the software is calculating the opening, ideal opening 8 to be able to correct the mechanical axis at a specific measurement. So for example, here we have corrected it at 55% of the tibial width. So in the new measurement panel, we can see the measurements are changing with the amount of correction. So now we are giving it more correction or less correction, and we can see all the measurement in the panel at the right changing at this simultaneously. All the measurements are also calculated in every dimension, so we can have see also the effect of this osteotomy on dimension in the sagittal plane, for example the tibial slope angle, so we can be sure that with this correction we don't change the tibial slope. So here we are seeing is that the measurements are classified in initial measurement, final measurement, and the difference between both measure with the osteotomy applied. So this can be planned for opening wedge, closing wedge, also an opening wedge on tibia or closing wedge on femur. We can plan any type of osteotomy around the knee with this software. The next step will be the design of the cutting guide. What is interesting to note about is the special way how we cut the bone. We are using drilling technique. So the drills are depth calibrated, and with the cutting guide there's a drill sleeve that will control the depth of the drill for each drill. So with this concept we can be sure to respect the hinge position, to respect the hinge axis actually, and also to cut only the bone necessary enough bone to perform the whole cut, and not cutting more than what is needed. So here what is showing is the drill guide. So the drill guide are labeled with a blue 110 millimeters. It was the type of drill necessary to use with this specific cutting guide. In the surgical reusable instrument tray, we have different drill to use with different guides. Also, the guide is used for the bone spreader. So the box we are seeing in the posterior side of the cutting guide are used for the tool bone spreader. Final step is the plate design. So here we already have a plate that have been designed. We can see the specific part of the plate have a specific wedge. So the wedge is respecting the opening that was calculated in the step in the osteotomy step. We can see the wedge have a different height, so it's in a taper shape. So it's respect the exact opening we have decided to do. So the ratio are not the same for the opening. So we are less in the anterior part than in the posterior part. So we can see also that all the screws have been positioned correctly. So the software is calculating the correct length of each screw. So in the kit you will receive only the screw needed to implant this in specific plate. So when we are designing the implant, we can adjust the direction and the depth of each screw, so we have a perfect coverage of the plateau of the tibial plateau. So as you can see, the software is changing from length to respect if it's a bicortical screw or a cancellous screw. The software calculates automatically the right length to be used.
Welcome back. So, it is my great pleasure to introduce our next speaker, Dr. Ashish Babhulkar, who is one of the most eminent shoulder surgeons in India. He is the founder president of the Indian Elbow and Shoulder Society, and he is also a founder director of the mega shoulder event called Shoulder and Conclave. He has pioneered the number of surgical procedures like reverse shoulder replacement first time in India. He is also on an editorial board of the BIOS, the Shoulder and Elbow Journal. When not in his scrubs, Ashish enjoys running marathons, scuba diving, and shooting the air rifles. With his motto of the Yog Karmeshu Kauchalyam, Dr. Babhulkar truly excels on everything he does. A very warm welcome, and over to you, Ashish.
Hi, thank you very much. And this is indeed a pleasure and privilege. Thank you, BIOS, Amit and Bijayendra and the entire team. It's a great opportunity. Am I audible to everybody? Hello?
Yeah, we can hear you loud and clear.
And you've got my screen as well?
Yep.
Yep, thank you very much. Those are the two commonest questions that are asked these days on Zoom. So without much ado, let me continue, and I'm going to share with you our concepts on the shoulder rehab program, and that we have indigenized to our local needs, and sort of a cookbook recipe program, and we'll share that with you. I'm not going to give bells and whistles because I'll just share the concepts that we have done. Now, to be honest, most of us understand that amongst all the joints, the shoulder is the most difficult one to rehabilitate, and it's always challenging because of several issues. Now, if I look at the design of the shoulder, there are some feature of the shoulders that are absolutely impressive and fantastic. And at the same time, there are some concepts that if you look at, and I look at them at absolute ridicule, to have such a loose capsule, no real ligament as such, and the fact that there are two tendons that passing right through the joint makes them very vulnerable. So these are the things that spoil the chances of a rehab therapist to recover the patient. Now, the posture itself will affect the function of the shoulder, and the suprascapular nerve, I find it is often neglected because not often do clinicians understand the role of the suprascapular nerve, which kind of denervates the rotator cuff, and you end up rehabilitating and not getting any rotator cuff recruitment. So that makes our job very, very challenging. Let's start with some of the biomechanics concepts of a frozen shoulder, which is known with a plethora of terms. There's so much diversity in what we call it, but at the end of the day, it still remains an enigma. And if any therapist or clinician today understands frozen shoulder, then I think he's got the answer for global warming. And I must confess, after 20 years of practice, we're still struggling to find out what exactly causes frozen shoulder and why it undoes itself and automatically gets better after a period of time. So truly, if anybody has really suffered frozen shoulder, only he can empathize with another patient. The triad of interminable pain, severe function loss, and sleep loss cannot be alleviated by painkillers and conventional rehab, and it just takes ages. Unlike a rotator cuff tear patient, unlike an impingement patient, this is something that defies treatment. And you give the same treatment to all your patients, not everybody responds similarly. Taking from Andre Roy and Jones' work from JSCS 2002, even after 1.5 years, when they have auto-recovered, they still remain stiff terminally, they still have weakness in their rotator cuff. So it's not all done, and so it cannot be automatic. And then we have different phases of adhesive capsulitis. I can't fathom how the shoulder understands that it's 3 months now, let's move to the frozen phase. So not every patient follows the written rule. So each one is different. Some of them will recover on their own within 6 weeks by the time they get their appointment coming through. And the others are absolutely miserable even after 9 months. Now let's consider some of the biomechanics of the frozen shoulder. But firstly, you must understand that this is one of the conditions that actually restricts your external and internal rotation both. Now that's strange because you would expect that if there was an anterior pathology related to subscap, you lose your external rotation. If you had a posterior pathology, if you have a teres minor infras problem, you'd lose your external rotation. But here is one pathology. Apart from primary osteoarthritis of the shoulder, I don't know any other pathology that will restrict both internal and external rotation simultaneously. So the external rotation is, I can understand, I can justify. The internal rotation is inexplicable. And because the biceps is involved in restricting internal rotation, it is the last movement to be restored back again. So let's see if we understand these concepts. So this is the rotation arc. So every internal and external rotator or every agonist antagonist has its own rotation arc or a rotation ratio. Let's say it is X here. And when you have a tightness of the infra or the subscapularis or the rotator interval or the anterior structures, that gets narrowed, and then you get a obligate anterior translation. So now look at the role of the force couples here in the axial plane. You have a weak infraspinatus, you have a very strong subscapularis, internal rotation, and then that's drawing the head anteriorly towards the coracoid, and then the subscap gets stuck to the conjoint tendon or the short head of biceps. That could lead to a fixed internal rotation contracture. So now you have restricted external rotation and restricted internal rotation. Look at case 2 here, that when we know that in frozen shoulder, the biceps is the most inflamed organ there. And invariably, because the biceps is inflamed, if you now take your hand behind your back, you would see that you're stretching your biceps there. Because it's inflamed, then it's going to restrict the internal rotation significantly, and you'll end up with a 0 internal rotation. I really can't fathom the role of biceps in the shoulder joint. And unless it's its march towards extinction as an atavistic tendon, the biceps, I think, remains as an organ where pain emanates from the shoulder all the time. And then the third sequence here, that when somebody has a restricted external rotation because the entire anterior capsule is stuck to the coracoid, they will lose their external rotation. The greater tuberosity will not be able to clear the acromion. They developed impingement and restricted abduction. So this probably is the whole sequence where there's a global loss of range of movement, but there are different entities involved in restricting these. And the challenge of this therapist is to work on 3 different entities simultaneously. Some smart therapist who understands this pathophysiology is going to work on each one by one and progressively improvise the patient. But if you just generically give same exercises to all the patients, then it's unlikely that they will respond. Now, there are several variables that affect the outcome of the frozen shoulder. Now, typically diabetes and hypothyroid are well known, and these are patients who wouldn't do so well in the long term. But to me, secondary frozen shoulder, like post-surgery, post-fracture, and post-manipulation under anesthesia stiff shoulders are probably the worst. They defy the best therapists, and they will take an enormous time to get even a mite better. Now, judging by the premise that a restricted external rotation is going to affect abduction and the entire range of movement, and for strengthening, you need some excursion of external rotation, and the fact that it is zero, we devised this study 2 years back, and that was based on the premise that if the rotator interval is tight, then we give a 20 cc normal saline injection, no steroids involved, and that is given ultrasound guided in the focal area. So this is a high volume USG guided extra-articular, the huge study that we did for disease capsulitis. And that has kind of made a big difference to our frozen shoulder patients. It's not rocket science. All we are doing is creating an external movement so that even if we can improvise a little bit of 30 degrees of external rotation, our therapists will get an opportunity to rehabilitate and strengthen their shoulders. So this is an example of a patient who's got very restricted external rotation, just coming up to barely 10 degrees, 15 degrees there. And then the next video is after the 20 cc normal saline injection, and you can see an instant improvement to almost 40 degrees here. So coming to our PSRP, which is the Pune Shoulder Rehab Program, we believe it's a bottom to top approach. So we work on the basic that they come for a robust 2-week exercise program, which is supervised. And then they should be 50% better in terms of pain, in terms of movement, and in terms of rotator cuff strength. If they achieve this all three, then they are qualified to move on to the home program, which they'll do for 4 to 6 weeks. As any right-minded therapist would agree, we don't use any modalities. We try not to give them any analgesics. And I consider myself as the chairman against the Society for giving steroid injections. The program is time-bound, so there's pressure on us to give the results in the first 2 weeks on all 3 counts. And we measure their UCL scores on day 1, and then again on 2 weeks, and then finally at 6 weeks. And they should be about 40–50% better after phase 1, and then almost 80–90 after phase 2. The program should be sustainable across all therapists, and we started with a single therapist, and then we've moved on to almost a team of 12 therapists in the city. And it ought to be scalable. So for the athletes, they will come back for a phase 3 higher program, which is more forceful and it involves plyometrics and advanced planks and such stuff. The intake is assessment based. So since I select the patients, and I probably think that I select the right patient should go for rehab and not the ones that have tears and neuropathy. So there are challenges. The challenges in shoulder rehab, each of us would have faced. How do you rehabilitate a patient in the presence of pain? So most patients, we try avoid analgesics because then the onus is on the therapist. And then the patient also, after 2 weeks, if he's 50% better, he will realize that his pure improvement is from the exercise and nothing else, and then likely to comply and stick to the program. We believe some of these are ungrateful muscles which do not automatically respond, and I'll dwell upon this in the slide ahead. I wish we could have measured proprioception, because those therapists who have proprioceptive skills or who can impart proprioception, those are the patients who will recover very quickly. And that's why some patients just chart a fantastic recovery, and there are others who are stragglers and will continue to recover pedantically. Of course, without the scapula, no shoulder program is successful across the world, and we understand we give that due importance to the scapula as such. And because we are, as I said, give a finite timeline, the challenge is that the therapist has to do his best in those 2 weeks, which usually invariably they do in our setup. As far as compliance is concerned, we keep telling our team that if they can impart function and they can mitigate the pain purely with an exercise program, that patient will have complete motivation to come in, and there's no reason why they should drop out. We do have dropouts. There are difficult patients. There are patients who have their own agenda as well. But by and large, we're saying that 80–90% of the patients would do well. I think over the 20 years of practice, I've learned that just because you're giving an X amount of exercise doesn't mean that that muscle will recruit. I think there is zero rocket science involved in rehabilitating a knee, in strengthening quadriceps, because there's no challenge there at all. It's a uniaxial joint, and when you give an extension exercise, it has to impart that to the quadriceps. But muscles like transversus abdominis, supraspinatus, infraspinatus, VMO, and the tibialis posterior are very challenging, and doesn't mean that just because you're giving the exercises, they will recruit. So you have to dig deeper as a therapist to ensure that your exercises are recruiting the right muscles and not causing any compensation. Here again, most of you will agree that those are research-oriented and modern therapists will agree that there is no entity like fibromyalgia. It's vague, there is no specific definition to this, and we don't believe that fibromyalgia exists at all. We know the yeoman's contribution that Kibler has done towards introducing the scapula to every rehab program, and all across the world, all of us do understand that the scapula has to work there. Since this is your forte and you understand this better than I do, I don't need to dwell upon the science of scapula and the contribution of Ben Kibler, who remains a hero for us. But Kibler did describe 5 types of chronic causes of pain, and we must understand that every shoulder condition, whatever, whether it's impingement, whether it's a calcification, whether it's rotator cuff tendinosis, bursitis, it will involve some scapular dyskinesia to some extent, 100%. And when you have a scapular dyskinesia, it's altered biomechanics. And so you get all these trigger points and fibromyalgias. The smart therapists who can recruit the rotator cuff and prior to that can restore the scapular kinesis will ensure that these aches and pains and fibromyalgias will get over. So we don't address these specifically. We look at the root cause fundamentals and we set that up. So looks can be deceiving, doesn't appear. So just because somebody has neck pain or tennis elbow doesn't mean that they have a local problem here. We started working on proximal inadequacy leading to distal decompensation conditions back in 2008, 2009. In fact, I stopped my tennis elbow injections back in 2007. And since we are aware of the victims and culprits approaches, we hit upon that. We realized that PSRP is sorting out so many other issues that we applied the same principles to the lower limb for tender Achilles and Pesclin valgus and tibialis posterior incompetence. And in 2009, I came across and chanced upon Dr. Janda. So Vladimir Janda is an absolute maverick. He from Czechoslovakia. He's an eminent neurologist, and his contribution to musculoskeletal pain is amazing. And when I chanced upon him in 2009, we realized that we shared so many common concepts, and we agreed on most of things. Unfortunately, he's no more. But if anybody who's a therapist worth his salt and who's not come across Vladimir Janda's work on functional training should really go back and study Janda. We are seriously inspired by his contribution. So this is where the victims and culprits approach was discovered, and when we realized that a weak rotator cuff will lead to other dysfunctions distally. And so instead of treating a local trigger finger and Tickerwin's tenosynovitis, we'd rather fix the proximal pathology first, and the distal will automatically fall in place. So these are several case scenarios. We'll go through all of these. You understand most of these. Let me quickly go through the PSRP program, which is, you can say, the idiot's guide to shoulder rehabilitation. So this is the definition of PSRP, a low resistance, high repetition, sub-impingement range of isotonic scapular muscle rotator cuff strengthening. Pretty much common principle to all shoulder rehab programs as such. Ours is a deficit-based approach, but the fundamentals remain the same. Because we do a 2-week robust phase 1 supervised for everybody. I know that is not feasible in the West, but here we don't trust our patients to do the exercise. I can't conceive that a patient sees the exercise once and does that exactly at home because there's so much of compensation involved. So as I said, it's a structured supervised program, and we improvise on 3 fronts: the pain, range of movement, and strength. But a key feature of PSRP remains the supervised program as such. We strictly don't like free weights because that is open chain and doesn't work well. We are completely devoted to using elastic resistance bands because they work the best and they're strength graded. But we spend a lot of time diligently trying to, let me just switch off the audio there. we spend a lot of time ensuring that compensations don't occur. And this therapist here is teaching the patient how to wear the band, use the sub-impingement, so not to go into abduction over 90 degrees. And this you must have seen, this is a bindi treatment. So these are the red dots that Indian ladies will wear on their forehead. We allow patients to wear these here because this is a reminder that they need to do their bracing. Otherwise, they lose the posture by evening. So some of the difficult MDI patients will be given. So these are adjuncts that we use to enhance their compliance as such. Again, I won't go into why bands, why no police, because given your forte, you understand much better than I do. But in the shoulder, there's a lot of compensation, and that's why here she's showing us the Euro grip. We must ensure that the bands don't cross the wrist because the wrist will hyperextend, create new points of pain, and you got to ensure that they measure the length so that the muscle is strengthened along its lines of stress, and at the same time, the peak forces should be in mid-range and not in the end range. So all our exercises are devised like that. I can't go through all the detailed PSRP program because it's a whole day workshop course here. And just to finish off, I'm going to introduce another controversy. I know that the literature is sold out on Fullcan being a better recruiter of supraspinatus, but I think they've got it all wrong. We are completely convinced that it's the empty can that works best on supraspinatus because all these studies have tested their movements in 90 degrees and above or full abduction. Now that's inconceivable that the supra can maintain that. So it is disingenuous to go above 30, 40 degrees. So all our patients will strengthen the supraspinatus in empty can in spite of the literature in support of the full can because we are picking holes in all this. So this is a FDG PET study, very nicely designed. But again, all their testing is done at 90 degrees. This is where a whole lot of deltoid, whole lot of trapezius is going to come in. The supraspinatus starts getting suppressed after 60, 70 degrees here. The most important feature of PSRP is the review. So we review them on day one. After 2 weeks, we do the UCL scoring. And then at the end of 6 weeks, we do another scoring. There are several adjuncts here. We don't handle subscapularis because that again creates a force couple that is way in favor of the internal rotators. But there are exceptions. So as in medicine, nothing is absolute. So in patients with slap tears, we know that subscap fatigue is a feature. They will get a subscap strengthening program. In subscap repair patients that I have done, they will get a subscap program. We are not so good on stretches. We don't think that stretching before strengthening is a good idea. So we are very minimal on stretching as such. Post-op role of external rotation is restricted when we're dealing with 4-part fractures of the proximal humerus, especially in the presence of hemiarthroplasty. And again, because we don't go above 40, 50 degrees of abduction in the scapular pain, our deltoid is not a problem. So we don't like deltoid recruiting. So finally, last few slides here. This lady is the inspiration for the PSRP. I started rehabilitating her when I started my practice. It's a long story, but she had the worst kind of scapular instability and she suffered for 13 months before. And she had a lot of psychological issues by then because she'd run from pillar to post. And I sat down overnight and wrote up the PSRP. And in next week, I started giving her therapy myself. And then I devised the whole program in the tenets of PSRP. And within 2.5 weeks, this baby could start her movement, stabilize her scapula, and was pain-free. So I realized that it's not that so difficult. But these are some of our examples you're seeing a lady who's had 3 surgeries. She had a fixation, then she had a hemiarthroplasty. She's a young 48 lady, went completely wrong and came to us 3 years after all this. And then you would have thought that she hadn't slept a day and a lot of pain, a lot of dysfunction. Unfortunately, we had to do a reverse shoulder replacement because by the time she come, her whole biomechanics was gone for a toss. There was no greater tuberosity there. And so this was in a form of salvage. It's a good salvage looking at the way she's performed here. This is another patient here who's had simultaneous right shoulder, reverse shoulder replacement on the right side and left shoulder cuff repair, same sitting simultaneously. And you would think that in 3 months' time, you would see such a good function. So this is not my surgical skill. It's a combination of the surgical skill complemented with a good shoulder rehab program. And these are, trust me, bilateral shoulder operated, same sitting, are very difficult patients to rehabilitate. surgeons are reluctant to do Bankart repairs for super athletes, contact athletes. If there's no glenoid bone loss, we do not do a Lataji, we don't do bone procedures. I'm still sold out on the Bankart repair. And these are some of our patients who won silver medals at the Glasgow Commonwealth Games. They are mixed martial arts. And these have all undergone a Bankart repair. So if there's no bone loss, I would still do the conventional arthroscopic Bankart as such. So from the patient's point of view, the emphasis is on pain, get me pain relief. From a therapist point of view, often there's I need to restore your range of movement. But from our team, I think our entire emphasis is strength of the rotator cuff. If you can recruit the rotator cuff, it means that joint has reached its biomechanically neutral status, and they will be able to restore the range of movement and pain automatically. The ranges and the pain will follow strengthening. It shouldn't be the other way around, because that's counterintuitive as such. We are big proponents of early versus late rehab. I don't use a sling. All my post-op patients are free of their sling. I think the sling is my biggest enemy because it forces them into internal rotation. Is there evidence based on this? There is evidence published in favor of fast rehab and in favor of slow rehab, both ways. So to each his own. I'm not disparaging the slow rehab therapists, but why disenfranchise 97% of patients just to save that 3% re-tear patients? So even our cuff repair patients and replacement patients will not wear the sling, except when they're traveling or except at night. So finally, with the COVID disruption, we've moved to the online PSRP for several of our patients because post-op, we cannot neglect them, and it has gone very well. And so I think we are charting the next chapter. Final slide. It is important for the therapist and the surgeon to be one-to-one. They have to have a sync, and we are very good on that because we talk it out, and our therapists understand orthopedics much better, and we try to understand their physio concepts equally well so that we can collectively give them a good rehab. In conclusion, I think I've shared the frozen shoulder biomechanics. I've quickly shared some of our basic tenets of PSRP. Please understand the victims and culprits, and that's why we don't give steroid injections for tennis elbow and decurvents as far as possible. I don't remember the last time I've done that. And we are great advocates of early rehab for our patients. Here in the picture, you see one therapist and one surgeon leaning against each other, supporting each other. I leave it to your judgment, which one is the therapist, which one is the surgeon as such. Thank you very much for your patience and attention. Thank you, really appreciate this.
Thank you so much, Ashish, for a wonderful, wonderful talk. It was really, really fascinating. I mean, being a foot and ankle surgeon, I was so pleased you mentioned tibialis posterior and Achilles tendon there. But I'm so pleased that I'm joined by the two eminent shoulder surgeons from England. We got Professor Harvinder Pal Singh from Leicester and Professor Amit Tolat. He's from Medway in Kent. And both of them are upper limb shoulder surgeons. So they are the one who are going to ask you all the questions which are from them and the panel. And if you be kind enough to answer some, we'll be very grateful. Thank you.
Hi,
Hi, Ashish. How are you? How can we forget Argentina, huh?
No, I can't. Buenos Aires. Did you see the logo?
Yes. So, Ashish, as you probably know already, in UK, our problem is that patients come convinced they require an operation. And to unconvince them that they need rehab, it takes an effort. Maybe you have some tips and tricks we could use here to, unconvince them that physio can give them the desired result.
I was worried about this facing two shoulder surgeons at the same time. And our problems are completely converse. Our tear patients are just reluctant for surgeries. They want everything done with rehab as such. So I really don't know. But sometimes there's a dilemma. I had a slap tear patient today who didn't have a slap tear. And one MRI reported a slap tear. I said clinically it is not. And he was under a lot of stress. A young boy of 25, no injury. And I said, see, your previous surgeon wants you to do a slap repair. I am suggesting let's do a rehab trial. Suppose we do a rehab trial and in 2 weeks' time, I can give you a 50% progression. Your job's done, you skip surgery. And suppose I'm wrong, and it is possible I am. We've not done any harm. So there's a win-win situation here in doing your rehab. And again, there's good evidence that patients who do rehab and come back for surgery later will do far better post-operatively than patients who don't come in for rehab. So there's a good chance they go on rehab and they miss surgery, and then you're restoring back to normal.
Good. Thank you.
Thank you.
So I think the next question we'll ask Amit.
Yeah, hi. Hi, Ashish.
Hi,
So
Amit.
wonderful.
Good to see you.
Hi. So wonderful to see you, and as usual, a wonderful presentation. And congratulations on your work on the PSRP. So like shoulder surgeons, I mean, we face challenges, as Harvinder mentioned. What I wanted to ask you is basically two parts. One is, what do you think is the impact of diabetes on this condition and its effect on the outcomes? Because we do see a lot of diabetic patients in the UK as well with frozen shoulders,
Yes.
and we have this constant problem of the monitoring and the control of this impacting upon their outcomes, whether it be the initial rehab or the subsequent surgery. And the second one is, how do you keep your patients motivated to continue with the rehab after surgery? Would you think that the pre-op rehab is really a good way of making them enthusiastic about continuing with this, because there's a reward-based system in place, in the sense that they do well, they see that, and then they get on and do it better, because remote physiotherapy has become a norm nowadays for many of us here in the pandemic.
Yes.
Sorry to ask you two, but thank you if you can answer them.
Well, there's a third question hidden in there. I will try my best, Amit. So we do get, if you look at literature evidence, there's nothing in favor of diabetes or against diabetes, but we know as a whole that group is a difficult group to treat. But I'm more scared of the hypothyroid patients. Now, if you look at the two sets of these patients, why are they the ones that are the most difficult? Why do they have so much grief after shoulder problems? Number one, I think, is the suprascapular nerve, and that has been neglected. And it's a very difficult nerve to pick up clinically on. Because it's a pure motor nerve, there are no sensory components. I think there's a great disservice from our side that we missed up. Because when the suprascapular nerve goes off, they are going to present as a weak rotator cuff, and we're going to treat it as a tendinosis or a rotator cuff tear. Diabetes neuropathy is known, hypothyroid neuropathy is known. So that's how we work on these patients. I have several diabetics who are not so bad and they do reasonably well. And there are others who are a great challenge that you would want to send them off to your enemy. So the whole thing is that you have to ensure that diabetes is reasonably controlled. They will take a longer time to get rehabilitated. Our therapists will put much more effort in getting their supra-infra recruited in terms of stimulating those patients. So I mentioned some adjuncts on PSRP. So we do stimulate the nerve with the galvanic stimulation, just the infraspinators, and that helps to kick them in. And once they improve, then they sail through. But to get that muscle to improve is very important. Motivation, again, if they get pain relief with the exercises, then they do good. So we try not to give them pain just because once they get an easy option to get rid of their pain, they're going to resort to that. And because we measure their strength quantitatively every time, they are disappointed when they find that the strength has gone down. So some of them are called back again once a month just to supervise and ensure that they're recruiting, because there's a huge amount of compensation in the shoulder when doing the conventional rehab. I hope that covers what you asked.
Thank you. I think they're always a challenge, and we have to continuously monitor them here to make sure that it's all going in the right direction. There is a question.
So I think, thank you so much. I think we got a couple of more questions, Ashish, but what I'm going to do is that we got time for the discussion towards after the end of the session, and I'll touch upon on those. But looking at your program, you know, a lot of people from the UK are traveling to India to the Yogagram or naturopathy. It won't be long before they'll be all coming for the shoulder retreat to Pune. Thank you, wonderful.
Oh my God.
Thank you very much indeed for the wonderful session.
Thank you.
Thank you. So now we still got two fascinating talks, and I'm going to hand over to my co-moderator, Mr. Mukesh Himadi, who is a consultant orthopedic and arthroplasty surgeon in a renowned center of Wrightington. So over to you, Mukesh.
One.
Thank you. Hi, I'm Mukesh Amari. I'm a lower limb arthroplasty surgeon at Wrightington Hospital in Lancashire in the United Kingdom. And I'm moderating this session, which is a couple of exciting talks. The first one is by Clare Robertson, and she's going to talk to us about the current concepts in patellofemoral pain rehab. Well, Clare is a consultant physiotherapist, and she has a keen interest in the patellofemoral joint, both from the clinical and research perspective. And all the clinicians, we know that it's quite a difficult area to deal with, and I'm sure Clare has some tips and tricks to help us deal with the problem. Over to you, Clare. Thank you.
Okay, so today I am talking about my favourite topic, patellofemoral pain, and I'm doing a little bit of an update really from the physiotherapy perspective. So I'm a consultant physiotherapist working exclusively in patellofemoral pain and have done for the last 15 years. I'm a researcher in the field as well, and I'm bringing some of my own research to this talk as well. So it's a bit of a whistle-stop tour of emerging literature. So I'm looking really at clinical applicability here. It's always my passion. How does this influence practice? So therefore, I've chosen the following topics to talk about. I'm actually looking at some of the emerging qualitative literature, including some of my own work on crepitus, some very interesting work around kinesiophobia, a bit of an update on adolescent PFP, and then also what's the latest on the medial lateral dynamic control of the patella. So hopefully we'll all still be standing at the end of that. So first of all, actually, ironically, I'm looking at a model that wasn't even written for patellofemoral pain. This model, the pain and movement reasoning model, is, I just think, a really nice way to frame patellofemoral pain. So if we look at this triangle, in the bottom right-hand side, we've got local stimulation. So in this case, this could be subchondral defect, it could be bone marrow edema, it could be ischemic change in the parapatellar soft tissues, fat pad edema, anything essentially that is around the patellofemoral joint. And then on the bottom left, as you can see, we have regional influences. So that could be anything from an excessively pronating foot, an anteverted femoral neck. What is happening regionally that may affect the kinematic at the patellofemoral joints? And then the under-researched but emerging area at the top of the triangle, the CNS modulation. So everything from beliefs through to central sensitization. And because a lot of these patients have had the symptoms for a long time, they are certainly at high risk of having influences from the top of the triangle. And what this model says is think about the triangle and think about what's the relative contributing factors. So yes, if someone's fallen over last week, landed on their knee, it's bruised, but they're not catastrophizing about it, they might have your cross in the triangle might well be the bottom right. But actually, in reality, there's very few like that. There's a lot of people who have patellofemoral pain, who have a lot of global limb issues. So we might actually not really have much going on around the knee structurally. We might actually have more on the bottom left. And if we've got a lot of anxiety around it, or altered beliefs, as we're going to explore in the talk, we might actually move our cross further up the triangle. So it gives us a way of remembering all these contributing factors. And in line with this, in the top of the triangle, Ben Smith's paper that came out a couple of years ago is, believe it or not, the first ever qualitative paper. And I know that qualitative research sometimes gets a bad press, but it really helps us gain a rich insight into this patient group. And I think really helps us understand how we should be communicating with these patients. So this paper was excellent, and it reminds us of the potential for the mismatch between what the clinician thinks and the patient perspective. So let's explore this a little bit, this particular paper. So it's emerging thematic analysis. So the first theme was impact on self, and really just reminds us that we might think, oh, it's a bit of mechanical pressure related pain at the knee, but actually these patients were saying that the presence of this pain for prolonged periods was making them change their career aspirations. They'd lost hobbies, particularly when the hobbies were around active hobbies. And therefore, particularly because of that, their social interactions have been affected. So say your social life revolves around your running club and you can't run anymore, you've lost most of your social life as well. And so they really then looked at the second theme, which was the uncertainty, confusion, and sense making. So there was a definite desire amongst the patients to understand the pain. And I think as clinicians, when it's obvious to us what's going on, it's easy to forget it's not obvious to the patient. And consistently, they felt there was a structural and very much a damage paradigm. So we need to think about that, because very often there isn't, particularly adolescent or young adult patellofemoral pain. So that is a problem as well, because that tends to lead into catastrophic thought processes. And interestingly, a real frustration regarding what we'll all know is often inconclusive radiology results. So the third slide, the third theme was exercise and activity belief. And I think this is particularly interesting. The belief was that sport had caused damage and that pain experience from sport creates further damage. So there was a definite hurt equates to harm. And feeding in from theme 4, around behavioral coping strategies, was therefore a belief that if exercise is bad and harmful, the best thing is rest, analgesics, and avoiding pain, and that wearing a knee support was the best strategy. And leading on from that, furthermore, and this is actually possibly the crux, really, particularly if you're referring to physiotherapy, was to remember this very inaccurate belief, the belief that pain would continue and that physio would not help because it was based around exercise, which was perceived as harmful. So therefore, the locus of control demonstrated was poor. And I think, as a physiotherapist receiving referrals, if this hasn't been addressed early on and the patient comes along thinking, oh, this is not going to work. Exercise has hurt my knee, it's caused the pain, and I'm going to have someone telling me to get more exercise. And also, we need to be careful with our terminology. So we use terms like wear and tear, and be careful with condromalacia patelli, because it's immediately creating that reinforcement of that structural damage paradigm. My knee's falling apart, it's wearing away. And actually what I like to do is try and frame the problem as pressure, because I find that the patients don't associate this with, they don't feel anxious about this concept. So try and move it away from structural damage to pressure, and that we're going to address the asymmetrical pressure through careful exercise that won't wind their pain up, that will actually be different from the exercise that brought it on in the first place. And if I ask patients to avoid pain, I'm very clear to say, look, I'm going to give you exercises. I don't want them to be painful, because I don't want the pain to escalate here, but it's not damaging you. It's not harming you. So again, trying to break that link between hurt and harm. And as I've said, absolutely setting the expectation that physiotherapy will be exercise-based. It has to be effective in this patient population. So some really interesting messages there. So looking further at beliefs, this is my work on crepitus now. So right back in 2010, I published an editorial saying, look, I think patients get extremely hung up about their crepitus. And then I followed that up. I was fortunate enough to be awarded a research grant from the Physiotherapy Research Institute. And looking at that qualitative research, it demonstrated huge fear avoidant and catastrophic beliefs. And bear in mind, I was looking at the non-arthritic population. And here are some quotes. It means my knee is wearing away. It means I have arthritis. It's my body's way of telling me to slow down. And this work has since been taken up further by a Brazilian group, and they've looked at quantitative work around crepitus and found that there is no relationship between the presence of crepitus and self-reported function, physical activity level, worst pain in the last month, or pain climbing stairs. And Impazzinato's group actually then bravely entered into the world of osteoarthritis of the knee and found that crepitus was not associated with higher odds of having a TKR and does not affect quality of life in patients with knee OA. So what do we do? So we need to educate, and I actually ask a really very, very telling question of my patients. If they mention crepitus, I just say, what do you think it means? And if they say, well, it means my knee's wearing away, it means that I'm going to end up with a knee replacement like my mother, whatever, that is your clue to say, well, do you know what? Crepitus is normal across the population. It's the pain that's the abnormality. Let's try and separate those out. Otherwise, the fear of the crepitus can become a bigger problem than the disability from the pain. So we're going to try and de-escalate it, okay, that it doesn't correlate with severity of pathology. And actually, I'm just going to read through this quote now from De Silva's paper, because it just absolutely sums it up. When educating patients about crepitus, clinicians should clarify that the sounds they hear have no relationship with pain, function, or physical activity. Patients should be educated that they do not need to reduce their level of physical activity or stop physiotherapy because of the knee crepitus. And in fact, one of my questions was, if your knee makes its noise when you're doing your physio exercise, what would you do? Every single patient said, oh, I wouldn't do it, I would stop. So we need to know that, don't we? So we need to make sure that that belief isn't becoming inhibitory and the main problem for the patient. And in line with this, again, anxiety, there's more emerging literature around kinesiophobia, so fear of movement. And Selhorst's work shows nicely that cognitive and physical treatment is superior to physical alone. So education, so the patient understands. And recent work on young adults shows that if you get them to do a jump down test, it's actually the poor movement landing is more associated with kinesiophobia than if we do static resisted testing of their strength. And taking this one step further, actually, all the work coming through on the adolescent population shows that strength is not the issue in patellofemoral pain. Michael Rathleff, who really owns this space on adolescent patellofemoral pain, has shown there is no decrease in isometric hip and knee strength compared to age-matched subjects. So therefore, in my opinion, we're looking much more in the adolescent group around poor motor control, especially at times of growth, and insufficient motor control for what often is quite high-level demands that they're trying to do. For example, landing from jumps repetitively in high-level sports. And this paper last year that came out was incredibly interesting. So they took a psychological model, which I love the name of this, common sense model for self-regulation, which basically has 5 cognitive dimensions. One is identity in terms of what is this problem? Okay, so here it's patellofemoral pain, it's pressure. 2 is cause. Okay, so this is happening because you've started doing more jump landing, or because you've started to wear different shoes for work, or have more stairs at home, or whatever it may be. Timeline. How long is this going to last? Is it self-limiting? What's the natural cause here? Consequences. How could or should it impact on their life? And most importantly, perhaps controllability. Can the patient take control? Can they do anything to alter this? And they made basically an 8-minute video, one 8-minute video around patellofemoral pain using these key elements. And the results were absolutely extraordinary. So it's 8.5 minutes long. I watched once, and look at the following results. So immediately after they tested, and then again at 2 weeks, 47% less pain catastrophizing at 2 weeks, 54% less fear avoidance at 2 weeks, 33% less kinesiophobia, and a statistical reduction in the anterior knee pain score, and mean of 21% improvement out of VAS. Now, look, we don't have to be doing a video, I don't believe, but we could so easily take those concepts and make sure that if we're going to get some education with these patients, these are the key things to be educating around. These reduce anxiety, empower the patient, hopefully get them moving and engaging then with their treatment. Okay, and Michael Rafflish work further on activity modification shows that adolescents really have a very polarized exercise profile in patellofemoral pain. So he found that basically they were either doing less than 1 session of exercise a week or more than 5. So virtually no one doing moderate amounts of exercise. So perhaps that's of no surprise to us, but it shows the importance of activity modification as a treatment strategy. And his paper here looked at activity modification and load management over 12 weeks and had fantastic results. So this is what I have in clinic. I have a little grid, and because often the sporty kids, they might not be playing, say, at national level. They might just be keen, sporty kids that are doing a lot of stuff essentially at school with a few other bits and bobs. But because they like it and because they're good and they're in various teams, when you map it out like this, it can become quite shocking as the accumulative load. So this is a patient of mine recently. So she was doing a bit of keep fit before school. And then of course, because she was sporty and enjoyed it, there was one day where she did netball at lunchtime, and she had school athletics or hockey, netball squad. And then she was also doing a park run with her dad at the weekend. And accumulatively, it was a huge amount of exercise. And actually, when you map it out, it becomes crystal clear, actually, the extent of the volume. Okay, I want to come away from activity modification education and now look at what's the latest around quads and VMO. So what are the myths that we categorically can say are myths? Okay, the VMO can be recruited in isolation. That is not true, it's a myth. That a weak VMO is a source of PFP. There is no evidence to show that the VMO in isolation gets weak and is therefore driving patellofemoral pain. And in line with these, therefore, we cannot say that the VMO can be trained in isolation. These 3 things are all myths. So what do we know? We do know that pain and or swelling can delay VMO. And this helps us understand that classic arthroscopy patient who's had a meniscectomy, that's all fine, and now they've got patellofemoral pain. That bit of effusion can really slow down the VMO. Or the patient has a heavy fall onto the front of the knee, no patellar fracture, but they're really sore, and that pain starts disrupting that dynamic recruitment. And then my work that I've been doing over the last 10 years, alongside working collaboratively with an anatomist, we've been looking at the architecture of the VMO, basically a fiber angle, angular pronation, it's the same thing, relative to the femoral axis. And what we've shown clearly, repeatedly, is that the fiber angle will increase when you hypertrophy and decrease relative to the femoral axis when you atrophy. So in other words, it's going to swing around and become a better medializer when it's hypertrophied. And any quads exercises done to overload, in other words, light fatigue, will inherently therefore overload the VMO. We don't need to be talking about VMO exercises. We can talk about quads exercise that happen to have the most useful effect through the VMO. So the work that I'm involved in, our hypothesis now is that some people have anatomically a more favorable VMO than others. The fiber angle varies, and this is measured on ultrasound, varies a lot across the population. In our study that we published first of all in 2014 of 70 knees, it showed that the angle varied between 40 and 69 degrees. That's a big difference. We furthermore showed that the amount of the VMO attaching onto the medial border of the patella was very variable. Some people only had 1/3 of their medial border with a VMO attachment. Some people, it was right down the whole length virtually of their medial border. And that then led us to think, well, does this correlate with activity? And this was this bottom paper here that we published, Benjafield's paper, where we correlated it neatly with Tegner scoring of activity levels and showed absolutely, if you're more sedentary, you will have a smaller fiber angle and you will have a smaller insertion ratio. If you're more active, you're going to have more VMO along that medial border with a more medializing force. Furthermore, we then showed, okay, can we manipulate this? So we looked at fiber angle, and does it increase with training? Absolutely it does, like you would expect anywhere else in the body where the angular pronation has been looked at. We found there was no difference between closed chain and open chain, and we found then this is a useful tip for patients. Once they've had their gain, the minimum amount to hold that change was 2 exercises twice a week. And then one of our more recent studies, we showed that actually closed kinetic chain used in addition with a stim was better than closed kinetic chain alone. So some interesting work there showing perhaps that it's not to do with exact firing times, like so much of the 1990s and 2000 work on EMG was looking at, and really was often very inconclusive. But what we're showing is that as per the muscle physiology literature, the VMO is no different. The angular pronation will respond to exercise and will create a more effective medializer. So how can we apply this clinically to summarize this bit? Well, look for that sudden onset pain and or swelling, because they are ringers for problems with their VMO. Post-surgery patients, heavy falls, as I've said. And it can be often something like an MCL grade 1 that's very painful, but not serious. That pain can really disrupt that dynamic control and start leading to a decrease in their fiber architecture. And then sometimes we've got those patients who have an asymptomatic meniscal tear, but actually it's leading to a smaller fusion, and the fusion sets off the patellofemoral pain. That's quite an interesting and challenging group. Do we address the meniscus when it's not painful? How do we manage that? And of course, the degenerate knee causing an effusion, that's then going to be feeding in to that poor recruitment of the VMO, and over time, then the architecture changes. So these ones are the ones that we really should be looking to target with strength, not the gym goers who are already actually very strong, and yet perhaps are sent off for quads, squats and lunges. How is that going to help in someone that's already got a huge VMO with a big fiber angle? And this is where our clinical reasoning is so important. But then we have the patient group, we've all been there, where they say, well, physio just makes me sore. And of course, tying that back in with what we've talked about already, you know, that feeds beautifully into that belief exercise is the problem. So how can we get around it? Well, we can if we're clever. So we can look at what do we want most? We want maximum quads load, minimum joint load. We don't want loads of pain. It's just going to feed that cycle of inhibition and lose the patient confidence. So if they're very shut down, say after patellar dislocation or something, we might just start with little and often firing. Let's just get some activity going. But once we've got that activity going, we want to make sure the exercises are hard enough to take the patient to quads fatigue and every other day. None of this faffing around, 3 lots a day of a bit of something. That isn't going to change the quads architecture. We have to take them to fatigue so they feel tired in the muscle. Then when it recovers over 48 hours, it recovers a bit stronger, and that fiber diameter will get bigger and ultimately affect the angle of pronation. So my guidance to patients is no more than a 3 out of 10 pain during the exercise. Any discomfort should settle up within an hour, and absolutely don't want to be seeing an increase of pain the next day. They're my guidelines for patients with respect to pain and what is acceptable. And we can think about the type of exercises, and Steinkamp's work is very useful for this. So if we look at this, particularly the red line on the graph, closed chain, so this might be take a mini squat. If we look at the knee angle, actually up to 50 degrees, the pressure, the contact stress and the pressure isn't too bad, but then it starts escalating. So why would we do a deep squat repeatedly to send them down to 90 degrees and really high contact pressures? What I might do is take that squat and keep them shallow at 45 degrees and load them with some weights, some dumbbells, a barbell, and then I might even hold it isometrically at 45 degrees. So keep them shallow, load them up. So high risk exercises for pain provocation is deep squats, deep lunges, high step ups. And we know that open chain, which is the dotted line here, is the other way around. So what we know is that around 45 degrees to 0, that on the leg extension machine, so straightening out, is a problem area. Okay, so don't send them off to the gym doing lots of repeated leg extensions, straightening their knees out. So good exercises, standing at 20 to 30 degrees, with a knee flexion, perhaps tapping the other foot around, so get some nice co-contraction around the knee, very low risk for pain. And we might ask them to do that, say 3 lots of a minute, no equipment needed, anyone can do it anywhere, and it's actually surprisingly hard. And we would want them to do that alternate days to light fatigue. A wall squat, so here, look, the knee is not that flexed, it's 45 degrees. Long holds again, so we're not up and down, potentially causing malalignment issues. I like putting the band around like this. It encourages them to work their glutes at the same time. So we get that synergy between quads and glutes, which is really desirable. And I would progress it by duration, not going deeper until way down and to the end of their rehab. And then we mustn't forget about the lateral side. So just to remind ourselves about the anatomy, the ITB is hugely thick. We can't stretch it, as you can see here. It's very, very thick. But we can stretch its contractile origins. It's TFL, it's gluteus maximus. And we must also remember, it doesn't just lateralize the patella when the complex is tight. It can rotate the tibia externally, which of course increases lateral patellofemoral load. And it would do that in knee flexion. So we don't want that tightness coming through from the proximal contractile structures. And rather than Ober's test, what I've just finished a study which we've just had accepted for publication using ultrasound. We get the patient to lie supine and then take their leg into adduction. And we look at the effects on patella tilt. We could measure the difference on ultrasound. And you can also look at the pain response with this as well. Very useful to see if their pain comes on, then we can say, okay, there's something about hip adduction and length that's causing feeding into this. And of course, also if they have contralateral pelvic drop, that will tension the ITB too as well. So it might be that the ITB complex isn't tight, but the drop is tensioning things up. And if they are they aware? Can they correct? So what are my take-home messages about medial lateral control? VMO, look for sudden onset of pain and swelling or for very sedentary lifestyle. Don't think about VMO exercises. Do think about knee angle for quads exercise. Do try and avoid winding the pain up. And for ITB, think about tilt, lateralization, and stretching proximally. And of course, it may be the pelvic drop that's the problem, tensioning up that ITB. So to conclude, I've tried to give you a bit of a whistle-stop tour of my PFP bubble, as I call it, my little world. Lots of exciting and really interesting emerging literature, some non-biomechanical literature to really add to the richness of what we're thinking and doing. And of course, as always, it throws up more questions than it answers. So thank you for listening. I have a website, Clare Patella, has lots of resources for both patients and clinicians. Thanks very much for listening.
Thank you so much, Clare, for that wonderful, wonderful talk. And now I'm joined by Mr. Rahul Kotwal, who's specializing in the knee. He's a consultant orthopedic surgeon in Bridgend. And he has got some questions. So over to you, Rahul.
Thank you, Yogesh. Absolutely fascinating talk, Clare. I have one question for you from the studio. Before I ask you this question, I would like to personally thank you for giving us these superb tips and tricks for managing anterior knee pain. They've helped me and they've also helped my patients, so thank you so much. So one question from the studio, it's about crepitus in patellofemoral pathology. As you said in your talk, that there is no relationship between crepitus with pain and function. In my practice, I often see that patients with minimal radiological arthritic changes, in fact, have a lot more crepitus than patients with severe arthritis of the patellofemoral joint. Is that what you observe as well? And what do you think is the reason for that?
Yes, we can actually look to the engineering world to help answer this. So there's a phenomenon called slipstick, which is when it's basically the noise that arises when fluid moves through a slightly irregular surface. So if we have someone with thick chondral surfaces, so the cartilage is all there, but perhaps superficial fibrillation, then often they'll get that sort of fine grating noise that you often hear on the stairs. And that's why we see it in the adolescents who really have a structurally sound knee. But it's, in my experience, it's that fine grating noise that often creates the most alarm amongst our patients. So I use the analogy with my patients. Imagine if we had a thick pile carpet, and I say, and that thick carpet's like your thick cartilage that's there. If I spill water on it and swish it around, I'll get a fine sort of grating noise, and that's akin to what is going on at the knee.
Thank you so much, Claire.
Pleasure.
Thank you so much indeed. So I hand over to my colleague, Mr. Mukesh Himari, for introducing the next fascinating talk. Over to you, Mukesh.
I can see myself. Can you see me now?
I can confirm we see you.
Yeah. Okay? Can I proceed, please?
Please proceed.
Yeah. Hi. The next speaker is Dr. Clare Minshall, and she's a rehabilitation and conditioning consultant with a wide experience of dealing with international athletes and patients alike. She maintains a keen research and academic interest and has a PhD in exercise science and rehabilitation. So she's going to talk on the formula for return to sports and work. Over to you, Claire. Thank you very much.
Hey there. Thank you so much. First of all, hopefully people can hear me. Is that a confirmation? Would be good.
Yep, we can hear you.
Perfect. Awesome. So thank you so much for this opportunity to present to such an esteemed faculty and audience. And following on from a fantastic Claire, I'll aim to do the name proud. So I've been asked to speak on a formula for return to sport stroke work. So I've been thinking about this for quite some time. I put my head to it, and I came up with the following thing. So if you've got a pen and paper, you can write this down. This will ensure a successful return to work and sport. Clearly, I'm joking. I've got no idea what that represents actually, but it does look fairly complex, and that's the intention really to convey. It's really a difficult, certainly in 30 minutes anyway, to get somewhere close to a formulaic approach for a successful return to sport or return to work stroke activities of daily living. And each setting is going to be different, each patient's going to be different, and each goal and indeed the tests selected are different. Now, we obviously have some formulae or approaches within different injuries and rehabilitation programs. So for example, the ACL is very well researched. We've got a decision-based model here by Creighton, published in 2010, that takes together different types of factors that need to be included in that decision-making process, and then the sub-factors within that. We've also got the brilliant Ardern et al. Paper from 2016, another Clare monopoly. Maybe there's something in the name, I don't know. But again, that presents similar things in terms of that decision-making process for return to sport in an ACL population or ACL reconstructed population. But to try and convey that to a broad spectrum of patients with different MSK surgeries, injuries, considerations is probably a futile exercise, actually. And in discussing and thinking about this formula and for return to play or return to work, I think there's kind of two elements here. One is that decision-making process on if it's appropriate, safe to enable them to go back to work or to play. Or indeed, are we thinking about the optimal preparation to enable that return to work or return to play, return to sport? And indeed, that it does inform the latter. So I think to try and get the most out of this 30 minutes, I think probably to focus on this optimal preparation with the consideration of that decision-making for return to play would probably be a more fruitful 30 minutes than discussing the different paradigms and different models for different conditions, because we won't really get too much detail. So let's just get some context in the talk and what we're thinking about. So we're thinking here, obviously, about rehabilitation, and a fantastic presentation before on Clare and looking at the patellofemoral joint and those specific considerations. But broadly speaking, the aim of a rehabilitation program is to enable that patient or that athlete to return to activities of daily living or to sport safely, effectively, and ideally as quickly as possible. Now, we'd all love to kind of be in this situation where everything's in place. It's idyllic, we can sit back and relax because we've got all the resources we need. We've got the personnel, the patient does what you want them to do. You've got the finances and all the equipment. But in reality, it's going to be a version of that, and some less fortunate than others. So the reality is that we still have this remit of the individual to return to function, performance, or play as soon as possible. But oftentimes, particularly in busy, let's take NHS practice, you might only have a single session per week, if you're lucky, with that individual, yet the goals remain the same. So we have competition for limited resources and time and expertise. You've got different patient profiles with different goals and different starting levels of conditioning. So often that task can be quite a really difficult one to juggle and to manage properly. But that's not to say there aren't a few key things that we can follow and strategies to follow to enable that success to be, or more chance of success. So increasing the chances of success and making a more manageable situation for this preparation for return to sport and to work is, it kind of starts really with the determination of what that rehabilitation program is aiming to do, commensurate with the aims of the patient. So they're, such an important part within this model. We can't forget them. They're integral to it. And then we can start to plan to optimize the efficacy of those rehabilitation interventions. So in terms of a formula or a model, I think the one that we could look at today would be a fairly simplistic approach, one that we acknowledge first and foremost the goals of the plan, of the individual, and where we're headed. Then I think a framework of conditioning efficacy would help formulate thoughts around that determination of or enhancing efficacy of intervention, and a system really to go through to use within your rehabilitation practice would be the focus of today. And then also thinking about the tests and the validity. So just to kind of focus on goals for a minute, as I said, yes, it's a goal of the rehab plan, but it's also the goal of the patient and the goals of the patient, and they're central to this, absolutely central. And indeed, think as well that those, depending on how long you have with the individual and how long that plan is, that end point might change. So we're determining an endpoint, but that could be variable. And just to note here, there's the whole psychology of that individual as well, which makes up another course. In fact, we run a course on the psychology of buy-in, but that's for another talk. So we're acknowledging that the goals are super important, probably the starting point for determination, every point thereafter. And that can be, as I said, variable, dependent on the patient profile. It could be, improvement of pain or perception of pain, or learning to live with a level of pain, return to play or high level competition. It could be just to walk the dog. And once we've got that in place, then we can start to think about design of a rehabilitation plan to enable a successful return to whatever those kind of endpoints are. So we're going to talk a little bit about conditioning efficacy and what that represents. Here you can probably get an idea of the concept from the imagery on the right-hand side here. Efficacy is the ability to produce a desired or intended result. So therefore, conditioning efficacy is the ability to achieve the performance or indeed the rehabilitation outcomes through that conditioning prescribed. And a lot of what I'm talking about in this section here is published in a recent book chapter of the Elsevier's new sports medicine textbook. Although it's sports medicine and sport performance, the principles are absolutely relevant to every patient population. So within this conditioning efficacy paradigm, we've got three key things. Everybody loves a Venn diagram, don't they? Oh, maybe not everybody, but I do. So we have planning and design as one part of that. We've got the basic principles, and then we've got the performance demands and injury risks. And that conditioning efficacy, the ability to almost hit the nail on the head with what you're trying to do with your rehabilitation program, kind of represents that sweet spot in the middle. So what we're going to do is just look briefly at each one of these premises here, flesh it out a little bit such that it can be applied to rehabilitation programming, and you have a better chance of being efficacious and effective within that whatever rehab setting you're in. So planning and design, what is the focus of your rehabilitation plan and how is that progressed and adapted over time? And this is going to be commensurate with the goals, and particularly the goals of that individual. So I've taken here, in terms of the rehab priorities and things that you're thinking about within a rehabilitation program, just from a neuromuscular level, but clearly there are other parameters that you might need to incorporate within a rehabilitation program, dependent on the individual and the condition, etc. But it might be that we have, from a neuromuscular perspective, we want to improve neuromuscular performance. Well, what does that mean? We've got strength, we've got rapid force production or rate of force development. We've got even the switch on times of the musculus to consider. And then clearly all of that has to happen within a controlled, regulated way. So that's the sensory motor performance or proprioception. And to say here, and I'm sure everybody's absolutely aware of it, but just that we don't have that magic one exercise or one approach that's not changed that enables an optimal improvement in all outcomes. And that would include other outcomes that you're thinking about as well, regardless of whether that's a sporting population or a non-sporting population or an older adult population. And I highlight this because, this is something that I see a lot. I think we're getting better at I suppose critiquing this in the therapy and rehab world, but I still see a lot of it. This is your typical 3 sets of 10, let's say for the knee extensor group, and it gets given out on an exercise sheet, and maybe you're doing it 3 times a day or 3 times a week, to whatever. But you've got this 3 sets of 10, and you might get given an exercise or resistance band, and that exercise sheet gets given to everybody who needs that exercise, because the focus of that exercise is what? Well, typically people say it's for strength, but it's not a strengthening exercise. clearly you will get, in really deconditioned populations or those novel to exercise, you will get some adaptation on some things, but that will quickly plateau. And if you remember the characteristics of those individuals, they're very different from one another. So it might be representative of a stimulus in one type with one individual and maybe not even doing anything for benefit in highly conditioned individuals, but yet still we don't acknowledge that within the programming, nor is there any determination of progress or indeed overload. So I'm saying that that it's important to think about the planning and design such that you've got every chance of success to achieve the outcomes that you want. So we've got a clear vision of these rehabilitation goals. If we want to improve muscle strength, then we need to be specific about the programming of that. And one thing to take away with any intervention that you're designing would be this principles of training. You get these things right, you're going to be successful. So you've got specificity, overload, and progression, and you can apply this to all manner of exercise interventions, or indeed, I suppose, interventions on daily life. Specificity refers to the specific training intervention will improve specific outcomes. If you want to improve muscle strength, or you want to improve balance, you need to have that specific goal. Once you've got that specific goal and that marker, then you have to have the right overload. The overload represents in this case, neuromuscular challenge. So you have to set a training regime of greater intensity than the individual is accustomed to make sure that adaptation occurs. And Claire touched on it in her talk earlier about, you need to really work the musculature to fatigue to promote that adaptation. If you don't have the overload, there will be no adaptation. And then you get those two things right, your patient will progress. So that's great, but we need to program that within the rehabilitation program. So constantly assessing and improving the prescription by increasing the overload. And that can apply to any manner of exercise that you're prescribing. So that's the planning and design. What is it that you want to achieve? And structurally, how are you going to set up your program, your exercise to achieve that? Then we come to basic principles. Do we understand what muscle strength is, for example? I'm just using this as the exemplar here, but it applies to all other outcomes. What is it that we're dealing with? Muscle strength is, or maximal muscle strength to be perfectly accurate, is the ability of a muscle or muscle group to develop a maximal contractile force against a resistance in a single contraction. So when we're measuring muscle strength within research settings or indeed within clinic settings, if you've got the dynamometry to do so, it's often judged as the peak torque or the newtons produced from a single maximal contraction or averaged over a few single maximal contractions. Now that we understand muscle strength, we understand how intense basically the muscular contraction is. Does it make sense to provide 3 sets of 10 of a resistance band that presents really no stimulus for strength? Or it's very, very easy to do and they can do more. Why do they stop at 10? So this is something you can take away and apply to your resistance training in rehabilitation programs. This is a repetitions maximum continuum adapted from 2 sources, developed way back in the 1980s, but the premise still holds today. You've probably seen this before, I imagine, if you're in rehabilitation settings. If you haven't, basically on the top here, the numeric indicator is the number of repetitions of an exercise you can do until you can't do any more. The size of text indicates the size of response. And here, if we want to improve muscle strength, you see that represents really 3 to 5 repetitions maximum. That means lifting a resistance up to 5 times, but you can't lift it 6 because it's just too heavy. So that challenges a lot of thoughts and you think, oh my goodness, I can't do that with patient populations because they're in pain and they've got joint restrictions or whatever it is. But just to know, if you're at that 3 sets of 10 to 12, it's not really doing anything optimally. And in actual fact, more recent research is showing that 12 repetitions maximum is more of a muscular endurance type exercise and activity. So we need to be more specific and have specificity and create the right overload. And incidentally, there are a multitude of ways you can adapt exercise to enable that overload to occur. So you can change range of motion if they're symptomatic at some points. You can change the mode of muscle activation. It doesn't have to be concentric, eccentric. You can do isometric or purely eccentric. You can change the speed of muscle activation. You can train the opposite limb for cross-education. Again, quite a lot of information within there, but just to illustrate, just because that individual is a patient and they may have symptoms doesn't necessarily mean you need to ditch that prescription. And then finally, looking at performance demands and injury risks. This is completely related to, again, the goals of that individual. Do you understand the demands of the sport if you're dealing with an athlete, or the activity if it's a non-athlete? From a both performance and functional need, what are they going back to, and what do they need to be resilient to be able to cope with to mitigate future injury? So it's requiring, if you have an individual that has an osteoarthritic knee, and actually you're going to do some rehab with them or conditioning with them or prehab, whatever the best word is, to try and just maybe offset maybe a total knee replacement or get them into a better condition to go into a total knee replacement. So preoperative status determines postoperative outcomes, get them stronger, maybe reduce their pain a little bit. They want to be able to walk the dog perhaps on unstable ground for more than the 5 minutes that they can currently. What is it that they need to have in place? They need to be strong and have the dynamic joint support. They also probably need to be able to cope with unstable ground. So you're thinking about perturbation, training, etc. And the same principle applies to that elite athlete, except slightly different demands and risks. Such then, you've got that knowledge, you can design the exercises appropriately to promote the deployment of the newly formed muscular capacities in that unpredictable environment. So one, understand the environment that they're going back to, the demands and the risks. Two, you're designing the exercises to enable that. And then three, you kind of put them in those situations that's controlled, but still represents a challenge, and maybe a slightly less expected challenge than in a standard situation. Then you establish, when you're thinking about what you need to do with them and what you'd like them to commit to doing, you need to establish this hierarchy of importance of which factors are most important at what stage throughout the rehabilitation program. You try and do all things all at once, you'll do a lot of things very poorly. Our body pools resources, it's only got so many, so you might find that the adaptation is curtailed across a multitude of parameters. You might overload not just the neuromuscular system but the patient. You give them reams and reams of exercises, they're probably not going to do any. So thinking about what we need to do and when, and then we can design the program to achieve this. And incidentally, this sounds like a lot of work, but in the longer run, and even in the medium term, it saves time because you're not managing patients on the fly. You've got a planned approach. You know what's going to be happening throughout that period of rehabilitation. Yes, there might be changes from day to day, but you've got an end point that you're working towards, a basic structure that you're following, rather than kind of you're dealing with the situation on the day. And in terms of what's usually done, and I'm taking a resistance-based model here because we're talking about strength, typically what's prescribed is generally we focus on endurance. So we've got a pyramid here, what forms a foundation and the majority of intervention, and then it kind of tears up. And oftentimes we're focusing on muscular endurance. Then we notice that the musculature is slightly smaller and we've lost muscle cross-sectional area, so we probably need to focus on that. And then we've got strength and then maybe power if needed. And I don't think that's the most useful way to look at things. And particularly as well, when we're thinking about, when we're getting into the most important part of that triangle, which I think is certainly from the strength perspective anyway, is that, as I mentioned before, if we're loading heavily these patients, we want to, and they go, oh, that's sore when my knee flexes to 90 degrees, then typically what happens is people want to reduce the load to make it less symptomatic. But by reducing the load, we've lost the specificity. You said you wanted to improve muscle strength. So now that patient's doing 14 repetitions, fairly symptom-free, but they're not working muscle strength. So you've lost the purpose of the exercise unless you adapt exercise. So what I think is a more useful way to look at programming, and this is a whole talk in itself, is that I think strength forms the foundation upon which a multitude of other abilities are built and enhanced. So we should look at muscle strength first and foremost, and even more so in those older populations where we might be thinking people are frail and that we need to look after them, and you know, they're sarcopenic, and often they are losing strength because they're disengaging from exercise more. It should be something that we focus on first and foremost, particularly when we see the evidence that relates to not just increased knee pain associated with muscle weakness, risk of falls. We're even talking about all-cause morbidity, so all-cause mortality as well as morbidity. So we look at muscle strength first, then we can make that program individualized. And we've got all manner of prescriptions that are valid. So it could be that they do strength, then power, then hypertrophy, and go back to strength, and you know, you can see where I'm going with this. Or indeed, you might just do a little bit of that. But again, having that plan in place and periodizing it enables you to be successful at more things. And in the chapter, I present this system here, the hierarchy of importance, that helps consolidate and align your thoughts. You've got loads of things to think about, particularly in, you know, post-operative, and you've got loads of different parameters to think about. And these are just some of them. So once we've got, you know, the pain under control and we're happy with range of motion and function, that acute phase is past, then think about the things that we're left with and where we're headed with the rehabilitation program to determine, you know, ultimately that return to function or to sport. We might have muscle strength, we've got maybe some power, rate of force development, and then we've got sensory motor performance or proprioception, and that might be related to performance as well. The greater the size of arrow here, the greater the focus in that rehabilitation program. So we've got the early phase here, coming through to the late phase or end stage. And this is a model that can be applied to any rehab program. It's, you know, just the length that will be different. So first and foremost, we're thinking here that, you know, that sensory motor ability, the ability to walk maybe on unstable ground, to respond to perturbations is important. So balance and sensory motor performance is important. But from a functional perspective, going back to being able to, from a sports perspective, decelerate, twist, change direction, and head a ball while slipping, for example, that's not so important right now. And we focus on deploying those capacities in the late stage. But what is important as well in that early stage is muscle strength. So what you'll see is we've got a high focus on muscle strength and a high focus on sensory motor performance, low focus here on rate of force development or muscle power. And as we go through the progress, if you like, of that rehabilitation plan, the focus changes. Now, the exact focus for your individual can vary dependent on what their goals are. And maybe you don't even do very much of the performance-based tasks. You just want that individual to be able to respond to a perturbation, i.e. Avoid a fall if they stand up out of the chair and trip over the carpet. Still, you will have some perturbation training that represents that challenge, but it's not going to be the same as you know, an elite tennis player, for example. So we've covered quite a few things there. So if we go back to that original approach and model that we're trying to cover in today's presentation, we start this process. Well, what is the formula to enable an individual to return successfully to sport and to work or to activities of daily living? We have the goals. It starts off with the person in front of you, who they are, what the baseline conditioning is, and indeed maybe their propensity to exercise, factor all that in, but what's the goals of the rehabilitation program aligned with the goals of the patient? What's the end point at this moment for that? And then we've spoken about conditioning efficacy, how you can seek to develop your program such that it's got a greater chance of success meeting those goals. So you've got progression within there, you've got specificity within there, you're programming with a view to progression and managing multiple rehabilitation outcomes. And indeed, as well, you've got the overload right for each one of those parameters. Then it comes down to the tests. And as I said, we've only got maybe a couple of minutes left, so it'd be futile to try and unpack this completely, but just be mindful of the tests that you're using to judge that return. Are they valid and valid in the situation that you want them to be valid within? Are they sensitive to change, and what level of change? Are they reliable such that, on repeated tests, they're giving the same, under the same circumstances, the same data? And some of these things might represent limb symmetry indices, functional tests, capacity tests, and self-perceived inventories and questionnaires. So you might have a multitude of those things that make up that battery of tests that help guide your decision to return to whatever it is. So just to sum up there is no single formula to judge return to work or to play. That determination of needs and goals should be on an individual basis and factoring in the patient such that you can develop that plan. And having a systematic and specific approach will greatly, greatly optimize your efficacy and chance of being successful with that rehab and conditioning such that they can return to play or return to work. And the determination of order of importance, and this we're using periodization from the exercise science literature here, but it absolutely has relevance within rehab. It will depend on that individual's needs and goals. So what's the starting point of their physical conditioning, and where do they want to get to? And using this concept of conditioning efficacy can help guide effective rehabilitation design and enabling that successful or better chance of success of return to work and play. And just to make sure, there's another discussion on what tests to use. If you're going to be using testing to help judge that or help your decision-making in that process of returning to work and to play, make sure you understand the parameters of that test, the validity, sensitivity, reliability, and don't just rely on one single outcome. Take a more wider view. So thank you so much. That's the end of my presentation, hopefully on time. And happy to take any questions.
Thank you very much for the fascinating talks. I was moderating the one by the Clares, the patellofemoral joint and return to sports. And I hope you're happy to take questions, Clare Robertson and Minshall. Yeah.
Yes.
Right. So I don't see any questions from the delegates. I have a couple of questions, if you don't mind. I'm a clinician. My first question is to Clare Robertson. Clare, how do you deal with a 30-year-old gym goer with strong VMO, with patellofemoral pain, and he wants to continue doing fell running in the lakes? He is a marathon specialist. So do you have any tips for the clinicians to deal with such high expectations?
It's a really good question. And often people say, would you allow your patients to run or not? And that's far too black and white a way of approaching it. So there are lots of parameters within running we can look at. For example, downhill running, we know is particularly harsh on the patellofemoral joint. So temporarily, can we modify their routes so that they're not doing steep downhills? We know, for example, that if you run faster, if you're doing some sprint training, you get more hip adduction, which is more likely to create a dynamic valgus loading at the joint. So can we actually look at their training schedule, their running, and modify so that they don't get frustrated and then just go and blow it and do too much and make themselves really sore again? And then discussions around, okay, so we might actually be reducing your running load, but hey, let's get you running on the cross trainer instead. So perhaps building something else up. And then the absolute golden nugget is saying, look, if we can use this time wisely around strength and conditioning, your overall performance will hopefully improve at the end of it. That is the silver lining of this injury, is that you'll end up being better times and decreased your injury risk, but not easy.
I know it's a question of managing the patient's expectations, isn't it?
Absolutely, yeah.
Thank you. My next question is to Clare Menschel. Clare, how do you deal with a coach who wants an elite athlete to take part in the finals of a World Cup match? He's a main goal scorer, and you're not sure that he's ready to return. How do you deal with that conflict? Sorry to put you on the spot.
I can just about hear you. I can hear I've got a reverb or something. Oh, I think I'm hearing a delayed echo from you. I think I got the question. Yeah. How do you tell a manager no? Is basically what you're asking. That's right. Yeah. Yeah, that's a really difficult situation to manage. It depends what, if obviously that's the elite of elite. If you're talking about World Cup potentially within football, then it's a whole process of decision making within a team, and then ultimately it comes down to the manager who's going to say yes or no, and that's a decision that's got different elements to it, not just the welfare, unfortunately, of that individual at that moment in time. So I've been in those situations, not necessarily at the World Cup, but where you become more of, you've got to have good persuasive skills and understanding. And if you can, like Claire was saying, if you can silver line the reasoning, it can help with that. So, like I was saying, one of the hardest things to do is persuade runners to do strength training. But we've got evidence that shows that it could improve your time trial performance or improve your running economy. So if there's something that would help with that decision-making process, that's the only thing I could suggest. It's not something that's very easily done at all. They're the boss, aren't they?
Yes, absolutely. I mean, I think to give an analogy of a current situation, it's the chief medical officer versus a prime minister. So, sorry. Thank you very much, Claire, and it was fascinating. Both of you talks are fascinating and were very enlightening. And I shall now hand you over to my co-moderator, Mr. Naddarwala. Thank you.
Thank you so much indeed for what a wonderful session. I mean, as orthopedic surgeons, all of us have that common goal that let's get a good result for our patients. And all four of you, what you gave us has been really, really fundamental to that goal. Sharmila, you gave us a fantastic overview of pain in general and the chronic pain. And the key as a surgeon, we've been taught that it is not important, well, it is important how to operate, but more important, whom to operate upon. And you really gave us some good tips on picking up the winners. So thank you so much indeed. Ashish, what a refreshing concept you introduced, not dealing with the local pathology, but look at the whole limb and maybe try to deal with in a slightly different way. In United Kingdom, I think we are facing so much pressure for surgeons to become really like a technician and everything has been taken care of by somebody. and you really emphasize the need for all the surgeons to know some bits of rehabilitation, maybe some fundamental principles to make a good outcome out of their surgery. So thank you so much indeed for that. Clare, what can I say? I think only thing I can say, you are a patellofemoral guru. The concepts you introduced, amazingly clear and simple, and we can all really understand that topic, which is really very difficult. So thank you so much indeed. And your brilliant concept of the common sense model probably can be applied to any rehabilitation, and we are really very grateful for that. Thank you so much. And another Clare Minsul, when I write something in the physio form for functional rehabilitation, I don't realize how much complex thought process you guys put in and so much effort you put in and take the patient through to that journey, going back to the work and sport and really highlighting then. We are really extremely grateful to you, all of you, and my co-moderator Mukesh and all the people who is contributing to the questions. So thank you so much indeed. And I'll hand over now to Amit, who is our organizing chairman, and I'm also very well welcome to Mr. Bijayendra Singh, who is our president, and he has traveled all the way to the Wales, and I emphasize is all legal. Okay, that's fine. So over to you, Amit.
Thank you. Thank you, Yogesh. I really echo your sentiments. Everybody has given excellent talks. Just a couple of points for those in India. We are running on British summer time, so that's 4.5 hours, not 5.5 hours. So sorry for if there's a mistake in that. We'll now be breaking up for lunch, and it will be arthrex and joint operations, breakout sessions. And please join us back for the first session of the afternoon by Mr. Vikram Desai, FRCS Orth. Thank you very much.
Hospital Innovations was formed in 2008 and has since grown into the largest private human tissue bank in the UK. The driving force behind the formation was really to satisfy the growing demand for UK surgeons to treat patients with allograft. Over our 12-year heritage, we have introduced a number of industry firsts to the UK, including our pioneering allograft return service, which has saved the NHS and private sector millions of pounds on previously wasted grafts. We're exceptionally proud to be at the forefront of UK allograft innovation, and with the understanding that the products and services we provide can make a real difference to a patient's life.
Good evening, everyone, and thanks for joining us for this, well, hopefully be a great session. I'm Matt Ravenscroft, as Matthias has said, from Manchester in the UK. And in this series, the cutting edge series, we're looking at rotator cuffs. But in this one, we're not just looking at straightforward rotator cuff repairs, it's rotator cuff augments, which is the next big thing. So it's my pleasure to introduce Alan Hirahara from Sacramento, who's going to go through for the next 20 minutes or so his technique for going forward with cuff augmentations. Over to you, Alan.
Thanks, Matt. Hello, everybody. So just to kind of get started, the first thing that I always kind of start with is kind of where were we? Where did we come from? So about 2000s, early 2000s, we were doing a lot more augments. And this was a technique that I was doing around circa 2012, where we would pretty much put our sutures in, drag the graft in, suture down the corners with medially fiber wire and then laterally kind of these loops with push locks, and it worked, and it did help, but it was difficult and putsy. That's what kind of brought about the BioBridge, and that's where we actually started incorporating grafts into our speed bridge constructs, using a double pulley to control the graft and hold it in. And this worked quite well nicely as well, but also people are having some trouble because they want to be able to repair their cuffs first and then make their decision to be able to then graft afterwards. So we had to come up with a new concept. And we did. So this is the canopy augmentation that we came up with. This is a concept where you're able to do a speed bridge and then using the anchors that are already present in there, using the sutures that are still present in those anchors from the eyelets, we're able to then use this new technology of canopy and bring in a graft and put it over our actual repair. This actually is being currently already submitted for publication to Arthroscopy Techniques. Hopefully within a month or two, we'll be able to have this out for everyone to see. In general, I have a kind of a broad idea of how I think of rotator cuff full thickness tear problems. And I think the most important thing out of this, and we're not going to go through this whole thing, is just this one section here. This is my section where I decide I want to use some type of a speed bridge repair with a graft augmentation. And for me, it's these larger tears, not necessarily massive, but larger. They could be massive, but they're repairable. They're something that we can actually go ahead and repair down. And after we've repaired them, we have an acceptable tension. If it's too tight, it may not work. We may have to think about other things. But the other key point here is the poor tissue quality. So if we have poor tissue that we might need to augment, try to somehow thicken, to reinforce, patch, I think that's something that we have to consider as an alternative. Obviously, if we have super awesome tissue that's really thick, robust, maybe not needed. But for the most part, that's not always present. So we have to consider all of our options. And the nice thing about this technique is it's something that you can do after it's all done. So let's kind of go through this. Let's look at a defect. So this is a large rotator cuff defect. It is repairable. It's not retracted. We can bring it over and we can go ahead and get it put down fairly easily. So you're looking at a fairly simple type of speed bridge repair. Of course, some people might say it's a bit large, might need to put in 3 medial, 3 lateral. For purposes of this discussion, we're going to go ahead and just put in 2 medial and 2 lateral, doing basically a standard speed bridge repair. However, the difference is this specific construct is using a new anchor. This new anchor includes a knotless tensionable eyelet repair suture. So you have within the eyelet a suture that could be passed over tissue and then passed back onto itself using the preloaded pull shuttle stitch. That will then allow it to link onto itself and become tensionable and knotless so that we can now go ahead and use it as a tie down. Has many possibilities, many uses. This could be used to interlink 2 different anchors. It could be used to use attaching other tissue. It could be helped to put in dog ear repairs. There's a lot of different things that could be used for. And so this just opens the door for different options for us. So if we finish our speed bridge, which is pretty much the basic technique, taking our fiber tapes, passing them through our cuff, splitting the swedged on ends, taking 1 limb of fiber tape from each anchor and taking it to two separate lateral anchors, one anterior, one posterior, creating the standard speed bridge configuration you can see in the picture to the right. Once that's done, what's interesting is that we've now left all the eyelet sutures in place. And as I said, these eyelet sutures are our knotless sutures, and you can see them here in the corners. What's nice about these eyelet sutures is that these eyelet sutures are now ready to go. The speed bridge is done. Your rotator cuff repair is done. So should you decide to go ahead and now augment or do some other procedure, you have sutures in the anchors ready to go. Nothing else extra is needed. If you don't like it and you're done and you think it's an adequate repair, simply cut them out and let it go and you're finished. So it's easy. So let's talk a bit about these knotless swivel locks. So the fiber tapes and the knotless sutures. Now, one of the things we found is that if you pass all the sutures together in mass using a simple fiber link, that does work. The problem that we run into is that sometimes those knotless eyelet sutures can get actually kind of wound up on the fiber tapes, and then it binds as we're trying to pull things through. So at this point, what we recommend is that you pass them separately. So it's one extra pass. Using a fiber link, you're able to pass your actual mass of knotless sutures, and there'll be 3 of them, pass them separately, kind of a little bit more medial to where you're going to put your fiber tapes, where you're going to put your rotator cuff repair, kind of get them out of the way, but still pass through the tissue. Then with the second pass, you'll then take that sidelower scorpion and using the swedged on fiber tapes, pass that just slightly lateral to where those knotless sutures were. This will keep them out of the way, and it'll prevent kind of crossing and getting those sutures caught in each other. Small pearl that can make all the difference and make it much easier not to have to get things caught up and pull hard and have it potentially pull out. The next step, just like with the superior capsule construction, is measurements. And it's important to measure because you want to be able to get it nice and tight, get that canopy in there correctly. So what's important is measuring the distance from one anchor to the other. And using that SCR guide that we had developed, it's very easy to do. So if you grab one of the eyelet sutures, you attach it, you zero it out at its anchor location, then migrate it to another anchor, it will give you the measurements. Now I'll give you the exact measurements of how big you want to make your graft. This way it's not too loose, it's not too tight, it's not going to rip out, it's going to be just right. So you'll be able to measure it specifically. So for example, very commonly, these are the measurements you might see. 15 millimeters medial, 15 millimeters lateral, 25 anterior, 25 posterior. That's kind of an average. Now, obviously, it might be bigger, it might be smaller based off the tear configuration you do, but it's going to be based off of where you placed your anchors, because that's where the suture is going to come through. That's how big you want to make your graft. That's going to be the key right there. Once that's done, it's then going to be very easy to measure the graft size you want. And then once it's made, you simply just cut it to the size you wanted. Once that's done, we then are going to use the divider. This divider is critical to this technique because it really helps control your suture management. So this is a divider that creates 4 separate little areas that you can pass sutures through so that they're independent, they're not going to cross. And what I do is I will then segregate it so that I can pull each of my eyelet sutures through its own specific well. And I, of course, make sure that nothing's crossed inside when I pull them. Now I can work with all those sutures in one cannula and not have to worry that they get crossed up or twisted. This is a critical part of the surgery. And whether you do this with the knotless technology or non-knotless technology, it doesn't matter. This device is going to be critical to helping make sure you have success. Now, the knotless technology, let's talk a little bit more about it, the way it works. There are 3 suture ends to deal with. There's actually 2 main sutures. There's the repair stitch, which is the main suture you're going to use to repair things or hold things. The other one is actually a shuttle suture. It's all actually one long suture. One end has a loop, and the other end has a suture tape pull. They are different. So you can see inside that they are different, and you can actually then know which one to grab very easily. So the key is taking the repair stitch first. Once you have that repair stitch, you somehow, whichever way you want, your choice, pass it through your tissue. Once it's passed through the tissue, you then load it up onto that link tail, the loop. So once it's loaded up onto the link tail, very basic, you pull on the pull tail. Once you pull on the pull tail, it will load that repair suture onto itself. That whole shuttle stitch goes away, and now you're ready. And if you pull, that's going to tension that tissue down to where you wanted it. That's how the technology works. So the next key point is exactly that. We're going to take each of the corners of those anchors, sutures, those knotless sutures. We're going to pass the repair suture into the respective corner of my graft and then pass it onto itself, and do that total of 4 times, so that you have now linked each anchor to its respective corner on the graft. Now it's easy. Simply take the divider out, using a back grasper, bring that graft into the that subacromial space, and simply pull on the sutures, and you're done. It's tied down. You simply just have to cut off the excess suture, and it's finished. And on the right, you can see the dermal allograft canopy augmentation done. On the left was the speed bridge repair prior to doing the augmentation. So it's an easy repair to do. It's not difficult, and it can be done afterwards. The key, though, is what kind of graft you're going to use, because I found that the graft does matter. For example, the arthrograft, the Arthoflex graft we use a 2 millimeter. So we use not the 3 millimeter like we use with SCR, we use the 2 millimeter. So we don't need it to be that thick. But we found the 1 millimeter was a bit thin and a bit flimsy and difficult to work with. The 201 seems to be ideal. But another key point besides it being strong is the fact that it has not much DNA residual. Now, this is a key point that many people may not think about, but it's very important to me. One of the things I found recently was one of my patients had gone to see another surgeon in my town. They had done a bridging technique using a different dermal allograft. When I went in, at first glance, it wasn't there anymore. But then I realized that if you look up, we had Matt's bar procedure, because it had adhered itself to the acromion and then ripped itself out. And so making sure that it doesn't react like that is a key component. So that's why I think knowing which allograft you use, which dermal allograft, does matter. So please check out which one you're looking at. Another thing is I have used these bovine collagen grafts as well. This is an example of implanting on one of my patients for someone that had a very thinned out cuff, and perfect application. Implant it easily. I'm thinking this is great. Implant it, have it thicken up. The problem was, unfortunately, it didn't do so well. And when I went back, it had ripped. And the key is that when I went to go suture that down, you could still see that the graft had healed down. You could see that it was there, and there it is on the left. But as I put suture through it, the problem was it was very thin, very friable. It really, sure, it was tissue, but it wasn't great tissue, and it wasn't thick tissue. And this repair did not hold super well. And this is something we'll probably have to go back and regraft with actually a dermal allograft. But that's kind of the key point for me, is that the graft does matter. What kind you use will influence how you do. Now that brings us to another concept of grafts. So grafts have been discussed as being dead tissue, and that putting them in is useless, and they're going to just dissolve and go away, and they're not going to do well. Well, that's just not true. More and more data is coming out showing that grafts can integrate, and that actually they can be used and be helpful. I published this article in 2019 on SCRs, and it's applicable here. The key points are that we saw hypertrophy of our graft at the interface with the bone. We had put in 3 millimeter grafts, and you can see that in average, it went from 4.24 in about 1 year to over 4.41 on further follow-up beyond 1 year. Now, naturally, as you start getting closer into the joint, further away from the bone interface, that hypertrophy was less apparent. But the bottom line is it can hypertrophy. Furthermore, we also showed in that same study that we had blood flow. So based off ultrasound evaluation, we saw pulsatile vessels occurring within the graft itself, meaning it was vascularizing, it was integrating. Furthermore, explant studies, courtesy of Evan Letterman, have corroborated this, showing blood vessel formation and cellularization of the graft. We've also had second look surgeries, like with Julie Bishop at Ohio State, showing us that, in fact, we can see normal perivasculature, which we saw as well on our ultrasound. So that is something that is a normal phenomenon that you see in normal cuff architecture. Now, let's talk a little bit about what it actually looks like in situ. So here's an example of one of my cases we did this past year. He was a 63-year-old male technician, and he was having a lot of problems with his shoulder, and you can see the large tear that he had here. His tissue was good, but it wasn't awesome. And so what we did was we basically went ahead and we first did the rotator cuff repair. And once we had the repair done, didn't quite like the tissue as much as I would have liked it. So I went ahead with the canopy and it went very well. At this point, here's his numbers. Preoperatively, he had a VAS score of 3, ASCS of 62, and a SANE of 60. 6 months later, VAS was 0, ASCS was 93, and the SANE was 85. Yes, this is only one patient, but this is a new technique. We have more on the way. We'll have data hopefully within the next several years. But we also know that we've been doing augmentations for years, and some of that information can be applicable here. Here's his post-op ultrasound, and what we are seeing is that you can clearly see the arthroflex quite thick, quite doing well, and over that rotator cuff insertion, and clearly that cuff insertion is down and healed. So in summary, for the canopy augmentation, this can be decided and be done after rotator cuff repair. Rotator cuff repair is just a standard speed bridge technique. It is easy to implant. Use of the divider simplifies suture management. It's a knotless fixation, and the graft that we use has a proven strength, integration, ability to thicken with no reaction. Thank you very much.
Okay, thank you, Alan. That was a great talk and makes, what potentially people worry about a difficult technique very simple. I think that 4-port cannula is a bit of a game changer, isn't it? As with all these things, SCR, BAR, graft augments, suture management is the key. If you get a tangle, you're finished, aren't you? Especially with the knotless system.
Absolutely, and that's a key point with what you said. Bailing out of the knotless system can be very challenging, and if you already have all your anchors in place, your repair in place, the last thing you want is to lose that ability to get that tissue down. So you got to get it right the first time, and you're dead right. That divider is the game changer.
Yeah. So we've got a good few questions coming in, which have been sent through, and I've just been kind of scribbling them down as we go along. You mentioned quite a bit about the graft choice, and it is important. So we know those bovine ones, they're pretty thin, they're not very structural, and you showed that case where it adhered to the acromion. Have you seen any sort of inflammatory reaction or any negatives associated with those particular grafts?
So just so you know, the adhesion to the acromion was actually a dermal allograft. Actually, that was a graft jacket.
Yeah.
The second case I showed you was the bovine graft, and that was very thinned out. Now, what I have found, and I've done about easily, I'd say maybe a dozen cases, they talk about how it is less pain after surgery, and I found the exact opposite. I have found that these people actually have way more pain than my standard cuff repairs or posture repairs that I would do. Okay. Yeah. So I whether it's inflammatory or something else mechanical, I don't know, but definitely they don't do as well.
So the bottom line is we need this acellular, moderately thick, human dermal allograft that's got very low DNA content. That's is the ideal graft then, yeah?
That's my opinion, yes. And based off of what I've seen, the data, the research, I think it's ideal for our patients.
Okay. And the next lot of questions is going on to the technique now. So, we understand very well the technique, and it works perfectly with the speed bridge, with the knotless system, and that and the divider. Obviously, this is going out to other countries, and I know in my country, the UK, we don't have that knotless system. So there's been a few questions about, any tips, like if you haven't got that, or for instance, if it's not a 4 anchor construct, so you've only got a speed fix or something like that, what are your kind of options then?
Actually, there's a ton of options, and honestly, you're only limited by your creativity. As far as I'm concerned, you can do this exact same thing today with a basic normal swivel lock. So let's just stick with that for now. So let's talk about the standard speed bridge. Everyone has the swivel lock, and honestly, that's fine. And what you would do is you do the exact same thing. The difference is when it came to attaching the graft, you simply just tie knots. So you just simply pass the suture through the corner as you would, and then shuttle it in and tie it down using that divider. No problem. It's not. It's a little bit more fussy, yes, but it definitely is not that tough. And as you said yourself, that divider is what's going to make all the difference. So it's the same. So that's the first question. Second, even if you have other anchors, like there's new fiber tack anchors and other type of anchors, I don't think it really matters because there's so many different options that are going to come out that you could do this many different ways with the same idea. It's just an idea. And then lastly, as you mentioned with the speed fix, absolutely. You could easily go a little old school. Medially, pass in some sutures, drag the graft in, tie it down, and then laterally use that anchor to tie down the lateral aspect, or add in an extra push lock or suture like we used to do. There's many options, I think. I don't think you're limited to say, oh, you've got to do it this way or have this anchor. I think that's not right.
And as with all surgeons, if we're told to do it one way, we'll always think of another way of doing it our own way, won't we? You always want to tweak something. And I'm actively saying that's great. Yeah. Do what works for you and what you've got available. There's lots of options. It's just trying to open different ideas and different ways. That's all. Yeah, I agree. And the thing that I found when I've been doing my augments is that early on, I tended to find that this was without the speed bridge system when I was doing, person two suits immediately. I tend to find that when you put your graft in, it was actually lying more over the cuff and less over the bony footprint. And I think it's probably on yours there, you showed it actually, it's kind of half on the cuff, but it's half on the bone as well. So these augments, it's not just stuck on top of the cuff, is it? It has to cover the side of it.
I think that's a fabulous point. And that goes to why I showed you my data on the SCR, because having a bony bed for that graft will help to make sure that there's vascular integration and that it will, in fact, revascularize, recellularize, and attach. I think that's a key component that we forget, that we need to make sure that vascularity is present. And most vascularity from our repairs come from the bone. Yeah. So I think in doing this, I think what you said is really critical.
Do you think, again, a lot of the questions we've kind of covered, but a couple for me now. Do you think, going on from that question about vascularity and the importance of the bone, do you think we need to add anything underneath the graft? Do we think we need to put some ACP, some tendo? Do you think that's going to help?
Matt, you know me. I've been working with PRP since 2007, so I'd be going against my own self if I said no, because I routinely do that. I put in either ACP or bone marrow concentrate. I do a lot of that with these patients, and I absolutely believe in it 100%. But it's got to be put in, as you said appropriately, correctly. It's got to be placed into the interface that you want that adhesion to occur in. You can't just lay it on top. It's got to be underneath where you want the healing to occur.
That's the nice thing about the canopy, isn't it? That you can control the canopy coming in, and as you're controlling it coming in tension, you can just get your your goodies underneath it, can't you? And then
you nailed it. Yeah, and it creates a space for yourself to make sure that it will stick and it'll stay. You're absolutely right.
And another question about your SCR study, because I did a similar study on explants and showed nice tissue integration. So we definitely know that these acellular dermal matrices become a biological structure. They don't stay as a dead piece of skin. They do thicken up. As we said, form follows functions. If you stress something that's biologically active, it's going to react. It's going to get thicker. Why do you think you saw over 1 year post insertion, they didn't appear to have any sort of vessels? Early on they had vessels. This is for SCR, but it's equivalent. It's the same thing. do you think we didn't see them, or or they've healed and they're no longer needed?
Yeah, that's an awesome question. So I don't have the answer, but I had a long discussion with the scientists at LifeNet Health about this concept. And what we think is going on is that in a normal dermal matrix, there is normal vascular channels present, which are not removed in the acellular process, in the decellularization process, excuse me. So those vascular channels are present, and that's what's happening, is that the body is taking over those channels, revascularizing them, using them as their highway and structure to move blood around. However, if you ultrasound and look at a normal tendon structure, there are no vascular channels within them. It's all by capillary flow within them. And so what I believe is happening is that we're getting transformation into the native structure of what it was going to be, some type of linear structure which is going to hold on to it, whether it's ligamentous or tendinous is not relevant to me, but it's just the fact that it's going to be changing and transforming. So you're going to lose vascular channels and you're going to get capillary flow. And if we look at the histology, which they've been doing more and more of, they've gotten a lot more histology explants, that's exactly what we're seeing. We're seeing no large channels. We're only seeing capillary flow. It's exactly as we expected it. And so that's why we see in the first 8 months, between the time of 4 and 8 months, ultrasound evidence of pulsatile vascular channels in the graft. And then about 1 year and beyond, we're not seeing that any longer, and we're only seeing the tendinous on top of that area between the bursal side of the rotator cuff tendon and the deltoid in that bursal space, where we normally see pulsatile peritendinous vessels. And so I think what's going on is it's creating the normal architecture.
So in other words, they've done their job in the first year, and they've got all the cells there, and then they're not needed anymore, so they're becoming integrated as a normal tendon. Okay, so just before we finish this, and just a couple of questions just on essentially this decision about when to go FCR, maybe when to go cuff augment. And you mentioned on your nice sort of scatter picture about quality of tendon. So how can you give the listeners how do you assess the quality of that tendon? Is it by feel? Is it by on your scanning?
So for me, the best way to tell quality of tissue is to get my grasper in there and just start pulling and just try to see how it reacts. And as I pass my suture through it, how does it react? As I pass my suture and start to pull it over, does it start to pull slightly, start to rip slightly? Is it holding well? You can feel the thickness, the sponginess, the quality of it. You can really tell over time. And if you're not sure, put a passing suture through it, pull on it, look at it, look at that hole. Did the hole start to expand and open up, or did it really keep a nice tight hole there? I think we really can do a good job at assessing that directly. I'm not a fan of using the MRI or ultrasound as a determinant for that, because I feel it's not good qualitative assessment.
Yeah, I agree. And I mean, for me, I often use the shaver test. If you just put a shaver on oscillate mode, on normal good cuff, nothing will happen. But on bad cuff, or importantly, you don't want to be repairing bursa, because sometimes you get that thickened bursa, it'll disappear in a second. So I think they're great tips about the integrity of the cuff. Is like, will it hold the stitch? Can you pull on it? What happens to the shaver? That's a determination about whether you go cuff repair alone, augmented cuff repair, and if everything disappears and you've got nothing, of course we've got SCR. So I think now we are kind of describing we've got an option for every scenario, haven't we? You know, we've got cuff repair, standard speed bridge, we've got cuff repair with augment, you know, and we've now got SCRs. And I think if you've got all those in your armory, then you're going to offer a good service to your patients, because you can fix anything or treat anything, can't you?
You know what? That is absolutely correct. So I've stopped telling people what I'm going to do. I basically say, hey, I'm going to get in there, figure it out, and I'm going to do the best I can. I've got all these options, and I'll have it all ready for you. And I'll have a 201 graft, I'll have a 301 graft, I'll have all these different options, and I'll do what's best for you.
Yeah, exactly. Well, there are loads more questions, but I think they're kind of all in the same sort of theme. So it just goes to say, thanks, Alan, for, great talk, very informative. As always, I'm learning a lot. I'm scribbling down on my pad here at the techniques. So I think when we get those new techniques over in Europe, I think it's going to be great for our patients. So again, thanks for being part of this. I'm now just going to pass over to Matthias, who's going to close us out and tell us what's coming next.
Thanks, Matt. Thanks, guys.
Well done.
Thank you once again for joining us for this event. For more information on any of the products or techniques, please contact your local Arthrex representative. You may have also noticed that these webinars are hosted on our new Orthopedia site. Orthopedia is an online educational platform of orthopedic videos for you and all your staff. Please spend as much time as you want navigating through the website. It is open 24 hours a day, 7 days a week with no login credentials required. We hope you enjoyed, and as always, we look forward to your feedback about how we can help you treat your patients better.
Good afternoon, everybody. My name is Vikram Desai. I am an orthopedic surgeon in Mansfield, and I am one of the examiners. And it gives me great pleasure to chair this session on how not to fail the exam. Whilst this is largely aimed at trainees who are going to take the exam in the future, I think it will benefit a lot of our senior people as well, who teach on various courses and those who would aspire to become examiners. I have two fantastically experienced examiners and pediatric orthopedic surgeons. First one is Clare Carpenter, who's a consultant pediatric orthopedic surgeon in Cardiff in Wales. She spends a lot of time teaching, training, and examining, and it gives me great pleasure to introduce her to start the talk today, and in a few minutes she will start. 2 seconds she'll start.
Good afternoon, Prananda. Welcome from Wales. And today we're all actually 3 variably experienced examiners, and what we want to do is share our experience on how not to fail the FRCS Orth. And remember, for many of you, it will be a day of performance that actually, for not everybody, it will be a great day. But what you need to do is be sure that you pick yourself up and carry on in order to go on to your next performance. There are lots of people who have not passed the FRCS Orth the first time. But with all good sportsmen and all good elite professionals, preparation is in fact the key. And you'll hear many of your colleagues and many of the trainees saying it's 6 months of your life that actually is intense and that you have to put aside in order to revise and get through the exam process. But I'm putting it to you that it's not in fact 6 months of your life, it's in fact the tip and the pinnacle of your trauma and orthopedic surgical training career. And actually that forms the basis of how you should plan your career pathway and the strategy throughout your higher surgical training. And again, you're not passive in your higher surgical training process. You are there to guide and navigate your way through the multiple specialties, providing the foundation and the base by which you can base the rest of your orthopedic career. And in fact, if you do that, the FRCS Orth should be a fairly straightforward process. It is a test of your experience and your practical knowledge throughout your higher surgical training. And the ISCP guides you through that process. And I suggest that for both UK trainees and non-training applicants to the exam, that actually no matter where you are, you always formulate your higher surgical training and your lead up to the exam by the ISCP process. And therefore, you should not be aiming to sit the exam too early. And remember, our brains all age very, very quickly. And so you shouldn't leave it too late because you're not receptive particularly well to putting yourself through the rigorous task of putting the work in and answering the questions and putting the resilience. And again, you get to a stage in your career where actually doing exam may not be that attractive. So if you're going to plan to sit the exam, commit to your pathway and don't change your mind. Get involved early. Get involved with trauma meetings, with study groups, get used to communicating and talking about things that you may not know about. Asking questions, learning from other people is how you acquire a lot of your practical knowledge. And also it allows you to be able to discuss, to strategize. And again, that then is translated over into the exam, where you should see it as a two-way discussion with your colleague on day one of becoming a consultant. And actually you learn a lot from your colleagues. You are not in competition with them. You will all pass on the day if you are all good enough. So actually learning from each other and sharing experience is a really good and valuable thing. And there are many, many online resources now that are available to you. And so you don't need to necessarily rely on big textbooks. These websites will all guide you through the educational resources required of you. And again, if you belong to a particular region, and in the Welsh Deanery, we have our own online resource where previous trainees have put their experiences down of the exam. And that can be really good practical advice. And many of you will have access to your own deanery websites. But you should all start at the syllabus. And the syllabus is available on the JCIE website. It's downloadable. And again, remember, the question bank within the examination is vast and it covers the syllabus. So actually it's fair game to ask you anything which is within that syllabus. So if you are not prepared and you haven't read the document, then you are putting yourself at risk of not performing very well. And the JCIE is full of really good advice on how to apply and again, how to prepare yourself for the exam. So this may be obvious to very many people, but you must have passed your MRCS within one of the 4 Royal Colleges. You must have sufficient experience, and they define that as a minimum of 4 years appropriate surgical practice. And that will be in trauma and orthopedics. For international trainees, they require a minimum of 1 year in the UK. But I suggest to you that first year in the UK, will you be settling in and understanding the system? So don't rush in to completing the exam. It is costly and it does take a lot of time and effort. You will need 3 structured references from your locality. The first part of the exam is only a question of knowledge and technique on how to answer multiple choice questions and single best answer questions. And actually, the only way to get through that is to do the bookwork and to practice lots and lots of similar type questions. Many exam type educational theorists have looked at success in exams, and actually learning the technique of a particular exam is key to success. It's not necessary how much knowledge you may have, but how well you can actually technically complete the exam paper. So this part of the exam needs you to go through hundreds of multiple choice questions and support that with reading around where you acknowledge that there are gaps in your knowledge. The section 2 is currently a combination of clinical examinations and oral examinations. And I think James later on will go through that a little bit further for you. But remember, during COVID, we've currently had no patients within the clinical examinations. You will be shown clinical photos, but remember to still be patient-focused and not examiner-focused. The plan will be to reintroduce patients for clinicals after February 22. So you will need to carry on with clinical examination techniques and interaction with patients thereafter. So these are my top trainees tips. I have been a consultant for 8 years, so I think it's probably not that long ago when I remember doing the exam, but these are the tips from the trainees in our region who have recently completed the exam. Work hard. There's no getting around that. And it's not work hard for 6 months. It's work hard for 4 to 5 years going up to the exam. And work hard in a way that you know how, Nobody can tell you how to work. We all work differently. So whatever technique that you've used in the past, you are all great at passing exams. So you've been successful in the past. You know how to work hard. Warn your family, but they will still need you. So you cannot hide away for 6 months. Put time aside in order to have valuable family time, and then you'll be able to last the course. Talk lots to anyone who will listen. One of my trainees says, talk to the mirror, talk to the dog, talk to whoever will listen to you. But again, it's good to have a buddy who you can start the communication process very early on. And when you start the communication process, learn to slow down, learn to think about what you're going to say, learn to be efficient in what you say. There are loads and loads of online courses out there now to support you. Pick the one that you fancy. They're all great. Arrive in a comfy hotel the night before, not the morning before. We've had flights that have been cancelled. We've had traffic jams and candidates not turning up. You will not be let into the exam. You need to arrive the night before. You need to relax. You don't need to open a book unless you've got some quick things to look over. But ideally, you should eat, you should sleep, you should relax, and then repeat that the following night. You don't need any equipment because there are no patients. Currently, refreshments are provided, so keep your energy levels topped up. The exam is long, it is hard. You need to be on top of your game, and so you need to keep your energy levels up. But you need to also relax in between each of the stations when you can. Be confident. Again, your patients want you to be confident on day one. We want you to talk in a confident manner. Don't say, I have never seen this before. You should still know the principles of what you are looking at. And actually being confident about it will mask the fact that you have never seen these before, if your knowledge and principles are correct. Imagine that you are talking to a colleague. We are all fairly friendly examiners, and we all want you to pass. So imagine you are discussing something with us, and then it should be a fairly relaxed interaction, which is what it is the most of the time. If you have a bad station, because some of us did and some of us will, just forget about it. There is plenty of flexibility within the system for you to make it up later on. It's a fair exam, and all the trainees come out saying that. But if you fail, you've just had a bad day. That's all it means. And you get back on the horse straight away, and you keep working, and you just go for the next diet. So my examiner tips, and mine may be slightly different to James because he is a lot more experienced than I am, but I like to see a trainee that comes in and a candidate that is professional. In April sitting, there were trainees with their ties undone, with hands in their pockets. If I was a mother asking you to operate on my child and you came up to me like that, I'd wonder that your attention to detail in the operation isn't as good. So you have to act and come across professional. Do not worry if the examiner does not give you any non-verbal cues and appears neutral and indifferent. We are told to be that way. We are not meant to give you clues because in the exam we don't know how you are going to do overall. So we may appear a little bit cold and indifferent at times. Listen to and answer the question that is asked. Don't give us the answer to the question you think we are going to ask, because it wastes time. If you do not understand, ask the examiner to repeat the question. Having face masks is really difficult now, actually, and sometimes makes it difficult to hear. So if you do not understand, it's quite within your right to ask the examiner again. And be prompted by the examiner. The examiner will sometimes say, is there anything else you might want to consider? Are you sure about that? Be prompted by them. And because some candidates do not take the prompt and they will continue down a pathway which may be wrong. Do not offer irrelevant information. You are wasting time. Pace yourself. Do not go out of the gates like a racing horse. It's really difficult to pull back a candidate that has gone so far down the wrong path because they're just reeling out 12 causes of a condition. And actually, we don't want to hear that. So think about what you're saying. If you do happen to have pressure of speech and talk really quickly, practice slowing yourself down. Do not argue with the examiner. The examiner, on the whole, will always have a little bit more education and knowledge than you will. And actually, if you start arguing with them, you probably will put them into a bad mood. Do not say that you would refer to a specialist. You are the specialist, and you should know the principles of treating that patient. So don't say that, because again, it just becomes a little bit frustrating for the examiner. And again, the opening questions are usually straightforward, so get the basics correct. And then expand with the more higher order thinking, support with the evidence, literature, national standards, etc. Because if you get the basics right and you don't really know any evidence, that's usually sufficient to get you through that station. So this is an example, and again, this template is on the JCI website, so I'm not telling you anything you shouldn't already know. And most of the questions follow a fairly predictable pattern. And the opening question is normally fairly straightforward. And this is an obvious supracondylar fracture in a child. But as an examiner, I wouldn't expect you to say, I would treat this along ATLS principles. Children who sustain this injury are not usually polytraumatized, okay? I get you're trying to be the confident and the thorough individual, but actually it's not relevant within the exam. And you may be taught that in courses just to be thorough so that you don't miss anything out. But actually, we're not interested in that. And equally, I'm not interested in this is a radiograph of an immature skeleton. Of course it is. You don't see supracondylars like this in a mature skeleton. Well, very infrequently anyway. So again, you are wasting time. However, the candidate who tells me I can see ecchymosis in the antecubital fossa, this is worrying for me, as they may have buttonholed through brachialis, making my job in theatre a little bit more difficult. All of a sudden, I'm thinking, this trainee knows what they're talking about. I'm going to push him to a 7 or an 8. So be very specific with what you are going to offer in the answer.
Okay, and this is the second short case. This is Mr. O'Brien, if you can kind enough to observe his shoulders. Yes, right.
So this is a clinical video that I'm going to show you. And this is just an example of one of our examiners going through a clinical case, just to show you the pace and approach by which you should take. Let me just try that again.
Okay, and this is the second short case. This is Mr. O'Brien, if you can kind enough to observe his shoulders. Yes. Right, so Brian, how are you? Hi, do you mind if I examine you? Okay. Right, so I'm just going to look at you to begin with. And just on observation, there's clear asymmetry in O'Brien's upper limb girdle. Looking at the left-hand side, that's where the abnormality lies. There's quite dramatic wasting of the head major muscle, actually more so on the right-hand side there as compared to the left. What is noticeable on the left?
So what I wanted to illustrate there is actually his nice pace, his approach to the patient, how he then was centered and listened to the question to examine this gentleman's upper limb and shoulders. And again, many of the points that you will get from this will just be on observation and description. Now, COVID has meant that we can't use patients at the moment. So we've gone to using clinical photos. And this is an example of now how we would run that exact same scenario, but in photographic form. So we may say to you, this gentleman presents with bilateral shoulder weakness. Please, could you examine his shoulders? And you would look at the photographs in turn, and you would describe what you would do to the patient, okay? And how you would look, and you're looking specifically for asymmetry. And then the examiner may prompt you to see there may be some atrophy or weakness, or there may be scars, and will prompt you along the way. But you are still focused on the clinical examination. And again, if you look down at the bottom right-hand corner, the examiner may say to you, well, why in this shoulder exam is the patient showing you his teeth? And again, you're meant to pick up that you are looking for weakness in the facial musculature to see if this is associated with a facioscapular humeral dystrophy. So remember, only a small amount of the marking descriptors are on knowledge and judgment. It's about how you speak and your approach to the patient. Again, higher order thinking comes in the 7s and the 8s, and that is what you should be aiming to achieve. Because then that allows you to have some bad performances in some of the stations. So my final slide is be prepared. You will have a good performance and you will go away happy. Thank you very much.
Thank you very much, Claire. Thank you very much, Claire, for an excellent and a clear and succinct presentation. It gives me great pleasure to now introduce Mr. James Fernandez, who's a consultant orthopedic surgeon at Sheffield Children's Hospital. He also has an adult foot and ankle practice. He has spent a lot of time teaching and training, not only in this country, but also abroad. And he has a special interest in limb reconstruction, and he's also an international examiner. Over to you, James.
Thank you, Vikram. And Claire, thank you very much for a lovely talk which you have given. There might be a bit of repetition. We have tried to make sure we have different flavors for the same. So this aim of this examination was designed as an exit in training assessment to find competence so that you can find out whether that person or whoever you're testing is able to practice as a day one DGH consultant in the generality of trauma and orthopedics. In simple terms, it is just to assess a safe and competent surgeon who is able to, say, treat my child or treat my grandmother and so on. It's also just one of the requirements for the CCT or the Caesar through Article 14 or by a Caesar through CP mechanism. Now, for those who are joining from abroad, and if you are going for the international exam, the same talk is relevant because we have the same kind of marking principles and so on, and you're tested on the same level. And remember, examiners are the gatekeepers. This is Mr. Fazal Ali, a good friend of mine and colleague, and he is now heavily involved at the JCIE. And this exam is such that the general public and the profession can have confidence in the standard of care available when a GP refers a patient to an orthopedic consultant. And there are 4 prerequisites to success. You have to know the facts and your odds. You should know how to go about and face this exam and the structure of the exam, which Claire has already alluded to. You have to strongly believe that the exam is fair. I was an examiner for 10 years, and now I've been an international examiner for more than 3 years. I can say very confidently that's an extremely fair exam. And again, to repeat, preparation with study groups probably will help you best to get a good result. My only advice, which I tell all our trainees here, is do not prepare just to pass the exam. Because if you prepare like that, the probability of chance is you're going to fail. You have to excel, at least in some areas of the common conditions, because the exam, they're all common conditions which are asked in any subspecialty. So you have to score some 7s or 8s, because somewhere, if it's a bad day, you might get a 5 or a 4, and you can make it up. So these extra points will increase your balance to offset a slightly below pass station. If you look at the pass rates of the exams in the last few years, Section 1 is about 65 to 75%, and Section 2 is 60 to 70%. Of course, they're categorized as based on NTN type 1 trainees, who usually perform better, 75 to 90%, whereas the type 2s are generally 25 to 35. So this success of results of pass rates does indicate that being in a training program significantly helps your chances of passing. Partly this may be because the preparation is started right in the beginning, as opposed to the last 6 months leading up to the exam. It also does indicate that it's still possible to pass even if you're not in a training program. And many of you in this country, you will be exposed to such training opportunities as there are other colleagues in your department. The written exam is quite fair because it's set by a committee and they're scrutinized by 10 examiners, and it takes a long time to even set one question. Poorly performing questions are usually removed and they're looked closely by the panel and then either discarded or amended. Remember, these are negatively marked, which means that whatever you know, you can possibly mark the right answers, but whatever you do not know, probably you can still give a guess. The pass mark is set at a standard setting meeting, or it's called the modified Angoff procedure, where the examiners have to do the same written paper. And this pass mark is therefore set after the standard setting meeting of about 20 examiners. And therefore, there's no limit on how many can pass. There will be a percentage score cutoff, and whoever are below that line will fail. Whereas the vivas and clinicals are designed to test higher and lateral order of thinking. The examiners basically want to discuss management of patients, both investigations and management, just the way you do in grand rounds, or how you would see a patient in clinic and appropriately treat. So they expect these candidates to be able to advise on treatment on that specific patient, rather than give a list of treatment options. So if an examiner says, how are you going to treat? You should start the line saying, I would like to, or I would ask for these investigations. So you have to change the way you talk, and I should be your favorite word, depending on how the examiner has framed his question. So it's all about seeing whether you are a confident day one DJ consultant who can make proper decisions. And for the vivas, remember, all the examiners meet the day before and they do a standard setting of all the questions and images. And therefore, all the examiners are also, the next day, are assessed by assessors while they're examining you as well. And we all have a significant amount of training, including equality and diversity. And therefore, you should know that lots of things going on that behind the scenes to make sure that the exam is as fair. Over the years in the past, those examiners were deemed as unfair or too tough have been weeded out. So do remember that examiners are there to find out how much you know rather than how much you do not know. What about the clinicals? Examiners give you a chance to examine these patients. Of course, for the time being, they're all virtual, but I'm given to understand from May next year or November, there might be real patients, but the format may slightly change. There might be some simulated sessions for short cases, and the intermediates will be with patients for about 3 cases. So things might change. The examiners are also assessed during the clinicals, and the pool of patients we have for the day are the same for all candidates. Some of these things, Clare, Ms. Carpenter has already said a few things. Family support, you should remember that inform them, timing of the exam must be good for the family as well, and do involve them throughout and do not neglect them as well. Otherwise, you will get burnt out even before the part one. Having a revision group does help. When I went for the exam in 1997, we were 5 of us. I think 4 to 5 is the best. And you may have to save some money to spend on courses, which Clare has kindly put up in her slides, books, hotel, nanny, and so on. Remember, this is a marathon, not a sprint, so you have to start very early and prepare very well. I think statistics is something which is important. I've just put this in as an addition, just as a reference for you for statistics in orthopedic papers. Do stay in a good hotel, but do not stay at the same hotel as the examiner. On the day, do not keep on reciting things of ABC, ATLS, and so on. Listen to the question carefully, because everything is to answer to that question, and they are very specific. And if there are props and so on, or there's an iPad, don't try to touch or use your pencil on an iPad or a computer.
James, if we could hurry up, please. We're running out of time.
I'm just finished here. How to pass the clinicals. Examiners are looking to see that you have done particularly the examination technique. They look at how respectful and gentle you are, and all the other basic things you normally do in clinic. And do follow Apley's look, feel, and move. And always remember, all for lower limb, stand your patient. And also look on the JCI for the marking system. It's all there from 4 to 8. And examiners are urged to use the whole spectrum of marks. And because there are 96 marking episodes, the pass mark is 576. So this is very important, why you should get 7s and 8s. And remember, the examiner's fallback is this candidate suitable to be a day 1 consultant. So therefore, kindly look the part on that day. Thank you.
Thank you very much, James. Thank you very much for an excellent presentation to both James as well as Clare. Unfortunately, we don't have much time for questions. However, if possible, I would just like to share my 10 commandments, which actually is to a large extent a summary of what James and Clare have said to us. So my 10 commandments are these: the 5 Ps. Proper preparation prevents peaceful performance in an exam. So please prepare before you go for the exam. The second bit is do it in real time. These are all real cases and scenarios based upon examiners' experience. Don't rush through it and listen to your examiners. If you haven't clinically dealt with it, it is difficult to respond appropriately in an exam. So a good, vast experience in training program does definitely help. As has been said twice before, please listen to the examiner and don't answer what you think you want to answer, answer what you have been asked to answer. Also, please remember, every situation is difficult. So don't have to keep stressing that it is a difficult situation and you're going to talk to the patient. This is what you would normally do as a consultant. Also, treat every situation on its merit and practice to answer like a consultant as if you're talking to the patient themselves. Please don't refer every patient to a specialist, because if there is a specialist for everything else, what are you going to do? Also, treat the examiner as if you're doing a subspecialty clinic, so that if you've done these subspecialties, you should be able to talk through them. Talk in an exam as you would be in a clinic. Also, there are so many courses out there. You only need one course because too many courses do become confusing. So thank you very much. Thank you for listening. It now gives me great pleasure to introduce the next session, which is going to be chaired by Mr. Amit Sinha, and it is about orthopedics, a Welsh perspective. Thank you very much for listening, everybody.
Welcome, everybody. It is a pleasure for me to welcome my friend, Owain Ennis. He is an orthopedic surgeon in Carmarthen, where he is currently the clinical lead. He hails from North Pembrokeshire and trained at the University of Wales College of Medicine before undertaking basic surgical training in South Wales and higher surgical training in the West Midlands. He has been a consultant since 2009 and has been the Honorary Secretary of the Welsh Orthopaedic Society since 2015. His main priorities are family, Wales, and golf, in that order. We welcome you, Owain, and thank you. Over to you.
Hi, good morning all, or good afternoon all rather. Sorry, a bit of a bad start now because I can't find my share screen button, having perfectly found it earlier on. So my apologies to conference. I will get to you as soon as I possibly can, which is a little bit of an embarrassment. It's an honor to be asked to present today. You'll just have to bear with me a very short second.
Well, the Welsh Orthopaedic Society has been established for many, many years back. And to be honest, we owe that to our professor, Bob Owen. At this moment, I just see that the PowerPoint is on. Owain, are you ready to go now? Excellent.
Hopefully you can now hear me. Please accept my apologies, conference. That was after many, many days of preparation and planning. Then it all went wrong right at the very end. I think I might have got the heebie-jeebies from the excellent talks about the exam, which brought back the sort of cold sweat running down the nape of my neck facing David Jaffrey and Oswestry. Or even worse than that was Jay Trivedi, to be quite honest. I hope Jay's listening. So thank you once again for the invite. It is an honor to be asked. I've been given quite an open brief. So I thought I'd touch on some historical aspects of orthopedics in Wales and give a very brief summary of where we currently are. Now, as Amit's already alluded to, I'm a very fiercely proud Welshman. And anyone who's Welsh is a little bit prone to romanticism. They swing between pessimism and optimism. We've got a little bit of militancy about us now and against, and anything we have a passion for, we're definitely biased, which for me, that includes orthopedics. And of course, orthopedics is inherently Welsh. And without certain Welsh individuals, we certainly wouldn't have our speciality. But what sort of state are we currently in terms of orthopaedics in Wales? Well, to be quite honest, it's pretty dire overall. As we all doubt know, the surgical specialities in general have been adversely affected more than any other, and orthopaedics has been disproportionately affected more than any other surgical specialty. And orthopaedics in Wales, I think, has been more disproportionately affected than any other nations in the UK. Now, politicians would have us believe this is all due to the COVID effect, but we know in Wales that it isn't. It's just simply exposed our services and revealed how fragile they were pre-pandemic. We can't return elective and trauma capacity in the post-COVID era if it wasn't really there in the first place. But we're going to save the doom and gloom and pessimism for a bit later on, and we're going to touch on some history and some romanticism. Now, I'm sure many of you will know the story of the Anglesey bone setters, and if you don't, it's not my intention to go over it all today, but there's a very good article by Mel Jones on the Welsh Orthopaedic Society website, which I would draw your attention to. And the orthopaedic dynasty, as it were, really starts with this man, who is Hugh Owen Thomas, designer of the Thomas splint. And he was basically a non-stop kind of guy. He would work every hour of the waking day. He'd very rarely take any holidays throughout his entire career, and he was always working. Now, the other reason Hugh Owen Thomas is important, apart from the design of the Thomas splint, is, of course, his nephew, who was Sir Robert Jones, who was orphaned at the age of 13 years and 30 years old. And Hugh Owen Thomas became his guardian, and Sir Robert Jones then followed in his practice. Now, Sir Robert Jones probably made the Thomas splint more famous than Hugh Owen Thomas ever had by its use in the Great War, and a significant reduction in mortality rates as a result. And he, of course, is almost famous, along with also famous along with Dame Agnes Hunt for the institution that bears his name, which is the Robert Jones and Agnes Hunt Hospital in Oswestry. And it's from this place, realistically, that the rest of the orthopaedic dynasty flows. And the first interesting chap on the way is this chap, is Sir John Lynn Thomas. Now, Sir John Lynn Thomas was originally from not far from where I live. He's from Cardiff, which is Cardiganshire. And it is said that most people from Cardiganshire are a little bit tight. They're careful with their money, and I suspect that this man was no exception. Now, he worked alongside Sir Robert Jones during the Great War, and also helped to establish the Cardiff Royal Infirmary as a centre of excellence. His description as an individual is very interesting. He was described as being of above average height, of a very stocky build with a large unruly head of hair, but it's his personality that is perhaps most interesting, that he was said to have a friendly, childlike disposition, but at the same time, he was very combative and transparently interested in his own affairs, which makes me wonder whether he's the very model of a modern-day arthroplasty surgeon. And he was also helped establish the Welsh National School of Medicine, and to establish within Howell House, which is pictured here, the hospital for limbless sailors and soldiers, which is a very cheerful name, which was subsequently renamed the Prince of Wales Hospital, and eventually moved to its site in Rhydlafar, finally opening in 1953. Now, the next name in our orthopaedic dynasty is Dilwyn Evans, and Dilwyn Evans' work on foot deformity made him world renowned, but he was also very well recognised as a very prolific and gifted teacher, sat as the chair of the medical board of Welsh National School of Medicine for many years, and as president of the Medical Student Society on 3 separate occasions. Such was his popularity with the medical students overall, due to his commitment to teaching. The next notable individual to mention is Roland Hughes. He was the first sole appointment to the Robert Jones and Agnes Hunt, and was again a renowned teacher. And it was him that was responsible for instituting the famous Friday afternoon clinical conference sessions, followed, of course, by the evening meal in the doctor's mess and the usual game of Oswestry billiards. And another person to mention in this story is Professor Bob Owen, who I was honoured enough to meet in his time. Even at the age of 95, he was still coming to Welsh Orthopaedic Society meetings and engaging with trainees and his consultant colleagues at that point. And it was an honour to have met him and have known him. And Professor Owen was himself very responsible for the introduction of the Charnley implant in the first centre outside of Wrightington, due to his close association and indeed friendship with Sir John Charnley. And it was the ideals of these three individuals and the ethos that they helped set up in terms of Welsh orthopaedic surgery that led to the formation of the Welsh Orthopaedic Society, which was very ably assisted by David Jones, previously at Ysbyty Gwynedd and now and also in Great Ormond Street as well. So after this fantastic start, where did it all go wrong? Now, as you might have gathered, we're about to move into the doom and gloom pessimistic session at this stage. Well, why am I showing you a picture of a roundabout? Well, this is the site of the previous Prince of Wales Hospital, which after 45 years of service was closed in 1998. And it would be probably disingenuous to suggest that the closure of the Prince of Wales was the reason why we're in such problems now, but it's a symptom of what else was happening in Wales at that time. If you look at these numbers in terms of bed numbers for Wales, this is the entire NHS. Over the last 30 years, bed numbers have been cut in half. And the biggest reduction in those bed numbers happened in those first 10 years between 1990 and the year 2000. And in 2003, the Welsh Government prepared this document and published it, called an Orthopaedic Plan for Wales, within which they demonstrated that the population was changing, our population was increasing, and the demographic of that population was also changing, with an increase in the number of 65 to 74-year-olds predicted. And they also demonstrated that within Wales, we weren't offering the same proportion of surgical intervention to people. We were under-offering surgery, and that if we corrected that by 2012, there would be a significant increase, somewhere around 30–40% in terms of the number of operations we would need to provide. And within that same document, they predicted a shortfall in number of trauma and orthopaedic beds by over 170 by 2014. The Welsh Audit Office then in 2005 kind of backed up those findings and went even further. They said, there's no clear overall strategy. We don't have protective elective capacity, which would help us get on top of the waiting list. The biggest reason for cancellation of an orthopaedic operation was an unavailable ward bed. And at the end of the day, no management of the waiting list issue had managed to provide a sustainable reduction in waiting time. So we had a perfect storm of increasing activity, reduced resources, and a much greater demand. Yet, surprisingly, as these figures show, there wasn't much of a huge effect. There was a fairly modest increase in the number of patients waiting for inpatient and day case treatment, and a slightly larger increase in patients waiting their first outpatient appointment. And of course, the reason for this was that we were using waiting list initiatives, which are simply another version of Aneurin Bevan stuffing their mouths with gold. And the Welsh Audit Office highlighted this in their report, saying that they've been widely used, but they didn't deliver sustainable reductions in waiting times, questionable value for money. They help out the patient who's having their treatment under that waiting list initiative, but they do nothing for the patient of the future. And most importantly, the control of the expenditure on waiting list initiatives had been very, very poor. So we have these two documents published, both of which were very critical of our current, of the system as it was at that point. And you would have thought then that there would be a fairly rapid pace of change, bearing in mind these two documents. But sadly, it was anything but. Welsh Audit Office published again in 2015, in which they highlighted, and this is from their document, there was 7 years of complete inaction following the publication of the Welsh Government Plan. Literally nothing happened, nothing changed. And then in 2011, the National Orthopaedic Programme was put in place. Now, the National Orthopaedic Board met quite a lot in 2012, 2013, but apparently didn't meet at all in 2014. So by the time the Welsh Audit Office published in 2015, they were pretty critical of that project as a whole. They stated that only 2 out of 15 of their priority actions had been achieved. And one of the main reasons they gave was a lack of engagement with senior clinicians in health boards and senior clinicians in executive roles as well. One action that the National Orthopaedic Board did manage to get through, though, was the commencement of a musculoskeletal assessment and treatment service, which is known as CMATS in Wales. In 2014, the National Board was then replaced by the Welsh Orthopaedic Board, which is part of the Planned Care programme. And since then, the board has been meeting over the years with very much an agenda driven from central government rather than a clinically led agenda, I would say. So despite the Welsh Audit Office, every man and his dog explaining the futility of waiting list initiatives as a reasonable measure to address the issue, the money kept on being ploughed in. The money was never available for sustainable solutions. And in 2013, I think it was, they provided 65 million over a 3-year period to address the waiting list, but only provided 4 million of that just to be able to spend on a capital project that would provide a sustainable long-term solution. Now, it's very, very difficult to gauge how much has been spent over the years, but it's probably close on to 500,000, I would say. 500 million, certainly between 400 and 500 million. And so by the time the Welsh Audit Office published their report in 2015, unsurprisingly, they felt we weren't well placed to manage. Now, GP referrals kept on increasing, and the particular uptick around about the time of CMATs coming into play. We had prudent healthcare, which was rationing by any other name, which was pretty radically applied to orthopedics, and we had the Getting It Right First Time report, which was completely ignored by health boards and Welsh Government to a man. And since 2015, we've been in some sort of Groundhog Day, with more money being spent on waiting list initiatives, bed closures of the winter crises, and not able to make any impact to provide better care for our patients. And then along came COVID, and basically our service was wiped out. Like everywhere else in the UK, we went into hibernation in terms of orthopedic practice for about 6 months. We had a very brief Indian summer at the end of last year, and we started back again in April of this year with only about 30% activity. But starting back, we've lost staff, we've lost clinical areas, we've lost theatre capacity. Some pathways of care have just completely disappeared for us. And the outpatient waits have increased, not by as much as you would expect maybe, but the proportion of patients waiting more than 36 weeks has increased by over 13,000. And of course, only a small increase in patients waiting inpatient treatment, but all of those outpatients are going to convert. But we're going to go back into a bit of optimism now, because our response as orthopaedic surgeons throughout Wales, and I'm guessing throughout the UK as well, has not gone unrecognised. We've gone from being fully paid up members of the awkward squad and always complaining to actually being clinically engaged with our managers and with Welsh Government centrally. We've rolled up our sleeves, we've learned new skills, we've looked after patients on critical care on the wards, we've been proning, we know how to give CPAP, all of these things, and that has gained us some significant traction. The Welsh Orthopaedic Society has also been very, very active, more clinical engagement with Dr. Andrew Goodall for the NHS Wales, and also a new regional approach to how we're going to provide orthopaedic surgery in the future. But what does the future look like? Well, we might need several of these. We might need several of these. I don't think only one of these will do, but certainly we're going to need lots of these if we're going to recover and get out of the dire situation that we're in. Thank you very much, everyone. I apologize for the technical aspects at the beginning, and I wish you all the best for the rest of the conference.
Well, thank you. Thank you very much, Owain. And you've given us a very honest account of the past, the current, and a hopeful future for orthopedics in Wales.
Hopefully not too militant, I hope.
No, not at all, not at all. And one has to be, as I said, honest and candid about it and accept the issues going around with us. Just one information I want to give to our audience is the father of orthopedics, Sir Robert Jones, was born in Rel. And I know exactly which building he was born in because I have worked in Rel for so many years, and I'm very proud of that. Thank you, Ayn, once again, and I'd like to hand over to Ajay Sharma for the next, all of us are waiting for, the inaugural address. Thank you.
Good afternoon, everybody. I'm Atul Gaitonde, consultant trauma and orthopedic surgeon at Princess of Wales Hospital in Bridgend. It's my pleasure and privilege to introduce Dr. Ashok Johari, who's the most renowned pediatric orthopedic surgeon from India. I've been privileged to
It gives me great pleasure in introducing Baroness Eluned Morgan, Member of the Senate and Minister for Health and Social Services of Wales. Baroness Morgan was born and brought up in Cardiff. She won a scholarship to the United World College of the Atlantic and gained a degree in European Studies from the University of Hull. Baroness Morgan earned her stripes early on, being elected as the youngest member of the European Parliament at the age of 27. She was only the 5th woman to be elected to a full-time political post in the history of Wales. Baroness Morgan brings with her immense and diverse experience. She represented Wales for the Labour Party from 1994 to 2009. In this role, she was the Labour spokesperson on industry, science, and energy. Way before green energy became mainstream, she authored the Green Paper on Energy on behalf of European Parliament and led the Parliament's discussions on Electricity Directive and the issue of fuel poverty. Baroness Morgan then served as the Shadow Minister for Wales in the House of Lords and as the Shadow Minister for Foreign Affairs. She was elected to the Welsh Assembly in 2016 and appointed Minister for Welsh Language and Lifelong Learning the following year. In 2018, she became the Minister for International Relations and Welsh Language. Just over 6 weeks back, she was asked to serve her nation in the most challenging of times as the Minister for Health and Social Services. Friends, you would agree with me that Wales is lucky to have in Baroness Morgan a very experienced, capable, and a people-centric minister. We, the British Indian Orthopaedic Society, wish her great success and assure her of our commitment to support her government's initiatives in the coming days. Over to Baroness Morgan.
Shumai, hello, I'm Eluned Morgan. I am the new Minister for Health and Social Services in the Welsh Government, and it's a huge pleasure to have been asked to participate in your event that's being hosted here in Cardiff for the British Indian Orthopaedic Society. So, croeso mawr I chi, diolch yn fawr I chi am ddod i'r gynhadledd. Thank you very much to the organisers for hosting this event in Cardiff. It's a shame we can't meet each other in person, but hopefully as we see things getting better, hopefully in the next few months and years, we will be able to rectify that in some way. We've all lived through an incredibly challenging time, haven't we? And we've seen really the best of the NHS really show itself during this time. The way people have come together, the way people have learned to be innovative, and the way people have managed to turn things on really, really quickly in order to protect, in particular, the most vulnerable in our society, has been truly a sight to behold. So thank you to you for your contribution in that. We are absolutely indebted, in particular here in Wales, for the contribution of doctors of Indian origin who make a fantastic contribution to our NHS. Of course, that was born from the inspiration of Aneurin Bevan, a hero to us still here in Wales. Well, COVID is still a huge challenge. It's not over. The Delta variant is still really a huge challenge for us. But of course, even after that challenge will dissipate, hopefully with the incredible success of the vaccine rollout, there are still immense challenges that are facing us, not least in the fields of orthopedics. And we know, and I'm very aware, that there are literally tens of thousands of people on our waiting lists here in Wales, many suffering in real pain, waiting for their turn. And as the Minister responsible for health, then I am very aware that it's our responsibility to try and do as much as we can to relieve that pain as fast as possible, knowing the pressure on the system, knowing that we still have to adhere to very strict COVID rules, understanding that there is a limit in terms of staffing and expertise as well. I am particularly privileged to have been asked by Amit and Keshav, who I know are legends here in Wales, and I'm sure they are within your community as well. But I, as the Minister, am absolutely determined not to waste this crisis. This is an opportunity for us to do things differently, to think differently, and to really get a grip. Let's not forget the NHS was born out of war at a time when there were huge debts that had accumulated in the country. And so now is the time for us to do some radical thinking and some real innovation. So I want to make sure we capture that spirit of innovation that we saw emerge so readily during the pandemic. And I'm aware in Wales that we, like everywhere else, need to think about doing things differently. And it's really interesting. I think one of the challenges is to make sure that we bring patients and the public with us. I had a very interesting conversation with a neighbour just a couple of days ago who was just telling me how she'd been waiting a very long time for a knee operation, how much pain she was in, and how she'd been told, well, actually, you know, you need to think about losing a little bit of weight if you want to get the best outcome after an operation. It would be best if you could try and lose some of that weight before. And she was telling me how difficult it was because actually there's a 9-month waiting list in terms of getting to see the dietitian. And I just thought, my gosh, you know, I think we've all got an idea what the dietitian's likely to say. So how do we get people to take far more personal responsibility for their own health? That is a challenge for all of us, and something, a cultural shift, I think, that we certainly need to embed, and certainly something that is absolutely central to our vision within A Healthier Wales, which is a part of our programme within the health service in Wales. I've heard loud and clear the calls for separate planned services when it comes to orthopaedics with sites away from the pressures of A&E. I have encouraged our health boards here to think in a different way, not to think on a health board footprint, but to think more regionally, perhaps even in a whole nation approach, because we do have to actually address the issue, and centralising services sometimes is the best answer. I was very interested also to see the work that's being done to get patients to understand the risks that they are undertaking when they put their names forward for surgery, and that Consent Plus website is something that certainly is of great interest. I think we've also got to ask difficult questions in terms of productivity. Why are some departments much slower than others? Why are some parts of the country much slower than others? What can we do to get others to catch up? Why is productivity better sometimes in the private sector than the public sector? What is it we need to do to incentivize people to work better, knowing the kind of political position that we take here in Wales as a Labour government? Are we getting too many people referred for surgery? Are we investing enough in alternatives? I was very interested to see, as somebody who spent all day, every day practically on Zoom calls, just getting stiffer and stiffer, and suddenly discovered yoga. And I'm an absolute convert now, and I was very interested to see that that is also a part of your agenda in this conference. So I'm only a few weeks into the job. I know I have a huge amount of to learn, in particular about this sector where I know there will be a huge pressure. I hope that I will be able to depend on people like you to come forward with good ideas, to come forward with suggestions, and we can then learn from each other and hopefully get the best outcomes for the people, certainly who I represent, and so many of your patients. So diolch yn fawr iawn i chi, and I hope you have a very, very successful conference.
Symbios, a leading opinion in the design and manufacture of custom knees, a surgeon-led alignment strategy with anatomically matched components, the Origin TKR is your clinical solution in a box.
Many thanks, Baroness Morgan, for inaugurating our conference. Now we'll be moving on to the next session, which is the best of best poster session. I'm Nitish Kogi, I'm one of the pediatric orthopedic surgeons. I'll start off with the first. We've had a lot of interest from the poster session, but we had to shortlist it to just 5 for best of the best, and the results will be declared later on in the conference. So we start off with the first paper, which is by Mr. Cheruvu from Bangor, regarding the study on overstuffing of the distal femoral condyle during mechanical alignment in total knee arthroplasty. And it's an analysis based on a 3D MRI model. So here we go for the first presentation.
I'm glad to present to you the overstuffing of the lateral distal femoral condyle during mechanical alignment total knee replacement, an MRI 3D modeling study. The most common alignment technique used for total knee replacement is neutral mechanical access. The distal femoral condyle resection is less valgus than native anatomy. And with the measured resection technique, the medial femoral condyle is the chosen target for the distal femoral resurfacing. There still seems to be a mismatch between the resection and the implants inserted. With the aim to achieve neutral mechanical access, there is a multitude of flexion extension, medial lateral gaps, conflicts, and soft tissue releases that are required. However, overstuffing of the distal femoral condyle is not addressed by these adjustments. Anterior knee pain is an ongoing common cause for poor outcome. However, the specific issue of overstuffing of the lateral distal femoral condyle as a potential etiology of this has yet to be explored. In our study, we observed using consecutive MRI scans. We simulated 292 of these and demonstrated 225 varus knees, 67 valgus knees, with a mean supine hip knee angle of 5.6 and 3.6 degrees respectively. Varus knees overstuffing was 1.9 millimeters in the lateral distal femoral condyle and 4.1 millimeters in valgus knees. Our study shows that overstuffing of the distal femoral condyle component occurs commonly with mechanical alignment total knee replacement. The magnitude is greater in valgus deformity, and indeed, most studies have concentrated on the relationship between anterior overstuffing and pain, and here we seem to have identified an alternative etiology. Mechanical alignment drives towards altering the native knee alignment and anatomy, and despite multiple other adjustments that can be done, the issue of overstuffing has not been solved. Indeed, this is also not evident on postoperative radiographs. We suggest that a more anatomical alignment technique aiming to resurface the distal femur may help solve this issue. In addition, we utilize cartilage wear pattern simulator to be able to identify this additional parameter, which should be utilized in preoperative measurements and planning. Thank you.
Right, thanks a lot. Moving on to our next presentation is by Mr. Belcher. It's regarding patient satisfaction and Boston carpal tunnel questionnaire assessment following the Volent technique for carpal tunnel decompression. Interesting one. Let's see what they came up with.
Hello, my name is Phil Belcher, and I'm a current Foundation Year 2 doctor working in the northwest of England. Today I'm going to be doing a brief presentation on the project, which is patient satisfaction and Boston carpal tunnel questionnaire assessment following Volent technique for carpal tunnel release. I'd like to thank Mr. Lowe, Mr. Iyengar and FEURD for helping me with this project. There are two forms of carpal tunnel procedure. One is wide-awake local anaesthetic non-tourniquet technique, which is a day case procedure that allows communication between the patient as well as the surgeon, and it allows the patient to leave that same day, versus traditional carpal tunnel surgery, which does not involve local anaesthesia, does not allow for interaction between the patient and the surgeon. And while often the patients can leave the same day, sometimes they don't. We looked at 30 patients, 15 in each arm, those who had received traditional carpal tunnel surgery and those who had received Wallant. And we compared two things. We compared a symptom severity scale and a functional severity scale using the Boston Carpal Tunnel Questionnaire. And we also compared subjective outcomes between the two groups using a visual analog score to evaluate patient satisfaction post-procedure. So what we did was, after procedure, we evaluated the subjective outcomes, so using the visual analog scale to assess whether patients would be likely to have the procedure again, whether they would have the procedure performed on their other hand, and whether they would recommend the procedure. Then, about a month or 2 months after the procedure had been performed, we called the patients to assess their symptom severity and their functional status based on the Boston Carpal Tunnel Questionnaire. We found that when we looked at the subjective assessments, so the visual analog score, 100% of patients in the Wallant group stated they were satisfied with the operation. When we looked at the functional and symptom severity side of our project, we found that relief from night pain and sleep disturbance were the most improved symptoms in the Wallant group. However, there was no real difference in terms of symptom severity and functional assessment between the two groups. Having said that, given that there are clear advantages of the non-tourniquet technique in relation to increased patient satisfaction, as well as patients being able to leave the same day and have interaction between the surgeons, Wallant technique could potentially become the new standard for carpal tunnel release surgery.
Thanks, excellent observations. Moving on to the next one, it's we've had a terrible time during the COVID pandemic. Getting back to normal is everybody's dream. So we've got Mr. Tambuwala who's presenting about the effectiveness of a green pathway for getting back to elective orthopedic procedures. Move on to his talk, please.
Good afternoon. I'll be presenting our study on the effectiveness of a green COVID-19 patient pathway at Wrightington Hospital. Now, the importance for delivering high volume and high quality elective orthopedic surgery was the reason why a green patient pathway was established at Wrightington Hospital. So in order to evaluate the safety and efficacy of this pathway, we looked at the records of patients operated between July and January of this year. Patients who did not attend their post-op follow-ups were also identified, and we looked at the regional COVID rates compared with the hospital COVID rates as well. So what we found was, among the 2,466 patients, 16 patients, or 0.6% of these tested positive for COVID. Of these, 14 patients recovered completely from COVID. We found 34 patients who did not attend their post-op follow-ups, and the importance for following up these patients was to determine whether they missed their appointments due to COVID-related illness or isolation. There was no major COVID outbreaks and no definite evidence of in-hospital transmission. We also found that the COVID rates in the region closely paralleled the hospital rates as well, as evident from these graphs. A distinct advantage that we had was the geographical separation between the elective and the acute sites in our trust. So to conclude, the green pathway helped streamline patient flow and segregate green zones from amber zones. We recommend modulating elective activity, quite similar to the variable speed on the motorway in response to regional COVID rates. Ramping up elective activity is important after a decline in regional incidence, and we found that this was an effective measure in maintaining elective activity through the pandemic. Thank you.
Oh, excellent talk again. I think we've got a similar paper from a treatment center looking at another elective surgery pathway during this COVID times and see how successful it's been. That's by Mr. Chiranjeev Dey from Sandwell and West Birmingham Treatment Center.
Hi everyone, I'm Chiranjeev from Sandwell and West Birmingham NHS Trust. I'd like to present this paper on practice of safe elective surgical practice during COVID-19 pandemic. So during the pandemic, there is a worldwide cancellation of elective services, which leads to a huge backlog. And we need a safe exit plan, which is reproducible and sustainable. So our study design is based on a single center prospective observational study, which was done in Trust's COVID-free environment, including the adult elective surgeries only. And there is nearly equal proportion of male and female patients during the surgery. However, the higher number of patients for ASA grade 2, and we have least number for ASA grade 3, and we excluded all of the ASA 4 patients during this endeavor. We included all the surgical specialties, including orthopedic, ENT, general surgery, gynecology, plastics, and urology. And most of the patients were of intermediate complexity followed by the major complexity. But strikingly, most important factor, we managed to discharge most of the patients on the day of the surgery itself. We maintained 100% compliance to the RT-PCR testing. One of the patients was symptomatic after the operation. However, she was tested COVID negative, and we encountered no significant postoperative complications. So the conclusion is the key to success is careful patient selection, adequate pre-assessment, strict adherence to the protocol, and vigilant postoperative care. It is very important at the same time to maintain a safe COVID-free environment, which is essentially a green corridor for sustenance of these elective surgeries. Thank you very much.
Thanks a lot, Mr. Dey. Now we're moving on to the final topic by Mr. Neil Chotai. It's regarding the arthroscopic dog bone procedure for the treatment of lateral displaced clavicle fractures. We don't have a presentation, but I'll be reading through the abstract. It's an interesting topic. The aim of the study was to present the results for treatment of fractures of the lateral end of clavicle, which have been arthroscopically stabilized by the tightrope device, which is dog bone copyright Arthrex. The methods were they performed retrospective study on patients between 2015 and 19. They were identified using the CRS Millennium software, looking at the operation notes and clinical letters. The assessment was performed by Oxford Shoulder Scores, and that was on the final follow-up. And the PAC system, hospital PAC system, was used to look for the post-op radiographs. The results were they treated 26 patients with displaced lateral end clavicle, 4 patients who were treated with the dog bone and supplementary plate fixation, and the remaining 22 were using the dog bone alone. Radiological union was seen at 22 in 22 patients, which is almost 84%, and the mean Oxford shoulder scores was 46. Apart from that, 1 patient required removal of the superior end button and not under local anesthetic, and there was no secondary surgery. There were no cases of infection, nerve injury, or frozen shoulders. To conclude, the arthroscopic tightrope treatment for lateral clavicle fractures is a safe, cosmetically friendly technique with promising high rates of fracture union and return to normal activities. And it's recommended instead of a conventionally used hook plate. Thanks. Here we come up to the end of this session. As I've mentioned before, the results will be declared later on in the conference. So all the best for the to the presenters. We're now heading into a coffee break, and while you're having a coffee break, enjoy the video from EpiSurf. Thank you.
Welcome to this session. I'm Tim Spalding, and this session is on behalf of EpiSurf. So I'm going to be talking about the Episealer implant in the knee. So if I start off on use in the knee, I'm a surgeon in Coventry in England, and I'm presenting the results of a recently published paper on 80 patients at 2 years, along with the indications, and then essentially I'll show you the treatment and the technique for this. The starting point here is that we have this treatment gap between patients that are likely to benefit from the arthroplasty, unicompartmental or total knee at one end of the spectrum, and those that would be better off with the biological treatment at the other end of the spectrum. And in the middle, therefore, we have this gap, patients that are not yet ready for the knee replacement and are beyond the biological options. And I think that gap is really being a bit more clarified now with the options that we can use to treat. Many patients have had biological treatments and may now have poor outcome from that, and they've had this previous surgery. Essentially, with the Episurf, what I want to be able to show you that we have much more predictable implants now and predictable results. And that indication is becoming refined as we buy time before knee replacement. There are other treatment options in this field. There is the HemiCap from 2003. We have the BioPoly implant from 2013 onwards. And then at the same time, the Episealer implant was developed with the Solo as a single implant and the Twin as a larger implant. And this is from Episurf based in Sweden. Let me just run through what the system is to begin with. And this is an individualized mini implant system. The key part and the benefit to me is that we send the MRI scan to Episurf, and then there is the damage report, which gives us the design and the manufacturer of this guide, as you can see in the middle of the screen here, where we have a 3D printed guide, which allows for the accurate implantation of the implant, getting it to exactly the right height. And we can choose and decide that that is the appropriate size of guide and implant. The implant itself is made from cobalt chromium, with then on the underside HA on top of a titanium coating to enable that bony ingrowth. And it is then shaped and individualized to the patient. Along with that come the disposable instruments, which allow for accurate final positioning, and I'll show you that on the video. The results then for this particular patient then on a left knee medial femoral condyle is a guide that allows us to accurately see and align onto the defect and then implant the specific episealer. It's also possible to do a larger area, and here we see the damage marking report for a medial femoral condyle requiring the twin implant. And then when we see the final result at surgery, there's the guide. We've mapped it up exactly. It sits in the right place, and we have the larger implant covering the defect. Rotation following surgery is essentially building up to full weight at 4 weeks. Free range of movement is allowed. There's no protection needed. And then strength work building once the pain and swelling is settled from about 8 weeks. And I tend to recommend avoiding impact activities, though we know some people have got back to running. Now if we can go through the results from this multi-center study, which is 80 consecutive patients in a series. And this was published in Castor, where you can see the final detail. It should be out very soon in published form. This was a prospective study with outcomes at 24 months in the group for focal defects, ICRS grade 3 or 4. It's a single lesion on the femoral condyle, on the trochlear or the femur, not on the patella, and intact cartilage on the tibia with normal leg axis, and we define this in less than 3 degrees out of alignment. We've collected data at 3, 6, 12, and 24 months, basing this on the Coos score and the visual analog score, and I acknowledge my co-authors in this work for this multi-center study. We have 75 in the particular study cohort. The 5 removed, 2 had revisions, 1 declined to be followed up, and 2 had incomplete data. So we have complete data on 75 of a consecutive series. You can see the demographics here with 59% female, mean age of 48, and you see the range from 27 to 69, and a BMI at 28. 65%, interestingly, have had previous treatment, and this is going to be a common indication for the episealer implant. Many following microfracture, and you see mosaicplasty, ACI, true fit plugs, and simple debridement before. On the right-hand side of the slide, we see where the implants have been placed. with 40 solo implants on the medial femoral condyle, 25 twin, and then 10 on the trochlear, which can either be the solo or the twin implant. Looking specifically at the results, this is the results in a nutshell, the whole group from the KOOS, the different domains of the KOOS, and the visual analog score. So on the left-hand side here, we see the different domains, and then over the time points at 3 months, 12 months, and 24 months with the pre-op scores down here. So you see a progression over time and an improvement for the pain, the symptoms, ADL, and then the sport scores and the quality of life scores. So this is reflected then in the visual analog score for pain, with the pre-op pain reducing at 3 months, 12 months, and 12 months. Sorry, and 24 months. So there is an improvement that is maintained over time in these results across the consecutive series. We tried in this series to look at whether there's any difference in the implant type between the solo, the twin, and trochlear, and essentially there is no significant difference. Now, this study was not powered to detect a difference in those groups, but it's important to know at this stage whether there is a difference. It may appear there's a trend that the trochlears actually do slightly better at 12 months, 24 months, but that is not significant. You can see that essentially all are improved. And the visual analog score, again, there is improvement over time in that pain that is maintained across the 3 different implants, the solo, the twin, or the trochlear. We looked at whether there was a difference with previous cartilage treatment. It does appear that there may be a difference in the primary cases, but this is not significant. And as we do more cases, you may understand that primary cases do indeed do better. But there is a range of patients who've had prior cartilage repair, and this hopefully is a very good option for those patients. So we will follow that out as time goes on. There are 2 patients that have had revisions. The first patient had an atypical lesion, and there was a lot of bone marrow edema preoperatively. There was no improvement after the implantation, and that patient went on to have a unicompartmental knee replacement at 15 months. The second patient had previous OAT surgery and was never really pain-free, and there were definite subchondral cysts. So a thicker implant was used, and again, there was no improvement, unfortunately, and at 19 months, that patient was revised then by bone grafting and application of a chondral guide membrane. That was one of my patients, and I know that after that, patients had a good result. We've had one case who had an infection, which was revised after this series at 27 months, and 2 have had arthroscopy for release of scar tissue and 1 for mechanical clicking. So from the study, the conclusions there is that this is an ongoing series. We know that there have been previous published results on this, and those results are variable and need to be improved on. This has been a select cohort analysis of 75 implants at 2 years, where we have shown there is a low failure rate, there is good clinical improvement, and that individualized design seems to produce a very accurate fit with the instrumentation that allows it to be placed in exactly the right position, and the depth and the location for that is easy to achieve. And that is helped by this damage report at the beginning that allows a surgeon to actually confirm what they're going to be doing. So the focus then in the future is to understand the exact optimal indications for this technique. So let me show you that technique. This is the left knee medial femoral condyle we're going to do, just excising an old scar. And for the approach, medial parapatellar, but then using a subvastus approach, which allows a wider field to enable insertion of the guide to place it in exactly the right place. So this is the subvastus approach. And then by inserting the appropriate instrumentation and the appropriate retractors we can then reveal the damaged area. It's important to define that. And on this side, there is a damage marking report that we can see and marry up to it. So this is the actual epi guide that is 3D printed and married up to the patient, and it sits amazingly well, exactly where we want it to go. It's very hard to then move it once it sits down, and it's held in place by 3 pins that are again provided in the kit that comes with it. So there's minimal extra kit. These 2 are in parallel, note, so that if we want to take the guide off, it can be slid over those 2 pins, removing the oblique one at the top right. Again, we're mapping out the area to know exactly that it has covered that area. So this is the first drill socket, and the sharp pointed drill is then used to create the starting hole. The drill has a sleeve on it, so we drill into the right depth at that point. And that's marked at the top so that we can get the orientation correct. So once that is removed, then we insert the adjustment socket, and this is inserted at the 0 point. And this is all worked out so that by that drill going, same drill going back in again, this should be down to the base exactly where we want it to be. So we've got the peg hole for the implant. Now we're taking the epi-dummy to see exactly where it's sitting. And the aim here is to get to about 0.5 millimeter below the articular surface. So I'm using the pin here, the reverse end, just to be able to feel. And if it's not right, if it's still flush or proud, then we use that same adjustment socket, turn it to a different number, and then drill again. Now they're marked in 2, 4, 6, so that's 0.2 of a mil, 0.4 of a mil. So it's very easy to then dial this down to exactly the right depth. You can use the arthroscope to see that the implant is at 0.5 millimeter below the joint surface. I've marked the top of the site, and there is a small indent on the actual implant and on that epi-dummy as well, so we can marry it up and see that it sits correct. Final check, making sure it's 0.5 millimeter below the joint surface, and then insertion of the actual implant using the epi-mandrel to gently impact it into place, noting that it will then be that 0.5 millimeter below the surface. And that completely then covers the defect according to the plan before through this mini approach. Closure is then, as a surgeon would like to do, with either staples to the skin or subcuticular sutures. This is the final check for the implant in place. Tourniquet can be released, and then closing the subvastus layer. So let's try and tie that all together. The indication, I think, now for focal resurfacing in 2021 is this list here. So it's a focal lesion. It's pain compatible with the MRI. The opposite surfaces we do not want to be too worn, so ICRS grade 2 or less. We do not want bare bone on the opposite surface. On the PA30 standing X-ray, no loss of joint space. The meniscus volume, yes, we still need good meniscus, so 50% or more as a guide without extrusion and failure of the meniscus. No deformities in the bone, clearly no erosions. Deep cystic formation, that's going to be difficult. You can get a thicker implant requested, but it needs to completely be supported on subchondral bone. Neutral alignment, or within 3 degrees as we defined in the study. Appropriate patient expectations, as always with implants like this, and not expecting them to go back to impact type activities. Acceptable BMI, non-smoking, sure, those are sensible indications, normal ligaments and no metabolic disorders. So I do draw your attention to the main website of episurf.com, which has more information about this and the published paper. And with that, I thank you for your attention, acknowledging all the co-authors in this study. Thank you.
Good afternoon, everybody. It's a great pleasure to be here in Cardiff for this 22nd BIOS meeting. I've been given the introducing Ashish Babhulkar, who certainly in India doesn't need any introduction. He's an old friend of mine who I've known for a number of years. He did do some training in UK and then went back to India. I mean, I can easily say that he's one of the doyens of shoulder surgery in India. He runs numerous courses. He's also the founder, president of the Shoulder and Elbow Society. If I start counting his accolades in shoulder surgery, we'll probably not finish the meeting. I'll probably just say a few things about his non-shoulder side of things, which not many people know. He's great in calisthenics, and he's good at 10-meter rifle, so beware. And he's also a ninja warrior. So with that, I give you Ashish Babhulkar. Thank you, Ashish. Good to see you. Yeah, Ashish, you're live now, please. He's frozen. Ashish, ready? Ashish, thank you. We are ready for you.
Hello. Hi. Good afternoon. So thank you very much, Amit and Bijayendra, for this opportunity. And Bijayendra and Harvinder, if you remember, this was the BIOS advertisement in Buenos Aires. So I had no idea National Geography was also transmitting BIOS. This is from 2019, and I've been waiting to be part of this since then. So for those who are not aware, this is where you are and this is where I am in Pune on the western parts of India. And today we'll talk about our proximal humerus fracture journey. Very brief snippets without didactic details that you all know as such. But this is an interesting study by Le Martina and from Frankel's unit. And they found out that if they were to discuss all the fractures that came through and send the x-rays to everybody and the CT scans in their unit, and they make an assessment for what surgery they would do, and then actually discuss what surgery was done, there was a unanimous agreement in only 63.5% patients. So there is no good argument, or no good agreement between even the topmost surgeons. But the interesting part of the feature was that amongst those who agreed, and if that surgery was carried out later for fracture fixation, those patients did the best overall. So it's good to have a consensus, but I doubt we'll have everybody agreeing on everything. So conservative treatment, I think Amarangan has done a huge task, mammoth task by putting in the Prof trial, and it has changed the outlook. It has improvised my practice as well, and we've been treating more conservative patients since then. What is important was the loop was closed by doing the impact of Prof trial, and they found out that it has positively changed the practice of 80% of the surgeons after the Prof study. What's important from the conservative part is that it's just not about immobilization and wait and watch and let nature do the healing. It's important to understand that only the patients who started their supervised rehab after day 14 did well in this Kenneth Kowal study from 1997. That's very important, and we practice this to the T in our unit as well. So this is, of course, a 78-year-old lady, and even she would do exceedingly well even after a 3-part proximal humerus fracture, and that GT looks amiss, but you can still give them a good function. So you don't have to be conservative about being conservative. In terms of lock plate, I seriously think it's slightly overdone. The plate at the end of the day is just a means. You still need the surgeon's technicalities to reduce the fracture and fix it in. Unfortunately, 21 to 27% screw penetration after the fracture heals is just not acceptable. It's a sad statistic that we have to wake up to. And I would also recommend that use a greater tuberosity suture, even if it's a 2-part fracture, because it's that anchor to prevent the progressive varus that could happen, especially if your calcar screws are suboptimal. So I like to use C-arm throughout, and I like to see my plate and screw fixation in all 3 planes. Just the AP plane is not enough. The 2 calcar screws, of course, you understand, are the most important ones. And then I have rarely ever used more than a 3-hole plate, very rare. And always be checked. I believe that the C-arm position behind the patient is unmatched in terms of its quality of picture. And you don't need to move the arm. The C-arm can do all the moving if necessary because it's unstable. And this should go on to healing quite satisfactorily. Now, people talk about augmenting fractures in difficult cases. I don't remember augmenting a fracture, a primary fracture. But those who come in as a non-union, like this top film that you see here, and it's a poor picture of fixation, I would definitely use. But it's not easy. It's a complex surgery. Firstly, it's non-union, revision surgery. The planes are not there, too much scarring. And a fibula may not go through into a shaft. So I usually use a split fibula to augment and ensure it's supporting the calcar side. That's important. So often an ICBG is not enough. You need a structural bone graft. In this case, we did an ICBG with a split fibula to ensure fracture union. And then the peak plates look sexy. I don't think there's much to choose between a lock plate and a peak plate, except for the fact that the chances of cold welding are not there with the peak plate. So that's the only probable advantage. But this is something that should not happen. This is a fracture patient, almost 60 years old guy, very fit person. He had a fracture fixation done. Now, technically, you look at it, you wouldn't follow it. He seems to have ticked all the right check boxes. That K-wire is floating. It's not doing anything to the lateral and clavicle. But that's 12th of April. And by the time it's June, that screw started penetrating. And this is the worst nightmare of a lock plate or a Philos plate. So the biggest bugbear is screw penetration. And if it is not removed and you just wait and watch and let things settle down by itself, 1 year later is going to damage that entire joint. And so we have a situation now that this was a fracture and has been fixed. It would have healed very nicely even without the fixation. But this is what it has ended up to. 1 year later, we've had to do a revision surgery and do a hemiarthroplasty for these. These are tough surgeries, and you can't do the same with both primary and revision surgeries, cannot be compared together. And if you look at them, we have made a significant difference to this gentleman, but even then it's still a revision surgery and it's not the same as primary surgery. So the biggest challenge is to get rid of pain. That's important. That's why we've done a total shoulder on this gentleman, not a hemiarthroplasty. And then the biggest achievement is to restore the rotations, and that may not happen because of scar tissue and stuff. So if you're able to restore rotations, then you're going to restore good function for this gentleman, because the sine qua non of ball and socket joint is freedom of axis. You should have a 3-plane movement in 6 degrees of freedom. And that is not always easy with a revision surgery. And then you have an odd patient who has had a screw fixation intra-articular, and that's just going to damage the entire glenoid. Luckily, we came across this girl within 6 weeks of a previous surgery, just not a happy bunny, and it was making a lot of crepitus and noise every time she moved, and we realized it was a fault. And we had a ginormous task of removing the screw arthroscopically. There are patients who occasionally need a replacement on one side and fixation on the other. Again, these are going to be tough to rehabilitate. We did a talk on this in the afternoon on the principles of rehabilitation. Let me dwell over this slide, because I know there are several who like to do a deltoid split approach, and I'm not a fan. You could call me orthodox, but I think the deltopectoral approach gives me an expansive approach, and I'm used to that. And I have not felt a need for doing any other approach. I can handle my gritty tuberosities very well from the deltoid. This was a very nice paper from Westphal, published in JCS Jan 2017. And they had done EMG studies in all their patients that they did deltoid split approaches. And these were 13 patients. More than half of them had nerve conduction changes, but 10% of them had permanent axial nerve injuries. And that's burnt all bridges. Once the axial nerve is gone, there's no salvage there. If it's a non-union, it's a poor union, you still have different means. So do be careful if you're going down that line where you're trying to use a deltoid split approach. Coming to replacement, hemiarthroplasties have got bad publicity, so they are not being done enough. I'm still a big fan of hemiarthroplasties, and but in a measured manner. And reverse shoulder replacement are probably going to change the whole situation, which is the new kid on the block. Split head, 4-part fracture. When I do a hemiarthroplasty, I want to see the GT sit in there in a robust manner. I do a transosseous repair, and we do a lot of stuff to ensure GT, but there's no obligation for the GT to remain there. And the biggest disaster would be for the GT to go into non-union or split off and fly away. And that's an all or none, because that's 0. So a few tips there. Number 1, always use a fracture stem, which is hydroxyapatite coated, has a friction fit. So the GT will want to remain there and help integrate it. Use copious amounts of bone graft from the head of humerus that has been extricated, and ensure that you use 2 different techniques. Number 1, Frankel's paper on cerclage wires has changed our practice. We've not lost a GT after that. And the sutures between the GT, LT, and shaft, we use the niece knot, which has made a hell of a difference. And touch wood, till date, we've not used. But previous to that, I've lost 3 greater tuberosities, and it's not a very pretty sight, because patients then have a very poor function. This is a very elderly 72-year-old diabetic gentleman, had a nasty fracture, Bose head, known osteoporosis and hypothyroid. We ended up deciding to do a reverse shoulder replacement using a fracture stem, and did exceedingly well. 2 months post-op, started rehab. He did very well, reached almost a good full range of movement. And 9 months later, had a road traffic accident on his bike, which he was driving, and he shattered everything. And that can be a disaster. Fortunately, the prosthesis was unaffected. We managed to retain the prosthesis. It was in place, uncemented prosthesis, so that was a big help. We put in a plate and use fiber tapes. So I've stopped using cerclage wires, so you don't want metal work in there. The fiber tapes come with a device to tighten the tapes nicely and work even far better than any cerclage wires. And he's done well. This is a 6-month-old video after the revision surgery, and you can see he's had a reasonably good range of movement. Luckily, because of the healing of greater tuberosity, we've managed to give him a significant rotation. To achieve rotations after a reverse shoulder replacement is not easy, may not happen, and that's why I counsel all my patients. But there are a few tips from my side. Number 1, that you should have a greater tuberosity union. Number 2, you should try and do a subscapular repair, which is probably possible if you can give back the native humeral version. I know there are several of you who put your prosthesis back in 0 and 10 degrees to facilitate internal rotation. We've switched 5 years back to giving native humeral version to all their patients. We've achieved a far superior range of movement, especially rotations. In the long term, I don't know, but I think this could be the future, but this is, I agree, a fairly controversial, and it's not universal as such. Before I finish my presentation, don't forget that there are other options as well, especially in a 59-year-old lady. You don't want to do a replacement, but she's osteoporotic. Then you could do something like this. This is a just unique. And as long as you can put your tuberosities back together, that's absolutely mandatory. Then this is being central to the axis will heal much better with the own native head. And this is her result after 2 years. And she's actually a yoga teacher, so it was very important for her. That's why she refused her hemiarthroplasty, saying that she needs to do all her yoga because that's her profession. So that's also possible. So in the end, the proximal humerus fracture funnel, I said, pre-op CT is a must because you should treat this as intra-articular fractures. I would always prefer a deltopectoral approach over a deltoid split approach, unless it's an isolated greater tuberosity fracture. When you reduce them, get the tuberosities in, ensure it stays in there firm and solid, and ensure that the calcar is back in this anatomical plane. Confirm all this in 3 different planes inside the operation theater. So if there's going to be any malpositioning, it should be apparent within the theater. You don't want the post-op X-ray on the second day to look funny. We have a great emphasis on rehab on all of these. Even the conservative patients, they undergo the PSRP program that we underlined in the morning session. And of course, if you are able to give them the rotations, pain-free and a rotator cuff strength, then you've achieved everything. We've moved on to the holographic assisted shoulder replacement for selective patients who need glenoid mapping. And that may be the new future, the new normal later. Thank you very much for your patient listening.
Thank you, Ashish, for a lovely presentation on fracture proximal humerus. I'm sure there's lots of questions, but I think I'd just like to thank you, and we're going to move on to the next session. So please stay with us, and I'm going to hand you over the session to Sunil Garg, who's going to do the session on terrible trial. Thank you.
Hello, everyone. Thank you, Amit and his team for this excellent organization. So we'll stay on the theme of trauma. So what we have is three eminent.
I don't think I can.
Can you hear us, Ashish? So we've got three eminent shoulder and elbow surgeons. We've got some cases which you see on a day-to-day basis in your trauma clinics and the management. So we'll try and make it interactive. So Ashish obviously needs no introduction now, as Bijay has kindly introduced him. I've also got in the panel with me Mr. Shantanu Shahane, who is a shoulder surgeon at Chesterfield and practices at Sheffield University Hospital as well. I've also got our president-elect, Mr. Amit Tolat, who practices as a shoulder, elbow, and hand surgeon at Medway Hospital in Kent. So we've got about 40 minutes to discuss cases from each of these three surgeons. So we'll kick off with Ashish, followed by Shantanu, followed by Amit. So we'll listen to their presentation, look at their cases, and then we can then ask them questions based on the cases they have and the queries we might have. So Ashish, over to you. I really love that the screen you have and you measuring the range of movement in the forward plane and the side plane. That's really good. And that lady who was doing yoga, I don't think I can do it with my normal shoulders as good as she was doing with her shoulder. So well done, man. Okay.
Thank you. Thank you.
I'll be switching the slides for you if that's okay.
Yeah, lovely. Sure. So as I said, there's this controversy about whether hemiarthroplasties are over, and there are several surgeons I know from Germany and France who would refuse to do a hemiarthroplasty. Can I have the next one? The reason for that was that the hemiarthroplasties don't do very well on the comparison studies against reverse shoulders. But you must understand, these are papers based on patients who are 70 and above. So we'll share a case regarding this. Go on, Sunil. Next one. So this is a 45-year-old lady, diabetic, politely plump, I would say. And then she's had this fracture. It's a fracture dislocation, a difficult one. Next click. The surgeon went in and did a half-hearted job and realized that this hasn't come through well. He spoke to his senior, and senior said, this is not on. And on the very 5th day post-op, they went in and did a monoblock hemi on this. So can we have the panel on this and tell us what went wrong? Sunil, hold on. Yeah, you can go on to the next slide, and then we can discuss with the panel.
So yeah, so the floor is open to discussion. So what went wrong here? So if I go back to the previous slide, if I go to Amit first, I think this is a 45-year-old lady with this, I think, fracture dislocation of the right shoulder. You can see several parts. The humeral head is lying under the coracoid. The greater tuberosity is off, the lesser tuberosity is off, the proximal humerus is in bits. And obviously they've tried to fix this, and you can still, and even after the hemiarthroplasty, you can't see the tuberosities aligned. What do you think?
Yeah, so thanks, Sunil. I think the first thing is that this has not been reduced properly. We have this constant problem in proximal humeral fractures where the plate sometimes is being asked to do too much. The first thing is that we needed to get this well reduced and properly fixed. And if that had taken place, then the second half wouldn't have happened. But after having now lost the plate, the failure of the fixation, the second part, which is proceeding to a monoblock prosthesis like this with zero tuberosity, no cuff, it's almost doomed to failure, really. It wouldn't have worked out. So I think that's where the problem started with the original surgery, I think, but the next steps taken were also inappropriate, leading to where she is.
I would say that, do you think that a further sort of investigation in form of a CT scan would actually help you decide whether this was a head which was salvageable by fixing it or not? So, but we obviously don't have that advantage, and maybe the decision was to be made on that CT scan. And but what are your thoughts, Shantanu, on this?
Yes, I agree completely. I personally, three-part fracture dislocation, which is what this may be, the lesser tuberosity may still be attached to the head, is verging on the unsalvageable. And then we need to see the physiological age. There's everything is wrong with this, Ashish. I don't know if this was the first post-operative check X-ray, because the humeral head either was never reduced or it was reduced and it has migrated again. I can't see the tuberosities. The hemi doesn't seem balanced. It is posteriorly subluxed on the glenoid. I can't see anything right in this, rather than saying what is wrong.
Shantanu, do you think, do you think we could have just revised the fixation and put another plate back in?
No, so I was doubtful.
The first failure.
Yeah, Ashish, I was doubtful even in the first time around whether this was a salvageable head. And therefore, to me, the answer here, after a 3D CT scan, would have been either a hemi or a reverse. But she's a bit young for reverse, I accept that. But I don't think this head is easily salvageable.
Yeah, I mean, Ashish, I think we've got to look at, obviously, the physiological age of the patient as well. Salvageability of the head in a dislocated scenario is, through a fixation, is going to be very poor. The outcomes of these are known to be riddled with AVN, secondary malunion, non-union, all kinds of problems. So I would probably have, again, gone for either a hemi or a reverse shoulder. I would have considered a reverse shoulder if the patient was physiologically a bit older than her years and she was overall a low demand patient, on the basis that this would be the best option for her to get the maximum out of her arm.
Ashish, do you think the X-ray you've shown us for the hemiarthroplasty, this is after a few weeks or months? Because I can see there's sclerosis around the greater tuberosities. Maybe it was not reduced when the hemiarthroplasty was performed. And actually, this was done elsewhere, Sunil. And if you look, the staples are still there. So the history we got was, she came to us 3 years later. And this was the 5th post-op X-ray. Okay. 5th day post-op. And so the staples are still there. It's just a poor execution. And knowing that she was 45, young diabetic. She's not physiologically very old, except for the comorbidity of diabetes. But as you said, the presence of fracture dislocation suggests as a high velocity injury. So the rotator cuff would have been involved there. Right, let's move on. Where it went wrong.
Move on. Yep. So then after 3 years, we were not left with any other choice because the GT was not salvageable. I find that I can salvage the GT if it has come within 4 to 6 weeks of the previous surgery or the injury. After 6 weeks, it can be very difficult to pull it back and fix it in there. So not a very happy option, but we had absolutely no choice. So I would be in a dilemma if she had come to me immediately after that hemi. But because she came out 3 years, I think everybody will agree that the reverse was in position here. Can we go to the next? Right, Sunil, you will have to click on the second video as well on the right side.
Yep.
So you can see on comparison, there when we saw her on day 1, she had absolutely worse than pseudo paralysis. Any chance you can get the right one moving? Just need to click on the right frame, the second right half of the
Yep,
screen.
we'll try.
Or just press next, it should work.
Yep.
Yeah.
Getting it now.
There you go. Yeah. So she is now till date 2-year post revision reverse shoulder replacement. You can see that she's not old, really speaking, but she has an active profession. She's a teacher at the school, and what has been alarming was she's just not able to lift her arm up to write on the chalkboard and stuff. So that has damaged her self-respect. But fortunately, even though late, we've done. She's 5 years after the original accident, but 2 years after the revision reverse. The problem with the reverse is the lack of rotations, especially if the tuberosity is not there, and we didn't have anything there to repair as such. So although her axial movements are reasonably good, we could offer her only this much on terms of rotation. She's fairly satisfied because she came from nowhere, so that wasn't too difficult. Next slide, please. Yeah.
Ashish, there's a very quick question from Mr. Khurana, one of our surgeons from Great Yarmouth, and he is asking that, did you get a chance to feed back the regional surgeon about what went wrong?
Actually, we're not in direct contact, but we gave a lengthy letter to her explaining the problems, and we did ask her to touch base with the previous surgeon, which she did, and she had several dialogues before she agreed for surgery to come to me. So he was in the loop, so indirectly he is aware of the problems, and I'm hoping that he read the letter that we gave her.
Thank you.
Yeah. So as I said, just last two slides here. Again, deltoid split was not the option. It had to be deltopectoral, certainly because it was a revision surgery. I do use the deltoid split for reverse shoulders frequently, but whenever it's an extensive approach, then I would always use deltopectoral. And sometimes we need to do a laparoscopo to give back their external rotations. But in revision surgeries, I don't think we have any control over the lat dorsi, which is usually scarred down. I think most of us will agree on that. Next slide. Thank you. That's done. I'm done on my side.
Lovely. Thanks a lot, Ashish. We've got 30 minutes now. So what we'll do is we'll come back to you, Ashish, after the other two talks, if that's okay.
Sure.
So
Sure.
Thank you very much. So if you can move on to Shantanu Shahane's slides. Shantanu's got an excellent case on double fracture of shoulder and elbow.
Sorry. No, clicker.
Sorry.
Oh, sorry. Sorry, Shantanu.
Give him the clicker.
Yeah.
Ladies and gentlemen, good afternoon. Thank you very much for the invite, Amit and the whole BIOS faculty. We have 5 or 7 minutes to just discuss an unusual case. This came quite recently. It is a scapular and elbow fracture in the same arm. I work at Chesterfield and Sheffield Children's Hospital, which is my pediatric shoulder and elbow practice. I do some work for the University of Sheffield. And recently, for my sins, I'm a medical director of our One Health group in Sheffield. This is a 58-year-old lady who suffered a fall down a stair, simple injury, but very high velocity, a few steps down. And she sustained, which is quite an unusual fracture. I haven't seen this quite commonly. It's an extra-articular scapular neck fracture, which was completely displaced. And the terrible triad injury of the elbow, we see it quite commonly. And therefore, I thought this will be a good discussion topic for this sort of session. She was intact neurovascularly, and the elbow was reduced, following which the x-rays were taken. Back slab applied, patient was then presented in the trauma meeting next morning. The question here comes, how do we proceed with future management? So this was the initial x-ray of presentation, which was slightly confusing because I thought you could see the glenoid nicely, but then there was obviously a large double shadow in the front. And as I said, this is not the common fracture pattern that we see in this. And the elbow post-reduction showed what appears to be a fairly large glenoid fracture on the, fairly large coronoid fragment in the front and a comminuted radial head fracture. So the question then came, how do we start managing? How do we prioritize? And I'll come back to the learning points at the end. Before it was shown to me, she had a 2D CT scan. And again, you can see a very large coronoid fracture and the radial head, which seems multiply comminuted. I am a real fan of 3D CT scans. This is a separate patient. The other patient did not have a 3D CT scan because there was an urgency to fix it, and we had a slot. But the 3D CT scan has transformed our management. So this is a different patient in which you can see how the radial neck is fractured, but the radial head is intact. And it gives a really good idea as you turn the images around. So to me, 3D CT scanning has now become quite imperative. Going back to the previous patient, we obviously did the procedure in staged fashion, and we did a radial head replacement. And I'm showing you the final x-ray, and I'll come back to the learning points later. If a radial head is in more than 3 pieces, in my hands, it is unsalvageable. With 3 pieces, sometimes you struggle. And with 2 pieces and a radial neck, you can just about do it. This one was not salvageable. To me, initially, a radial head replacement in younger patients was a taboo. It is not anymore now. I have really no lower limit. If it is not salvageable, I try not to do a bad fixation. It is better to do a radial head replacement. The reason I show this slide is because 2 screw fixation of the coronoid is quite rare. And this was such a large fragment, we actually got a fantastic hold with 2 screws. And the final point in this is, nearly always the LUCL is avulsed from the humerus. And if you can isolate it and do it fairly early, you can primarily repair it. If it is not repairable, I will give you examples of what we can do later. So this came quite nicely. You can see a little drop sign. You can see a little bit of a gap between the humerus and the coronoid. And this is the drop sign. I do not worry about it at all because as soon as the patient wakes up and the brachialis starts contracting, the drop sign corrects itself. It's important not to stuff the radial head too large or too big. This is not the projection. It looks like this. I'm very careful to keep it more floppy rather than too overstuffed. Next was this. This was an interesting problem. And as you can see, the 3D CT scan tells you a very substantial injury. The entire scapular neck has been fractured and with an intact glenoid cartilage has been translated anteriorly. I can't remember many examples of such complete displacement. So in this case, we did that rare approach, posterior approach to the shoulder. I don't know if my pointer is showing to you, but this is the arm going this side and the head is on this side. The patient is in a sort of a semi-prone position, and you can see the stay sutures on the posterior deltoid, which have been removed from the back of the scapular spine. The second approach shows an infraspinatus, which is a very bulky muscle. Second to subscap, this is the largest cuff muscle. And between infraspinatus and teres minor, you can find a nice plane. Suprascapular nerve is here, axillary nerve is somewhere there. Once you find that plane, the procedure actually becomes quite easy. I'm just going to show you this video, which shows the deltoid nicely reflected with a nice flap posteriorly, and this is the infraspinatus. Be very careful that fat raphe you see in infraspinatus is not the gap between infraspinatus and teres minor. The gap is quite lower down as it's a multi-pennate muscle, the infraspinatus. And once you have found it, the procedure is very easy. We harvested and found the glenoid lying anteriorly. And it was quite hard work to relocate it back. And personally, I use the Acumed contour plates, which are fantastic because it gives us a lot of hold proximally and a few distally. And this is the post-op X-ray. This patient's only 4 months down the line, and I'm hoping to get a CT scan done later to see it was okay. So the terrible triad of the elbow, we are all aware of it, a dislocated elbow, fractured coronoid, and a radial head fracture. And just to mention it, and I'm sure all of you know this, we don't need to say this more, but the sequence of events is to reduce the elbow urgently, assess the stability, and fix the coronoid if required, and I'll come to that later in the learning points. And all of us are aware of the Mason classification. That still remains my way of treating a radial head fracture. The coronoid classification has changed, which I will come to now. When I became a consultant 20 years ago, Regan and Mori was my classification. And I still teach this to the students because in FRCS, this is what is asked. You have a flake of bone anteriorly, which may be fixable or may not, in which case you take a capsular stitch. Type 2 and type 3, they are large fragments, you can fix them. Very, very rarely do I need a specialized coronoid plate, and it's only in a posteromedial rotatory instability where you need that, but otherwise screw fixation is quite good. This is just a quick off slide. This is a separate fixation. I have completely gone off radial plate fixations. So if I can salvage the radial head and neck, I do a teapot fixation. I do a teapot fixation in which the 2 fragments of the radial head can be fixed with the neck, and the 2 fragments of the radial head can be fixed with each other with a headless screw. And I'm very, very pleased with this outcome. I cannot last remember when I put a neck on the radial head plate. It is a problem, and we'll discuss that later. And this is another case just to show that if the screws are too small, then you can use anchors in the coronoid, and you can have a capsular stitch go through it and provide stability. So this is just going slightly off tangent. I think we are all aware of this. The only reason I put it is the outside circle is the ulnohumeral joint, anterior band of MCL, and LUCL, which are the primary stabilizers. And inside is the radiohumeral joint, common extensors, and common flexors. In the outside circle, if you see the ulnohumeral joint, LUCL, and anterior band of MCL, 2 of the 3 have to be restored normally. If you restore 2 normally, the third often heals. And invariably, because the approach is often lateral, I try and restore the ulnar-humeral joint and the lateral ulnar collateral ligament, and the MCL heals nicely in a cast brace. I have not had a problem with MCL non-union or needing it reconstructing many times. So the last 3 slides, what are the general learning points? Firstly, it's a staged fixation. I did elbow first here because in trying to fix the scapula first, I may have made the elbow unstable. So I did the elbow first, and over a couple of days later, we did the scapula fixation. As I have mentioned before, 3D scanning is very useful. And I strongly believe that these surgeries are left best in the hands of people who do this more frequently in daylight hours. This is not something to be undertaken late in the night and by a non-specialist surgeon. What are the elbow learning points? As I have mentioned before, radial head fractures are fixable only if the radial head is in 3 or less pieces. I have already mentioned the radial neck fractures. I don't fix it with a plate because I just think finding that little spot, which is the non-articulating area, is not easy. Patients get crepitus, and invariably in my hands, it becomes a 2-stage operation. Fix it. When it heals, take the radial head plate out and then do an arthrolysis. So it's either my deficit, but I have found problems over years. And finally, some kind of coronoid fixation always is needed. That may be a capsular stitch or a screw fixation or a plate. I don't use Regan-Murray classification. O'Driscoll has classified, which is too complicated for me, but I use the Wrightington classification, which is fantastic. It's a 3-column classification, and that has again transformed my management. It's not appropriate for this meeting, but I would recommend that we read that to manage coronoids. And if I can't repair the LUCL primarily, I always have LARS on the shelf, which is the polyester artificial ligament reconstruction. It's a fantastic stable fixation, and it can allow early mobilization. And finally, the shoulder learning points. Please be familiar with posterior approach amongst the shoulder surgeons amongst us. And the important thing is to be aware of the neurovascular planes and the structures. I never use self-retaining retractors deep inside. That's the single biggest recipe for neuropraxia. Even if the scapular neck is displaced anteriorly, there is very little plate due to the presence of subscap to put a plate anteriorly. Therefore, we approach posteriorly, and once you reach through the gap, I think fixation is quite easy. And I always use pre-contoured plates. A recon plate or a DCP is not appropriate for scapular fixation. And as Ashish has already said, I think a very diligent, specialized therapy input post-operatively is absolutely mandatory. We've had a very difficult year. I don't want us to see these pictures of ventilators and compressed air and the masks anymore. And we hope we are moving into a nice, pleasant world. And we hope that in BIOS we all meet face-to-face next time. Thank you very much.
Thank you, Shantanu. That was brilliant. We've got a couple of minutes for some questions. I just want to start off asking you about what you already touched on briefly. So scapular fractures are generally treated if they are well aligned conservatively, but obviously in this kind of fracture where the neck was anteriorly displaced significantly, almost off-ended, you obviously chose to fix it. In most of the DGHs, the shoulder surgeons like myself are not very au fait with the posterior approach to the shoulder. What's the window of opportunity you have to fix these fractures, and do you think we have enough time to refer them to tertiary center in lines with GIRFT?
Yeah. So thank you, Sunil. That's a useful question. In this case, the window of opportunity was not great because the scapular neck had moved anteriorly, but the humeral head had stayed back. So it was actually rubbing on the raw exposed neck. So I thought initially the whole humeral head had moved with the scapular neck, but it wasn't. And therefore, there was a reasonable urgency, but then it was complicated further by a very unstable elbow. So, and I didn't think an elbow terrible triad fixation and scapular neck fixation in one stage was appropriate. The positioning, the whole length of operation, the anesthetic was a problem. So we did both of those within 72 hours. Getting it right first time, you talked about GIRFT, and I think if you're familiar with the approach, I don't see any distinction between a teaching hospital or a DGH. And at some stage, we have to do it first time round. And I think we touched on it earlier. I think this may be an occasion for 2 surgeons operating, and I think you need 2 colleagues who know what's going on to do it together.
And with regards to the elbow case, what's your, for those the trainees join us, what's your approach for the lateral, so for fixation of your coronoid and for the repair of the lateral collateral ligament and radial head?
So when I started, I used to use a Cocker's approach, and I think the Cocker approach is just too posterior for radial head and I used to struggle with the anterior exposure. And Kaplan approach, which is the approach I use for posterior intraosseous nerve decompression, is just too dangerous an approach, and I just don't want to see a single wrist drop after my this thing. So I have now modified this, and it is now written up, well established, the EDC split approach. Yeah. So it is between the Kaplan and the Coccus approach. It is fantastic. And it irks you when you go in and you see a nice healthy muscle and you split it when you think you can just go above or below and have a proper plane, but split the EDC and go through it, you will have a very good protective envelope anteriorly for the pin nerve, and you will not be bad enough posteriorly for a Coccus approach where you're continuously retracting. So EDC split is my approach, and that is very useful because when I do arthrolysis of the elbow, which is the same EDC split approach which continues onto the column, onto the lateral humerus. So I come straight down from the lateral humerus, EDC split, and reflect the whole fascia from arm to the forearm as one. Replacing it is beautiful. So it gives me perfect approach between radial head, LUCL reconstruction, and coronoid.
Yeah, thank you. That's, unless there are more questions from the panel, I think we'll...
Yeah, I'll just ask one more question. What do you think, Shantanu, is the incidence of medial collateral ligament injury in these injuries? Because I believe it's a bit of an overhype, yes, and you don't see so many of them, particularly if you've got a coronoid fracture, which is the type 3 basin, where it's lifted off. Yeah. Then you start thinking whether the medial collateral ligament has also been lost, and would you assess that on table?
Yeah, so I always assess and do an EUA post everything fixate. But after everything has been fixed, the problem with assessing neurovascular, the stability status with the patient asleep is a bit tricky. I showed you the drop sign. The drop sign nearly always vanishes when the patient wakes up because the brachialis works. In 20 years, I have done 3 or 4 medial collateral ligament reconstructions. And they have always been delayed reconstructions where I just think that's not right. But it's just a rare problem. In America, it is a bit overhyped because of baseball pitchers and the MCL is so commonly repaired by them. So I don't think we have a major problem. Okay. I don't think. Thank you.
There's a question from David Plain on the chat with regards to the internal joint stabilizer.
Say that again.
Yeah. So there's a question about do you have any experience of using the elbow internal joint stabilizer in these cases?
No. So I have seen people use it. I have not. The only comment I would make is an external fixator of this. So when I initially started at, I never used to do terrible triad without an X-fix on the shelf. I have never used an external fixator. Internal stabilizer is a different ballgame altogether. I have no experience in that. But just to mention that if you do a proper internal fixation and repair the capsular and soft tissue structures, very, very rarely will you need an external fixator.
Thank you. Last question before we move on to Amit is, when you are fixing the elbows, is your patient supine with the arm out, or are you lateral?
No, always supine with arm out.
Okay, lovely. Thank you, Shantanu. Thanks very much. Right, let's move on to Mr. Tolet, who will give us a treat on another excellent case. Thank you, Amit.
Thank you. Thank you, Sunil. And thank you for your very generous introduction. So I'm going to show you this case, which is not an uncommon presentation. There's a 52-year-old man who's a well-controlled diabetic who fell from a height. And we all agree that this is a TY fracture of the distal humerus. There may be a slightly greater degree of metadiaphyseal comminution, but this is an unstable injury, and one would just go ahead and fix this, right? So there we are. He had a fixation. I don't think one can knock that back to any great extent. One has good distal screws, a plate which bridges both medially on a pre-contoured, of a pre-contoured type, and then a posterolateral pre-contoured plate. You got satisfactory reduction and fixation, and all seemed to be well until 3 months later he came and the posterior pre-contoured locking plate has failed through the vacant hole. He was in quite a lot of pain and discomfort at that point of time, and there are various thoughts that cross as to what are the next steps, and I think most of them we decide that this is probably the best option. Revision surgery with a long LCP and bone grafting. And again, you can see that the reduction of the fracture remains satisfactory. The plates have been revised, and all seemed well for a little while until he comes back 1 month after this, and there is a plate breakage. Now the posterior plate has again fractured, and on the medial side, the screws have sheared off, and you have this big problem of the diaphyseal non-union. I think the rest of it all looks good, and the intercondylar part looks to be well healed. So I think when you're faced with this situation, you probably start thinking, what am I going to do? And I would like to put forward some thoughts that might cross at this stage. I'm very happy for the faculty to add to that. So the first thing is whether the stiffness and stability of the construct was not sufficient for this type of fracture which extends into the shaft. One has to remember that titanium, which are what all these pre-contoured plates are made of, have a low modulus of elasticity, something like 20 compared to stainless steel or cobalt chromium, which is 100. And you do get a stress concentration factor of a vacant hole in a thin plate. The second thing is, at this point of time, should we rather be treating this as a shaft fracture in non-union? And then one should look at, are there any other patient factors that need addressing? I mean, there are two major causes of failure, biomechanical failure or failure of fixation, and the second is osteogenic potential. Is this a poor osteogenic potential? Should the patient have been braced? Is there a low-grade infection? The patient was diabetic but in good control. So there wasn't any other issues really with this man. And I think the main problem was that the stability of the construct was not sufficient for what was essentially a very comminuted diaphyseal extension of a TY fracture. And then finally, he had a LC-DCP applied and bone grafted, and the man went on to heal. And he is fine. At 9 months, 10 months post-second revision, he's had a full consolidation, and there is no issue with his function. So I think one of the things that we need to remember with these sort of implants that we use is that those which are made from titanium could be potentially at a greater risk of failure if we are not able to stiffen the construct adequately. There is also an issue of a vacant screw hole. It creates a stress riser. I was interested in reading some biomechanics on this, and there is something called Peterson's stress concentration factor, which basically means that if you've got a vacant screw hole, it increases the stress by a factor of 3. The other interesting biomechanical point here is that the stiffness of a plate is directly proportional to the thickness raised to the power of 3. So if a plate was made slightly more thicker, one would probably increase the stiffness of the construct quite significantly. Vacant screw holes adjacent to a fracture site do increase this risk, and there were a few in this case in the first and second fixation. And then one has to remember that the bending forces at the elbow in flexion and varus are often extremely high, and they may not be possible to control by less stiff plates. The recent studies do show better biomechanics if you place them medially and laterally rather than at a 90-degree construct, which is what we do. But the jury is out there. I don't think there is clear-cut evidence. I think for the younger members of this online audience and elsewhere, perhaps it's important to bear in mind that TY fractures of the elbow, you have to follow that cookbook recipe. If you don't follow the steps, you're not going to get there. And the first part is obviously reducing the articular fracture and fixing it in such a way that it does not interfere with your provisional plate, which is fixation, which is the second step. After that, you're going to put in a screw in the lateral side, which is in a slotted hole, and that will allow you to move it up or down a bit, and then you compress the pillar across with a clamp. You need to have a good number of screws in the distal fragment, and one would recommend that you put 2 screws on either side, which are long bridging screws. The next part is obviously the medial plate, and you construct that again by placing the pre-contoured plate and putting a number of locking and non-locking screws. I think a couple of tips. You must put 4 good distal screws. They do not need to be locking because the purpose of this is to provide compression. You may run these screws across the articular components separately, but they're much more effective when put through the plates themselves. The second one is that you should try and use a home run screw, yeah? And in this particular case on the right, there is no home run screw. You can see that the screw is very short, the plate's not holding too well on the medial side, and it should have really had a long distal screw over there. There are problems with the approach as well. The transolecranon is perhaps the favored approach. I generally do favor that, but I'm just going to show a few slides on this issue because a lot of people use different approaches for this, and at the end of the day, the old proverb, you can skin a cat in different ways, and a pride of elephants has different shapes. So just in brief, you have the triceps tongue, Van Gorder, you have the paratricipital, you have the triceps reflection from medial to lateral, the classical Mori, or the lateral to medial, which was described by Deakin and Deshmukh. And then you have the olecranon osteotomy, the intraarticular and the extraarticular. But the intraarticular is the common one, and that's what I prefer to use, and a number of people do because of the huge exposure it provides to the intercondylar element. Finally, there's a tricep split and a trap approach, which is also, I would say, a limited exposure, and the paraolecranon, which gives you a wider exposure, but splitting the triceps. So I think the gold standard is an olecranon osteotomy, and if you want to reduce your problems with that, perhaps the best thing to do is to use a osteotomy cutting jig. I tend to use this because this is far more effective than cutting it freehand. You can take your cut through a chevron, which is distally angled, and go 1/3 through this, and then after that remove the jig. You've already pre-drilled your screw holes, and then you complete the osteotomy with a thin-bladed osteotome to avoid damage. So what about the effective surgical approaches on the functional outcome of open reduction, internal fixation, or intra-articular distal fractures? This paper is quite an interesting one. There were some increased risks with olecranon osteotomy, but there's really no difference between the various surgical approaches. So you can use what is appropriate in your hands and is safe in your hands, but I would probably suggest the olecranon osteotomy is a good way ahead. Thank you very much.
Thank you, Amit. Very quickly, in terms of the panelists, Ashish, do you use, what sort of approach do you use for the TY fractures of elbow? Do you use olecranon osteotomy, or do you prefer something else?
If it's a type B or type C, I go for the olecranon osteotomy. It works best because I can mobilize my patient quickly, and that works faster. If it's a type A, then I might consider a triceps on approach and work through the gutter, medial or lateral.
And do you also subscribe to the philosophy of filling in every hole in the plate, as has been suggested? Do you think that could be a stress riser? Because I personally saw there were 3 good screws, I think, around that hole, and I personally would have not minded leaving that alone, to be honest.
I don't know. I'm freaked out since Amit has shown this case. I have not had that experience, and I don't fill in too many screws. But it's important to have 3 screws in the proximal fragment on both columns, I think. And as Amit showed, the 2 screws on both columns going distally. I have never had a problem with leaving holes open, but I'm sure there's some other issue there with delayed fracture. If fracture even is delayed, your mobilization is going to put in a lot of bending forces and create problems.
Thank you. Shantanu, what do you think about the
So it's interesting. I subscribe. It may be laughable, but I subscribe to the theory. If there is a hole, there is a reason for it, and it needs to be filled. And I totally agree that I think if you have an ability to fix it, you are creating a stiff construct. That's the purpose of it, so as to allow early mobilization. Now, whether that's responsible for this failure, it's an unusual failure because the first X-ray didn't look bad at all. So I would have been reasonably happy with it. But yes, if there is a hole in it, it needs to be filled. Why not? I would say why not?
Yes.
Yeah. Sorry, Vijay.
My hole is an opportunity, not a necessity to be screwed. One of the reasons what I found, having had a couple of these along, is if you go back on the X-rays, there is a lateral comminution. And what I've noticed is that if there is a lateral comminution, then that is something that will make it fail more readily than if there is no lateral comminution. And I often wonder, by putting that many sort of 3 in proximal on each side and 4 distally, whether we're making the construct too stiff.
Thank you. With those words of wisdom, I think we will put this session to close. Thank you, Amit. Thank you, Ashish. Thank you, Shantanu. And thank you, BIOS, again, for putting up this excellent session. And we're very grateful. I hope you all have a lovely afternoon. Thank you.
Thank you.
We're all breaking for tea and coffee now. And so please do hydrate yourselves, and we'll be back soon for the next session.
Exhibitors.
Please do not forget going on to the exhibitors section online. The exhibitors have been extremely generous in sponsoring this conference. And as you know, without their support, we would not be able to run conferences like this and increase the educational profile of orthopedics. Thank you.
All right, so I think a lot of folks are interested to see how people actually do what they do. And it's fun to kind of keep track of all the different tips and little tricks that we all use. So these are the opinions of the presenters, not Bioventus, just in case anyone was curious. So for me, you know, the workhorse injection technique that I use is either using the interlateral or anterior medial approach. My cocktail that I use for steroids is this. So I use 10 cc's, 1 cc of Kenalog, 5 cc's of bupivacaine, and 4 cc's of lidocaine. So there's no mystery. I'm in the joint. There's no mystery that the patient got an injection. We're all on the same page. So I'll use a 1.5 inch needle, 22 gauge needle, 1.5 inch long. I don't necessarily raise the lidocaine wheel. Some people will. Where you inject, they'll take a 25 cc or 25 gauge needle and inject a little lidocaine wheel before they inject. I typically will just use ethyl chloride spray. I've got a gauze, a Band-Aid, and then I'll prep. Remember, ethyl chloride in general is not sterile, okay? So if you're going to spray that at the end, theoretically you violated your sterility. So I typically will spray first, then do a betadine swab, and then I'll kind of cheat. I'll take an alcohol pad. I got a little trick where I'll take the alcohol pad, palpate one more time, make sure I'm happy where I am, and I won't have sterile gloves, and I'll palpate using the alcohol pad so that I haven't violated my sterility, and I can kind of wipe away the betadine and then inject. So that's kind of a little trick that I learned a while back. So the literature really looked at this, and there's pluses and minuses with all the approaches that are out there. So if you look on the right, those are the interlateral and intermedial approaches to doing knee injections. So what I do is I'll find the inferior pole of the patella, and I'll go on either side of that, okay? And then you'll feel a soft spot, and you can kind of feel it on your knees. But the key here is finding the inferior pole of the patella. And for the residents, family medicine residents, and folks that are learning for the first time, I'll have them draw a little line right at the inferior pole of patella so that they can visually see it. And then they go on either side of that, make a little mark with the end of your pen, and then that's their target. And then you inject, again, aiming for the center of the knee, aiming for the notch, not straight because you'll hit the condyle, right? Not up, not down, parallel to the floor. The other most common route is using the suprapatellar approach. So you can see that picture on the left there. So this is done with the patient laying supine. And then we all have kind of little tips and tricks. And I think Dr. Redlow will give you his trick on doing that. This is a little more challenging. Even my orthopedic residents struggle with this a little bit in terms of injecting and making sure in the joint. And this can be painful because if you miss, patients are not happy. So you just got to be a little careful with this. But the trade-off is there's a higher chance you're in the joint. So the research shows if you go with the inframedial or infralateral portal using radiographs and dye, what they found was about a 20 to 25% miss rate when you went from the front. Okay? If you did it supine, superlateral, okay, the miss rate went to about 5 to 10%. So that was the Jackson study that was there. So the pros in terms of having them sit and go from the front, it's faster, easier, a little less painful. However, it's less accurate, right? So there's a give and take. So that's My preference oftentimes is with that because it's just very efficient and is a lot easier, especially if you got grandma, then you got to lay her on the table, you got to do this whole 10-minute thing, versus the supratellar approach, more accurate, but like I said, the cons are a little longer, more painful, and technically a little more challenging. And that's usually the approach I'll use for aspiration plus injection, because usually the knee's pretty blown up, so I'll stick a needle in there, aspirate, unscrew, and you'll see a little trick with Dr. Redler on how to do that. So like I said, identify the landmarks. I make a mark, spray, betadine, alcohol pad, insert the needle, and then for the supratellar approach, if you're aspirating, unscrew it, and then screw on the new syringe, and then go ahead and inject. Mike?
Well, thanks. I said to Dr. Das this morning, I said, we're two colleagues. We weren't going to go through a point-counterpoint type thing there because there's not a right or wrong answer. But I think that what you want, frankly, is the opportunity to have some different alternatives in how to do injection. Because, look, if you have a very thin patient without joint effusion, I would suggest that no matter what technique you can do, you're going to get into the joint and you're going to do very, very well. Frankly, the challenging patient is the larger, either the obese patient, frankly, sometimes the very muscular patient, and there it becomes very, very important, because I will tell you that my experience has been the viscosupplementation injections are well tolerated as long as, and it seems like a simple thought, as long as you actually get into the knee. And I had a patient years ago who was a tough factory worker guy. He's one of those guys, he comes in, he's got the motorcycle boots, he's got the chains hanging down there, he's got a lot of artwork, a few piercings, and he's a pretty tough guy. And he had significant arthritis of his knee, and actually one of our physician's assistants that day was actually going to be doing an injection of one of the viscosupplementations for his knee. And this PA was a wonderful guy, but I think that day he missed the joint. And this guy who, was pretty sure he could, bite off a barbed wire fence without difficulty, came out sniffering and with tears coming down his eye because he was in such significant pain. And, and it turns out he may not have been quite as tough as he laid himself out to be. But the bottom line is, it's a thick, viscous material. If it's not in the joint, it does hurt. So getting into the joint becomes really important, which leads me up to the two-syringe technique. All right, so here we're doing a little video there. This is the lateral suprapatellar position, betadine. And we use the superior lateral parapatellar portal as being the most accurate and comfortable. So we essentially have a 3cc syringe with a 22 gauge needle, drop a cc and a half of air, palpate where the patella is to make sure that we're in alignment, go into position here, and if there is, in soft tissue, there's resistance, but as soon as we're in, there's no resistance whatsoever. So then we keep that needle in place. Leave the needle in place. We take the viscosupplementation, and if need be, and if the office allows, you can also confirm that with ultrasound control. But we also now know, because of the fact that we are in the knee, because of the two-syringe technique, the injection is done without difficulty. And we don't numb it up because the placement is so quick and accurate. Thanks. Okay, so bottom line is the whole concept of this technique, of the two-syringe technique, is we're borrowing a thought pattern that was used by, I think, anesthesiologists that are doing like epidural type of injections. So I take a 3cc syringe with a 22 gauge needle. And the 22 gauge needle is perfectly fine. And Durolane, even with its cross-linking and based on its volume size, injects very easily into a 22 gauge syringe. I have the patient lay down. I will palpate the patella because I want to make certain that the medial and lateral portions of the patella essentially are parallel to the ground. I ask the patient to point their foot up towards the ceiling, which will help with that, but at the same time relax their muscles. I prep with betadine. I don't use any lidocaine at all because doing this technique is so comfortable. I don't use any ethyl chloride. Again, for the reasons that Dr. Das talked about, is the fact that it's not sterile. And it's a real simple technique. You've got 1.5 cc of air in the syringe. Once you go in, you're going parallel and just superior to the patella. If you are in fat tissue, there's resistance. If you're up against the fascia of the muscle, there's resistance. If you're up against the muscle, there's resistance. If you're up against the capsule of the knee joint, there's resistance. The second that you are into the knee joint, there's absolutely no resistance. You can just plunge forward with a little bit of air. And once you have that, you're in. There's no debate. You then, as I said, you hold that syringe and needle in place. And here's the injection there. Grab it with a syringe, or I'm sorry, with a hemostat so that needle stays in place. Take the Durolane. And again, you know, the ultrasound issue, you know, and in some offices done, some offices don't have ultrasound. You know, frankly, for some offices, the coding is different for the injection if there is ultrasound. But with this technique, even in the largest of patients, you know you're in because everything else has resistance. Once you're in the joint, there's no resistance. Clamp the needle, hold it, inject the Durolane. And you saw the video. Literally, I wanted to show a quick video, and so I was doing, you know, a month or so ago, patient came in, and I had the X-ray tech. I handed her my iPhone. And so what you saw was real time, except it actually probably took a little longer because I was talking during it there as well. So that's as long as it takes. And that patient, actually, you saw that left knee quiver just a little. They're perfectly comfortable, and they walk away saying, oh my gosh, I've heard such horrible things about these injections. That was nothing. You place it into the joint. All right, so that's the 2 syringe technique.
can imagine a world where I can be connected with a patient, I'm in Oregon and they're in New Jersey, I can know through cloud-based information, biometrically what's been happening to them, help me to understand their problem better, well, now you're talking about the future of orthopedics. The problem that we have now is, frankly, not a lot of us know what to do with the data once we collect it. So it's great that we're collecting it, but it's not pushing anything really forward.
If it could just do all the busy work of taking all those data points out of that chart and putting them on a page in front of me that made sense, that would be great. Who knows the amount of problems we could see and solve by having better data solutions.
And that's where ZB Edge comes in.
One of the really powerful things about ZB Edge is it is an ecosystem. It's ever improving and ever growing. The combination of Rose and my mobility data, I'll be able to have an artificial intelligence recommendation from our previous history to give the patient their best possible outcome.
I think as technology has progressed, we can use that information to help the patients.
It addresses the entire range of communication.
And it empowers the surgeon to be able to focus on the patient in front of them.
You watch somebody go from being in pain and then seeing them out of pain and seeing that weight lifted from them, man, you just can't put a price on that.
Zimmer Biomet is writing the future of orthopedic technology.
The journey to becoming an orthopedic surgeon takes drive, dedication, and a relentless focus on excellence.
It's been filled with education, residency, fellowship, and building my practice.
Now, my days are filled. I need a way to stay connected to why I do this.
It's always been about helping patients change their lives. They come to me, scared their pain will keep them from living a full life. They come unsure about their possibilities and anxious about their future.
They come with a championship career on the line. I need something that engages my patients at the beginning of their surgical journey and supports us each step of the way.
Something that delivers an experience outside the operating room that matches the excellence we deliver inside it.
Something that keeps my patients engaged in their care and allows my team to track their progress each step of the way. Something that keeps my patients informed, giving them the right information at just the right time.
I need something that lets me keep a personal connection with my patients, no matter where they are. Something that's with them when they go home, preparing and encouraging them for what's next. A tool that makes following up easy and efficient.
Something that makes their exercise plan convenient. And their day-to-day progress measurable. It should make tracking outcomes easy.
I need something that identifies patients who need extra help and asks standard follow-up questions so my team doesn't have to.
Something that can integrate data from other technologies to help me up my game. And it should be one platform, because I need technology that works for me instead of me for it.
So I can focus where I need to focus, while knowing my patients will get the best care experience possible, whether they live down the road
or in a different time zone. Something that delivers an experience and connection that helps us hold on to why we do what we do.
Good afternoon and very welcome to this afternoon session for primary total hip replacement. What can go wrong? Joining me on the days are Mr. Sanjeev Agrawal, Consultant Orthopedic Surgeon at the Landock and University Hospital of Wales. And on my right here, Mr. Shaival Dalal, one of our senior trainees. Joining me on the panel internationally, we have got Jonathan Howell, Consultant Orthopedic Surgeon at the Princess Elizabeth Orthopedic Hospital in Exeter. Jonathan trained in London, followed by a stint in Royal Air Force, and his orthopedic training was in the Southwest, Vancouver, and then Exeter. Jonathan has been the president of British Hip Society and is the executive member since 2011. Joining me from India is Mr. Vijay Bose. Vijay is a senior orthopedic consultant and joint director at the Asian Joint Reconstruction Institute at the SRM Institute of Medical Sciences, Chennai. Vijay had done his higher orthopedic training in the UK, gaining his FRCS Orth and MCH Orth from Liverpool, and he is also been the vice chair of the Indian Arthroplasty Association. Joining me from further north in the UK is Ananda Nanu. Ananda is an orthopedic consultant at Sunderland. He trained in the Northeast and Liverpool, getting his MCH Orth and FRCS Orth. He leads the pelvic and acetabular reconstruction service in Sunderland. And he is one of the few people across the world who is still doing hip resurfacing. He's widely published and has a chapter in Oxford textbook of orthopedics. He was still recently the president of British Orthopaedic Association. So welcome all. We have a wonderful panel, and I'm sure we'll have a very stimulating discussion this afternoon. What can go wrong? So what we thought was we'll find out from the trainees' perspective what they worry about the most, what can go wrong. And we have a trainee here, Mr. Dalal, who will tell us a couple of worries that he has when he's doing a hip replacement. Over to you, Shaival.
Thank you, Mr. Singhal, and thank you, BIOS, for this wonderful opportunity. I'll start off with a couple of questions which I'm always concerned about while doing a total hip replacement as somebody who's starting out. One is I'd like to get an opinion from the faculty while reaming the acetabulum with the first reamer and going medially. I've always found it a bit difficult to assess as to how medial you need to go right down to the floor, and what are your landmarks and any guidance about that. And the second one is with regards to the limb length discrepancy, which we need to assess intraoperatively. There's a bit of eyeballing when we assess the limb length after doing a total hip replacement. And I'd again like to get the advice of the faculty and our expert panel here as to how and what are the tips and tricks they can give to assess accurately the limb length assessment intraoperatively.
Thank you, Shaival. So Jonathan here would say this is all down to proper preoperative planning. Over to you, Jonathan, because I know you're a great proponent of preoperative planning and you'll share your experience with us. Thank you.
Shav, thanks very much indeed, and thank you for having me here. Hopefully my slides will come up in just a sec. The session's all about what can go wrong with hip replacement, and I think what you've just said is absolutely right. A lot of the problems with hip replacement can be avoided if we actually plan the operation before we get into the operation theatre, and I hope to address those two points during these next few slides. So I am very keen on templating and planning, as you say. Here's my disclosures. I'm a consultant for Stryker on the Exeter hip replacement. I'm going to avoid talking about any prostheses during this presentation. So really, preoperative planning for me can be done in 6 basic steps, and I follow the same steps whether I'm doing this for a simple primary, a complex primary, or one with a robot. The first step is really to assess the x-rays. They must be recent. For me, that means within 3 months. An AP pelvis for hips, showing the femur more than the spine. I use a marker to judge the magnification of the x-ray as outlined by that white arrow. And the legs should be internally rotated 15 degrees to get the valgus right and to get the offset. And this x-ray really shows the difference if you don't. On the left-hand side there, these are the same hip. On the left-hand side there, the externally rotated x-ray, it looks more valgus and the offset is foreshortened. On the right, it's properly internally rotated. You see the true offset and the true varus neck angle. So the second thing really is to look for bone deficiency and bone excess. I find a horizontal line placed across an identifiable landmark like the teardrop very useful, because then you can draw a parallel line across the roof of the normal acetabulum to show any defect on the side that you're going to do, where that defect is and whether or not it is contained. And in terms of bone excess, well, of course, we often have osteophytes around the hip, but other things can also crop up. This person with bilateral shelves has got an anterior bony excess that must be dealt with during the surgery if you're to avoid impingement and dislocation. We've just heard that leg length is a concern, and it absolutely is. It's a key reason why people get sued after hip replacement. So leg length is really key to get right. Again, the horizontal line, either across the teardrops or the inferior aspect of the obturator foramen is a constant landmark, and we can measure down to the lesser trochanter, same point, to assess the true preoperative leg length difference. And then we can try to correct that during the operation. The fourth step is to establish the center of rotation of the acetabulum. On the left-hand side is how I do it with a cemented hip. And the three landmarks I really look for are the teardrop here, the bottom end of the cup being down at the teardrop, the ilioischial line, the reamer here in the dotted line should be adjacent to the ilioischial line. And then the superlateral margin of the hip will give us the sort of correct size. So this is a 54 cut on the left side. On the right side is how I plan an uncemented cup. You can see I've just left that uncemented cup just off the medial floor, and perhaps we can come into that in discussion because it goes back to what your guest just said there about how to ream medially. I'll come on to that perhaps in discussion. So having got the acetabulum in the right spot, we can now measure the femoral offset and size. You can see here, this medial dot here, that's the true center of the acetabulum, and that's what we've got to match with the femur. Now this femur has an offset of 37.5. It's short here of offset, but this one here is 44 offset. And you can see that the femoral offset, the center of rotation is overlapping the acetabulum. And so that's the correct offset for this patient. Sometimes this is best measured by just looking at the femoral template, putting that down the center of the femur there, and then looking at the femoral head and putting that concentrically within the native femoral head. And that will really give you a very good guide to the offset that you need. In terms of stem size, I use cemented stems. I look for where the reamer would be. You can see on this size 3 here, that reamer would be in the cortical bone. That's too large. Here, it's too small. So I'll go between these two, a size 2 probably for that. And then really importantly for leg length, measure how deep your stem is to be inserted. And I measure this line from the tip of the greater trochanter down to the shoulder. And really the key concept here is control of leg length. If you get the cup in the right place, control of leg length is entirely dependent on where you put the femoral component. If you want to shorten the leg length, you put it in further. If you want to lengthen the leg, you put it out leave it out further. So intraoperatively, we would measure the depth of insertion here of the rasp, measure that on the rasp handle, and then insert that rasp to be opposite the greater trochanter. And you know that you've got the leg length right if you've put the cup in the right place. Here's a couple of examples of how to get it right. Very valgus hip and a dysplastic man of 45 years of age with a failed left hip. So I'm going to leave the neck cut long. I'm going to plan to leave the stem further out. And you can see by doing that, you restore the leg length to what it it should be, but you've thought about it before the operation, and so you get the leg length right. Here's an opposite thing, a very varus hip. Here we've got a hip that starts the same length on the other side. We're going to do the right hip. In this case, we're planning to put this, the rasp in 26 mils. You've done that in the operation, and you've got the leg length right. So it's purely leg length is controlled by how deep or otherwise you leave the stem. And this technique has been assessed by the researchers in Scotland, and they found the lowest rate of leg length discrepancy in the world literature of 1.3 millimeters average post-op. So to summarize, I think planning is part of the procedure, absolutely integral to it. I think whether you're using acetates, digital or robotic techniques, you can follow 6 essential steps and you'll get your planning right pretty much every time. I'll leave it there and return for discussion.
Thank you, Jonathan. You have illustrated beautifully why the trainee should all get into the habit of preoperative planning. So to come back to Shaival's original question of preventing a acetabular flow perforation, would you give a tip to him about preventing that? And I'll then follow the same question from Vijay and Sanjeev.
Absolutely. I think it starts with whether you're going to do an uncemented cup or a cemented cup. I think it also starts with preoperative planning. Like I said, the bone deficiency, bone excess. So you're looking for that osteophyte on the medial floor. How deep do I expect it to be? You know that there's always fat in the fovea there. That's your first sign that you're getting close to the true medial wall. And then the medial wall should be identifiable once you remove that fat. With a cemented cup, I tend to ream down to that medial wall, then put bone graft on that medial wall, then cement it in the cup. With an uncemented cup, I tend not to go all the way to the medial wall in every case. It really depends on the preoperative planning and where I want to put the uncemented shell. It is in my view, it's a technical mistake to over-medialize an uncemented shell. I've probably been doing it for years, and it was only when I got into robotic surgery that I realized that was actually reducing the total offset of the hip. So I think the avoiding reaming out medially starts, I don't want to sound like a stuck record here, but it starts with planning and understanding what you're going to try and achieve during the operation before you even pick up the knife.
Thank you, Jonathan. Before I go on to Vijay, perhaps I can come to Sanjeev. How do you prevent a medial blowout?
Well, the views expressed by Mr. Howells are absolutely spot on. And I think preoperative planning is the key to avoiding any such problems during surgery. So before I start, and this happened when I was a fellow in the US, we were not allowed to operate unless we had drawn out a preoperative plan, and that was stuck on the operating theater wall. And that makes you look at the x-rays in detail, makes you spend time with the x-rays, understand how much you want to achieve with the acetabular component. So planning, knowing where to put the socket, identifying the medial wall, as has been mentioned as well. So identify the fat on the medial wall, and that's a good landmark that you've got right down to the medial side of the acetabulum. So planning and identification of bony landmarks for me is key to preventing problems in that area.
Thank you, Sanjeev. And I think both of you have pointed out a very important landmark, which is the fat pad on the medial wall. And the fact that whether you're using cemented or uncemented makes a difference to how deep you ream. Vijay, coming on to you, if you can address this issue, and then I know you've got some illustrative cases of femoral fractures intraoperative. So Vijay, we've already introduced, and he's very kindly joining us from Chennai. Over to you, Vijay.
Thanks for having me, Keshav. Am I visible? Yeah. So addressing this problem of socket reaming, the polygonal fat pad is the most important clue that we all emphasized. Another thing that you do with the templating is that you find out at the supralateral margin how much is your cup going to underhang or overhang. Now, if your cup is not going to overhang on the template, and you find that it is doing so during the surgery, that means you're doing something wrong. You've got to revisit as to your orientation of the cup rather than ream more to get that. So that would be the other tip that I would add. But the polygonal fat pad is really the key point where you want to leave the cup at the level of the true flow Rarely in this plastics, in Pro 2, Pro 3, may have to medialize a little more, but never beyond the inner table, never beyond that. I'd go sometimes in Pro 2, Pro 3, slightly a couple of millimeters more to get superior cover. So that would be my take on that.
Thank you. Would you carry on with your femoral splitting case, please? In your presentation.
I'm not sure it's a femoral splitting, but right, okay. So we'll show you some of the complications that we had in our primary hips. So this is the first one. So this is a 35-year-old patient. She had a road traffic accident in 2008. And you can see that she had a segmental fracture, so which was treated with the elsewhere. I mean, I'm not the surgeon now. So with the supracondylar nail. And then immediately after they did this surgery, they found out they had missed the fracture neck of femur. So another learning point. In these cases, especially segmental fractures, you can miss these neck of femur fractures. So that was treated independently with screws, and you can see a fibular graft there. So she did okay for about a year or so, and then I can see that. That's how she presented to me. It's 18 months since injury. The fracture is almost united, but she's got a very painful hip. And here you can see that she's got avian, post-collapse avian. She's got a fibular graft, the screws. So the obvious thing to do here would be hip arthroplasty. So we decided to, I mean, the distal femur fracture was very united or not. So we had, plate, etc. To deal with it, should we see something else perioperatively. So we proceeded to do this THR just like a routine case. So probably lack of preoperative planning. And you can see the fibular graft in the neck. And I was happy with the post-op x-rays, although perioperatively, we find due to the fibular graft, we had to really bang it hard to get the stem inside. And then about, I think 4 weeks after the surgery, she presented again, and you can see the stem has fully subsided. Now, this is back in 2009, where, the ASR was very popular. This is actually an ASR cup, and you can see the stem has subsided significantly. So the moral of the story is that whenever you have implants, even if you don't have a fibular graft, there can be significant remodeling around implants, screws, the neck of femur fractures, etc. So you must have some instruments to deal with it. You think you can overcome that by force, by just hitting your rasp hard, you are in for trouble. And this is a lesson that we learned. And from then on, anything else that we have in the femoral neck, whether it is all implants, some kind of remodeling, implants that have been removed, we will have a Midas Rex high-speed bar to deal with it. And this was, of course, revised to a distal fitting process. Okay, she continues to do well, by the way. Although the ASR, I've used the cobalt chrome solution stem probably because of that. She continues to do well. So the important thing about avoiding fractures is finding at-risk situations. So when you have some kind of protrusio and you have a constriction of the introitus, you've got to be extremely careful. And this is sometimes miss out. It's what we call the bolted hip. So he has some kind of a proximal femoral nail, and the nail is sticking into the socket. You don't realize it. You have the dislocation is going to be a problem. And as I said earlier, the implants is always a problem. So the golden rule is you leave the implant in situ and you do a dislocation first, and then you take out the implants. The exception being a bolted hip. By do the reverse, you remove the implant and then you dislocate the hip.
So, Vijay, can I cut in here quickly? I saw your first case, and your first implant you used was a collarless one, and then the second one was collared. Do you have any preference these days about using a collared or collarless femoral stem when you're doing an uncemented one?
Yes, the dominant stem that I use is the Korai stem, and we have moved on to a collared Korai from a non-collared version. But having said that, I've not had any problems with the non-collared one. But the Arthro group, told me that's a better way of doing it, so I moved on to a collared one.
So my experience is when I was using Korai non-collared, I used to probably have a femoral split once a year, maybe twice at times. But since I moved on to a collared version, that's a thing of the past. And then you don't have to worry about it subsiding at all, as long as you've got a decent fit. So yes, from my point of view, I think that's a good step forward.
I agree with that, Keshav, yeah.
Yeah. Sanjeev, what do you think of collared versus collarless? Because I know you are collarless, I suspect.
I am, and I used to be a fairly regular Corai user, but I had slight concerns about putting a fully coated stem, especially in younger people. So since I've moved to a proximally coated stem, I use a collarless stem. I rely on the metaphyseal fixation, and for me that works fairly well. Femoral split, very rare in my practice, not that I can remember in the last couple of years.
So Jonathan, you are a cemented guy as far as I can see. You are obviously an Exeter adherent, so you don't get femoral splits, I suspect.
Well, you know, when you use cement, you don't have to go for that press fit feel, yes. And so it is perhaps easier for me to stop with a smaller rasp than it would be if I was going for press fit. And the other thing is that with the cement, because you're putting a prosthesis into cement, you've got control over how deep you put the stem. So I've got control over the leg length without having to seat the stem, you know, after it's already made contact. So yeah, I don't have that much experience with intraoperative femoral fractures, I think.
So Vijay, if you were to have an intraoperative split, how are you going to manage it for the benefit of our trainees?
I'll just show that in a couple of slides. Is that okay, Keshav?
Yes.
Better with the pictures on, yeah. So this is the one with the bolted hip. You can see that. Interestingly, I was doing a live demo surgery with an audience of nearly 1,000 surgeons, and I was a surgeon, and I did talk about all this. And then when I dislocated it, then we had a distal femoral fracture. So all the delegates saw it live of how we manage a perioperative fracture. We put a plate on it at the same time. So be very careful when you have an implant protruding into the socket. You have to remove the implant. This is the exception to the rule that you keep the implant before dislocation. So she continued to do well. This is a hemiarthroplasty, not really a primer hip, but the way of doing this would be dislocate the stem rather than the cup. We find very commonly in our population here, these type of things where it really protrudes your type. The only way of handling is you do a ETO and remove the stem rather than the cup. So don't use excessive force. The directional sizing of your rasping is very important. Varus positioning must be avoided in a non-simplet stem. You will cause sulcar cracks if you are going to rasp your femoid and a varus. So as Jonathan mentioned, if your size during preparation is much smaller than the templated size, it's very likely that you are in varus. So you retrace your steps, find out what's going wrong, and do that. So two types of fractures. The question that you asked, Keshav, one is the calcar split, but you must make sure it's only a calcar split where you just do a wiring and you get away with it. Usually nothing happens. The other one is a fracture that goes below the lesser trochanter, like the one that I showed in my first case. It's very important that this is not a calcar crack. Many people think, just wiring it will do. It will not do. You have to put a distal fitting stem. I repeat again, you have to. Luckily, we have a lot of revision stems in our OR always, so we're able to handle that. But it's absolutely imperative that there's a wiring will not work in this type of fracture. Very typically, an iatrogenic fracture is a fracture on the medial side. The lesser trochanter has the middle part of it. It breaks around the lesser trochanter like that. This would need a long fitting stem. The approaches you are non-familiar with, high risk, like now the anterior approach if you want. Females, age, osteopenia, risk factors, previous implants, bone grafts, etc. So all these things that I said, you got to avoid all these things. It's a preventable problem. Identify risk factors, adequate exposure. Don't do new approaches if you're not familiar with it. High index of suspicion is the key thing for fractures. So identify it and treat it as required. And you must be prepared to deal with intra fractures. Thanks, Keshav.
So I think that nicely brings on to a big problem in total hip replacements, which is acetabular fractures. And to tell us more about it is Anand Nanu, who's joining us over the phone, I believe. Ananda, I hope you're there.
Yeah, I'm here. And you've asked me to turn on my video, so I have.
Brilliant.
Okay, we've had a few technical glitches. I've sent the presentation. I'm not sure that Clockwork Medical have actually got it. But I think the big problem with femoral intraoperative fractures is usually one-off approach. Either you make your incision too small for your degree of competence, or you place it more anteriorly, or you place it more posteriorly. And, I think you've got to be aware that you can do both cemented and uncemented. And if you have a calca crack, and even if it goes under the lesser troch, if you can recreate an intact tube, there's no reason why you can't switch to a cemented prosthesis. Anyway, that's something in the past. So the big issue you get is, I'm just going to show you this slide. Can you see this picture?
Yeah, we can see a pelvis with a right total hip replacement.
Correct. And you look at the right total hip replacement, it's an Exeter Trident. It's not done particularly well. It's in varus, and you can see a bit of calcification around the tip of the trochanter. It tells you that it's most probably done through a hard-hinge approach. So unfortunately, or fortunately, this person was extremely happy with the results on the right. So he's 72, and the surgeon who is performing his other side. So this is a case that is about 5 weeks old. It happened in our unit, and a pretty experienced consultant of 8 years standing was performing this surgery. And he was performing a double table. So he was doing joints in 2 theaters, switching between the 2 with a surgical assistant. So he decides to, despite this person's age, to go for a hybrid, a cemented Exeter with a Trident cup. And can you move the slide one further forward, please? So during the procedure, he finds that the cup is seated deeply. And anyway, to cut a long story short, because time is short, he has an acetabular fracture. So what I want you to think about is, you can have your instruments ready to fix a femoral fracture, either with cabling or with plating or switching your prosthesis. But acetabular fractures are probably something, especially if you have one or both columns gone, where people are pretty uncomfortable proceeding straight away to another level of surgical intervention. And I just thought I'd ask my fellow panelists or any member of the audience, including you, Keshav, what would you do in this situation?
So, Vijay, let's start with you.
Yeah, so I'm not able to see the picture very well, but I suspect there's an intra fracture of the acetabulum. Yeah. So the way we look at acetabular fractures intra is that if it's just a wall fracture and it doesn't compromise the stability, we're happy to do a non-cemented. We never cement our sockets, so we're happy to do a non-cemented socket and put screws inside. But if there is a columnar disruption, it's absolutely important that we will plate that column, especially the posterior column, and then we'll proceed with the non-cemented cup. That would be our strategy to manage if this, what was shown was a posterior wall or a column fracture, although I couldn't see that very well.
I think if you move one slide further, you might get a clearer idea of the...
Okay, we are one slide down. Vijay, you can see that?
Yes. So now there is also a medial wall which doesn't worry me, but per-op you need to look for really expose the column as you do for your acetabular fracture. See whether the column is intact. If the column is intact, quite happy to proceed with just a standard cup and screws. If the column is not intact, you need to plate that column before then, otherwise you're bound to fail.
Okay, so Jonathan, your views on this?
Thanks. Like Vijay, I was struggling to see what the actual injury is in this case. I think the principles that Vijay's just talked about are absolutely spot on in terms of the intact nature of the column and the isolated medial wall. Anand, can I ask, what was the nature of the injury there?
I've actually shown you the CT, and so you gather that obviously the patient was, was backed and the surgeon wasn't comfortable because it was clearly the column was gone, the quadrilateral plate was gone, and he wasn't sure about the extent of the injury. And I think he wisely, and the message here really is that there are periprosthetic fractures and there are periprosthetic fractures. And obviously the easiest thing is not to get into that situation in the first place. But having got there, you've got to know when to bail out. And you've got to know, because if you need to plate the anterior column and plate the posterior column, or you need to span across, or you've got a significant pelvic discontinuity, these are different degrees of problems that will require skills that not every arthroplasty surgeon, I mean, here you're talking to Vijay and yourself, both of you have an immense amount of experience, but the average arthroplasty surgeon in the United Kingdom probably would not be comfortable going into the ilioinguinal or stopper or indeed posterior column that exits high up in the sciatic notch. And so I think the safe thing to do is obviously pack it, close it, image it, and get help. And that was essentially the message. The solution is fairly straightforward once, you know, as both you and Vijay have said, if you just move the slides on. But I think a periprosthetic fracture of the acetabulum is a different kettle of fish as compared to the femoral one, because most people are comfortable dealing with a femoral periprosthetic fracture, but they are not comfortable dealing with an acetabular fracture. And if it's a simple wall fracture, it doesn't really matter. But if it's a column fracture or both columns are associated, both columns, then I think you're in deep trouble and you do need to ask for help. So that was my message, really.
It's interesting, isn't it? Because that's exactly why I said, what is the exact injury here? Because before you speak or before you act, you've got to know what you're dealing with. And that's exactly the message that you were talking about, isn't it, really?
That's right, that's right.
So I suppose the take-home message here is do not get into that situation. The acetabular fractures are very, very difficult kettle of fish. So if I move on, Ananda, do you have any other case you're going to show or share?
No, just the one. And I just wanted the opinion of the panel on. You see, there's such a, if you're cementing the hip, there is, that's why GIRFT in this country has had such an impact, is that the average surgeon, and 50% of us are average, it's easier to get away with cemented both sides hip. But you do need to be pretty meticulous and pretty outstanding to get the same results with an uncemented both sides. And I speak as somebody who's done only uncemented until maybe 4 or 5 years ago. And as one of the proponents of GIRFT, I've now switched, mainly because I can't tell people to do something that I'm not doing myself, not from conviction. I think the difference here is it's a question of line to line. And when you switch prostheses from one to the other, you need to recognize that the reamers, if they are labeled 47 or 48 or 56 or 57, they are sometimes undersized in with some companies. So when you think you're reaming to a 54, you're actually reaming to a 53 because they've built in a 1 millimeter difference for you to get a good press fit. And in some companies, it is actually line to line. So when you say that I always under ream 1, or I always under ream 2, or I always ream line to line, it depends on the prosthesis you're using. And the problem arises when you shift from hemispherical to elliptical, or you shift from one make to the other, and you don't recognize the difference between the sizing of your reamers and your actual implant. So that was essentially the other message I wanted to give. It's one that you see quite frequently. We dealt with the pelvic and acetabular work in the north of England for many, many years. And this was one of the common things we saw when there was a vogue for uncemented cups. So that's all. The 2 points that I thought are important, because it's an experienced audience here, is to say that if you do get into trouble, there's no shame asking for help in the acetabulum.
Thank you, Ananda. Another very quick point for our trainees from my perspective is eccentric reaming, which I've seen a number of trainees do. Eccentric reaming to the extent that they are blowing out of the anterior column. And then you end up in a much worse situation because you have lost your bone stock as well. So you have nothing actually to plate back. So again, you have to have 360-degree exposure, absolutely, and you need to keep on checking over and over again as you ream between one reamer to the other. The next issue that a number of trainees have flagged up is the acetabular orientation and dislocation.
Sorry, Keshav, can I stop you there for a second?
Yeah.
And can I just ask the panelists, why does the reamer always tend to ride up and anterior?
Okay, Jonathan.
You're right. You tend to ream off the anterior wall. And, if you look at it's a design reamer problem, isn't it? And it does happen. And I think one of the things that you consciously need to do is to use your hand to pull the reamer down to stay on the towel and to move it posteriorly, because it does tend to walk anteriorly. And these are tips that I'm sure that the panelists do subconsciously, but it's not something that you tend to tell people that you selectively ream anteriorly. And I think a lot of people who are training have not actually physically been told this until they find out for themselves the hard way. What do you think, Vijay and Jonathan?
Well, I think you're absolutely right.
I don't know why it goes. Sorry, Jonathan. Yeah. So the one tip that I have is the fat pad. You find the true floor. So that of course tells you the depth of your reaming. It also is a good landmark for your anteroposteriorly. So if you are if the reaming and you are where the palmar fat pad was very posterior, then your reaming is very anterior, and so the other way as well. So that area, the teardrop as we call it, must be the center of your reaming. That's the thing that you don't stray anteriorly or posteriorly. The other tip about this thing is no harm in using a trial. Trial I find is very useful, because sometimes the reamer can be blunt, or it can be a new reamer, can be very sharp. So this line-to-line reaming or 1 mm under reaming may not work in all cases. It's always better to use a trial, but you must know what is the differential between the trial and the real cup. For example, the Stryker PSL, the differential is 1.7, is probably one of the highest. The Pinnacle would be 0.6. So unless you know that, you wouldn't be able to do that. So once you know that, I think it's a very safe thing to put a trial in and see that you got your good 3-point fixation before you bang your real cup. Jonathan, sorry, apologies. Check out.
No, not at all. So I'm looking forward to hearing Ananda's reasons why we go high and anterior, because I know that happens, and you're right. Instinctively, we know it happens, but I'm not absolutely sure I've really thought why we go anteriorly. There are some pathologies where that's more dangerous. In dysplastic hips, for instance, it's much easier to run out of bone quickly when you put the acetabulum down at the true floor, and that bone tends to run out most easily anteriorly. In the standard case, I think it's really important you know what the size of the reamer and the implant that you're going to likely put in, and again that starts with knowing what your head diameter is. And if you are finding you're using a reamer that's significantly bigger, like more than 4 millimeters bigger than your femoral head, you better know where you are and what you're doing with that, because that you're getting into danger points. But and Andy, you're absolutely right. We do hold the reamer posteriorly and down, right on the towel. But what is the reason why we go high and anterior?
So if you take a reamer and you spin it, it spins clockwise. And if you look at the cutting flutes in it, it tends to walk anteriorly. And if you think about it, if you're reaming, say, for example, the left acetabulum, your right hand is on the reamer shaft and your left hand is on the gun. So when you're pressing here, with the torque of a clockwise movement, it tends to move anteriorly, and it tends to walk through the bubbles on the cutting flutes. It tends to move anteriorly, and that's exactly the same on the other side as well. And it's one of the things that I always use the hand on the shaft to control, and the right hand is just squeezing the trigger.
Thank you, Anand. We're running short of time, so I'm going to come to dislocation, and I'm going to ask Sanjeev, what is your take-home message that you can give to the trainees for cup orientation and prevention of dislocation?
Sure. I think we keep going back to the first message of planning. As was mentioned in the first talk, planning is crucial. For me, the rigor that the surgeon exercises in testing the stability of the hip will really set his outcomes. And the more honest you are with how much stable you've got a hip on the table, that will be the result of what you get after surgery. So when we do hips, well, certainly when I was trained how to do hips, there's a certain sort of ritual we go through in testing the stability. Not enough time to discuss it here, but I think that for me is the key. I have to be absolutely satisfied that I've got the offset and the length right, and there's no component impingement, no soft tissue impingement, and only then I'll start closing the hip.
Okay. So Ananda, would you put your version or your inclination in a certain way where you got a window of comfort to say, if I'm here, my cup will be not a dislocatable hip?
No, I think the planning is the key to all this. But when I'm looking at the acetabulum, I use the towel, and I think Dave Beveland has taught generations of surgeons this. So use the towel for your inferior mark. If there isn't any osteophyte, if there is any osteophyte, to identify the plane and take the osteophyte off. And I try and keep the anterior rim of my reamer about 1 millimeter behind the anterior, because I don't want the iliopsoas or the anterior structures to touch the anterior rim of the cup so they don't get groin pain. And if you keep the inferior part and your anterior part right, all the rest of it tends to follow, provided you don't ream eccentrically. And we've talked about holding the shaft inferior and posterior when reaming to avoid that. So those are the only tips that I have, because I think, except in a dysplastic acetabulum, and that's a completely different ballgame, it's actually quite simple. You just need to follow the normal anatomy, but first you have to delineate the normal anatomy and predict it based on your preoperative planning.
Thank you, Ananda. Jonathan, what precautions would you take, or how would you deal with a hip that is a leaky hip, maybe going on to superficial and then on to deep infection?
A wound that's leaking on the ward?
Well, yeah, what do you do intraoperative to prevent that from happening on the ward, and then all that rigmarole that happens after that?
Okay, so I think a prevention of leaky wounds starts preoperatively with knowing the patient. If they're on anticoagulants, making sure that those are stopped appropriately according to the indication, etc. If the patient's got a bleeding diathesis, it's about talking to a hematologist and working out what you can do to prevent hematoma formation. If the patient's got a mechanical heart valve, it's working out how you're going to manage the anticoagulants in the perioperative period. Intraoperatively, I think soft tissue handling is key. Meticulous hemostasis is key. I don't tend to use, I don't use drains. I haven't used drains for 20 odd years in either primary or revision. I don't think that they're going to help with the occurrence of leaky wounds. I think post-operatively, if you've got a wound that's leaking, do a risk assessment on the VTE risk, and if possible, stop chemical thromboprophylaxis and keep the mechanical going, but have a very low threshold. I personally have a very low threshold for going back to theatre and washing out a leaky wound, and in fact changing as many components as I possibly can.
Thank you, Jonathan. Last 30 seconds to Vijay. A tip to prevent sciatic nerve palsy.
Well, in complex cases, of course, we do identify the sciatic nerve, but otherwise you stay well away from the sciatic nerve. And I must say that it's very, very rare complication unless you do some major mistake. Complex cases, Crow 4, etc., we do identify the sciatic nerve and we feel for the nerve and make sure you don't, leave it very tense. Otherwise, you stay out of the sciatic nerve.
Don't over-lengthen the leg, because that's a surefire way of getting sciatic palsy.
Absolutely, yeah.
So that's a great discussion. I hope you've enjoyed it. Thank you, Ananda, Vijay, Jonathan, Sanjeev, and Sheval. And we'll call this an end. Thank you so much.
Hello, and thank you to Amit and BIOS for giving me this opportunity. I'm Harvinder Singh. I'm a shoulder and elbow surgeon from Leicester, and the topic we are going to discuss today is research, clinical or otherwise. I've got very distinguished faculty here with me. I've got Professor Bridget Scammell, who is a professor of orthopedics and a consultant orthopedic surgeon. She's a dean and head of School of Medicine at University of Nottingham, and she's the first woman in the UK to be a professor of orthopedics in 2010. I've also got Mr. Subodh Deshmukh. I should call Professor Subodh Deshmukh, who's a consultant orthopedic surgeon at Royal Orthopaedic Hospital in Birmingham. He specializes in hand and upper limb surgery, but as you will hear, he's got a lot of patents, and he's a professor at Ashton University in Birmingham. So we'll start off with Professor Scammell. We're going to ask, this is related to the trainees and what opportunity they get to get involved in research.
So thank you for asking me that, because obviously I have a lot of trainees who get involved in research, as Subodh would as well. So I think there are lots of avenues, aren't there, for all of us to get involved in research, and it's a really important thing to do because we know that by and large it improves patients' outcomes. So I guess the starting point usually is when you're an undergraduate. If you show interest, you might want to attend medical school, for example, that does an intercalated degree so that you can do some research at that point. But there are also opportunities through the societies that medical students have to get involved in research, and those are very active in a lot of medical schools. So once you get to be, I think the seeds are sown then whilst you're at medical school, and you can of course apply as a trainee to become a academic foundation trainee, so that when you're doing your FY1 and FY2 posts, that you choose rotations that have that 4-month academic component in it. And that can be quite a useful time depending on your choice of centre and who you, if you like, strike it lucky with to be paired up with in terms of supervision. I think that can be a very fruitful way to start doing research. And then again, there are the academic training programs, so the ACF program, and then finally the ACL programs. But they're not for everybody, those programs, and not everybody wants to take 3 years out to do a PhD. So if you don't want to do that and you don't want to be a future academic, I think the ways to get involved are that you could take part in a portfolio study, so a multi-center NIHR study, and you could recruit patients into it. You could perhaps be a local PI, even as a trainee. There are certainly opportunities for doing that. And I think that's a really good way of getting involved in research, because you will be in a funded study, part of a funded study that's likely to have gone through the NIHR assessment, rigorous assessment program. It will be involving a clinical trials unit, and just by way of being in a sort of tip-top research environment, almost by default, because of the nature of the clinical trial that you might get involved in. And so those, I think, are the principal ways that you could get involved. The other thing you can do, of course, is to you might just have the bright idea. Where'd you go if you've got the bright idea? And Subodh can tell us about the bright idea and what you do if you've invented something, an implement or anything that needs patents. But if you have a bright idea, if you want to compare A with B, I think the first place to do is to make sure that actually that hasn't been done before. So your librarian can help you to do that correct search. You might be lucky enough that it hasn't been done before. in which case I would take those ideas and speak to others, other like-minded people, speak to people in the Trust R&I, speak to people in the Research Design Service maybe, or in the if you're affiliated to a university, speak to the orthopedic department there. And then those ideas could be taken forward and worked up into a fully blown funded study. But that takes quite a long time to do, but it's well worth it if that's the question that you really want answering. And probably the best way of doing that, I think, is you've always got to be part of a team, and quite a big team because of all the skills that are required. No one person can do that on their own. So I hope that was helpful.
Thank you. So if I can ask Subodh now to please, how do we get a research patent or any patent? What are the opportunities and what are the hurdles that we are likely to experience in such a journey?
Thank you, Harvinder. That's an interesting question. How do you get a patent? Well, I think all the orthopedic trainees need to understand that there are different types of patents available in the world. And certainly for an orthopedic surgeon, there are essentially two types of patents. One is a design patent and one is a utility patent. A design patent is the easiest one to get. For example, if you have a brilliant idea, you can just draw it on a piece of paper and submit it to the design and patent office in Cardiff. And they will do a good search for you. Obviously, it will cost you a few pounds. I think about £70 it costs. And they will ask you some interesting questions on, how to draw this diagram, because they require different views of the interesting idea. And they will do a little design patent for you, and you will get a nice little paper from them that this is now is a registered design patent, worldwide patent, and I think is functional for about 10 to 12 years. The difficulty is converting that design patent into a commercial idea. And I think that's where most design patents falter. And I'll admit straight away that I actually don't have a utility patent, which is a commercial idea. I have one which is in process, but it hasn't reached that commercial threshold. So once you talk about a utility patent, for example, you have a bright idea about say a knee replacement or a plate or something, and you want to ask a commercial company to make it, that's where the commercial views come into play. Is this something which the world will pick up and other things? And the patent lawyers come into play, and it is something which is quite a complex negotiations, or quite a complex set of negotiations which the person has to undertake, and it is quite useful to get a university involved, because they have proper people who can help you to get a utility patent. So I think design patents are easier to get, but utility patents are much more difficult and extremely costly. I mean, to my knowledge, some of the patent lawyers which will give you a utility patent can charge you up to £1,000 an hour. So it is extremely expensive idea, and you need to be absolutely certain that your idea is something which can be commercialized. But that's what I would say about patents.
That's great. Thank you, Subodh. So if I could go back to Professor Scammell, having been unsuccessful in a few NIHR grants, I would like to know your experience of what do you think a successful NIHR grant application look like? I know it's not an easy answer, but what in your experience is,
So I have limited success, but I think you've just got to look at the bigger picture, haven't you? And it can take, I think, don't underestimate the time and the effort that it takes to get one of these grants. And they are a big team effort. And the expertise that you need to put into them is large, is what I would say to begin with. And there are various types of grants, of course. There's HTA grants, EMI grants, so HTA tends to look at one thing versus another. EMI grants tend to look at methodology or the underlying mechanism. And then there's research for patient benefit, again, which tend to look at or can look at pathways and ways that we approach healthcare. And can also be feasibility studies. So I think what you've got to have is not just the bright idea, you've got to demonstrate that you've got a proper research question and that's very carefully thought out and that hasn't been answered elsewhere. You've got to involve patients in the way that you design the study, and you need patients on your steering group who will advise you as to whether what you're doing is feasible. You obviously need to, go through the correct governance processes and get sponsorship, either through a university or through your trust, and you need ethical approval. But what you absolutely need to do is either work with a research design service or with a clinical trials unit. If you don't do that, you're doomed. You have to work with them. And what they will offer is suddenly there'll be an enormous amount of expertise available to you, which comes at a cost because that has to be factored into the grant that you're applying for. But it's really important that you tap into that expertise because we don't have it. But they have it, and they have a whole team who will help you formulate that research question. Usually when you first go and speak to either the research design service or your local clinical trials unit, you'll get sent away with a whole bunch of homework and told to come back another day. And that's fine because you hone down your research question. They'll help you with study design. They'll help you with where to go for funding. They'll help you with the statistics. They'll help you with, the key elements that you need to put together into it. They'll help you with the quality management systems that you require and the whole outline of how you're going to do your study. They'll even help you with disseminating the results and then archiving the data at the end. So they'll offer a complete package if you go to a clinical trials unit and do this. So I think the whole take-home message is this is a big team effort to get one of these big NIHR grants, and it just takes time. Good luck.
If I could now go to Subodh, please. Subodh, you partly answered this question, but I'd still like to take it. I have an idea to make a shiny new shoulder fixation plate. How do I take it forward? What do I have to do? Or what can I do?
Well, assuming that you have got a design patent on this particular plate and it is not a copy of an existing plate, then you have a chance. You have a chance. So the thing would be that this plate would have to be somehow manufactured by you or a company. You can either manufacture it as a metal plate or as a plastic plate, and you can take it through this so-called finite element analysis and make sure that this plate can stand the rigors of a standard plate. So your plate should be at least as good as, if not better, than the existing commercially available plate. And if your plate can stand that rigor in a computer or a simulated environment, then you can go into making it into a metal plate, or you can do what's called additive manufacturing. You can create a 3D printed additive manufactured metal plate and then go through another set of stress testing of this plate. So then engineering department or a mechanical engineering department or a metallurgy department in your local university can stress it to the limit to see how good it is. Once you got that, and you think that where it is as good or even better than the commercially available plate, then the next step would be to consider commercializing it. Now you could either get an industrial patent on that plate so no one can manufacture it, or you can go straight to an industry or a company which manufactures plate and then get an NDA, so-called as a so-called non-disclosure agreement with this company so that they can't manufacture it without your consent. And once you've got an NDA, then the company might consider manufacturing this plate because they might think, well, they don't have such a plate in their current portfolio and they might make some money from it. So it is all about making money. So that company will not manufacture the plate unless they have absolutely an absolute certainty that they will make money from it. You might then negotiate your deal or your cut in that implant. I will be honest with you, I have no such commercially available implant, as I said before. But there are certain steps which you have to take before you can commercialize your implant. So that's all I have to say. If that helps, I hope it helps.
Over to Amit. I think he's got a question for Professor Scammell.
So, hello there.
Hi.
Is Bridget Scammell there? I can't see
I'm here
on screen. Ah, there you are. So, sorry, just to introduce myself, I'm Professor Tolat. I'm one of the orthopedic surgeons in Kent, and I'm very pleased to see you here at our BIOS conference. Bridget, what I'd like to ask you is, we have quite a lot of trainees who are with us for short periods of time, particularly at the junior core training level. And one of the things that has been difficult is to actually encourage them to take up high quality projects, because they always go for the low fruit, so to say, and have something to progress their careers rather than actually concentrate and focus on some things that could be of more lasting change or more valuable research. Do you have some ideas on how that could be facilitated, say through the CRN or any other local mechanisms to get them better involved? Thank you.
So thank you. To be honest, I've never thought about the CRN, and you clearly have. So perhaps we could share those ideas. But certainly, I think it behoves us as supposed research leaders to be able to not just encourage them to do high quality research, but also to facilitate that. And it might be that, you've got somebody who's with you for 6 months to a year, and they do part of a project, or they do the systematic review with others that allows the grant to go in, and so on and so forth. And systematic reviews, of course, we can publish if they're done properly. So that ticks that box, and it also teaches critical thinking skills. I think taking part in larger projects so that you don't think you have to do all of it, I think is really important for them. And kind of almost want to have that sort of pipeline of enthusing people to maybe take some time out if they want to do something that they can really own, rather than be part of a team doing team science, as it were. I think also societies play a part in this, specialist societies. I believe the Hand Society, for example, are very good at this, and they have a network which, so have a network of like-minded souls where they can do team science, and also where they can tap into, if you like, that expertise to run multi-center studies. So I think those are the things that you need to set the groundwork, do the groundwork for them. And the CRN I hadn't thought about, sorry.
Okay, thank you, Bridget. I don't have any questions asked by the audience, so I'll ask one more question to Subodh. You know, despite being 4 and 5 year and a consultant, I was hoping my research interest would die down, but I still enjoy research. I would like to ask, what drives you to do research, Subodh? Why do you enjoy research? What is it that you get out of research?
That's a very interesting question. Well, I mean, I think there are two types of researches you can do. I mean, there's clinical research, and I do a fair amount of engineering lab-based research. And I think clinical research is interesting because it gives you ideas and gives you answers to your clinical questions, which you see every day in, day out. But engineering research is quite interesting because it gives you different satisfaction. You can have some bright ideas, and you can have engineering students who will do that type of those projects for you. And once they do these projects, what really makes me happy is that when they go for their job interviews in different companies, most of the time these students are asked questions based on the projects. And if they've done a good project, and if that engineering student gets a good job offer and he writes an email to me, I really feel very nice that my project has been able to give him a good job in the real world. And that's generally for the undergraduate students. But for the master's students, it's slightly different because they generally have a fair idea of what goes on. And the master's student will then use that project to get a PhD, or even if it's a PhD student, then he will go on to do a postdoc in that particular subject. And you can really answer a very good question if it's a good level master's student. And you can then have sort of multi-departmental research. Currently, I've got a research idea which I'm running through the university, where myself as an orthopedic surgeon, we got metallurgy involved, we got chemical engineering, and we got mechanical engineering, 4 departments involved at the same time, and in a particular research idea. So, and if something comes out of it, I know it will take sometimes even 10 years. So I could be dead and buried by then, by the time something comes out of it. But at least I will see some fruits in the next few years. So these are the sort of things it makes you happy at the end of the day. So that drives me, I must say.
So hi Subodh. I just wanted to, I don't have any questions for you. I just want to congratulate you on your dedication and commitment to doing this work. And also congratulations to you on your professorship as well. So well done.
Well, I had that professorship for a few years. So yes, it's almost expiring now. I need to do some more research.
Okay. Thank you. I don't have any questions on the chat, so I'd like to draw this session to a close. I would like to thank Professor Bridget Scammell for taking the time out despite a busy day of interviewing, and Professor Subodh Deshmukh for taking the time out today to talk to us. And Amitullah, thank you so much. Thank you.
Thank you all.
Thank you, everyone. Thank you.
For a very good session.
Bye.
Bye-bye.
Hello, good afternoon, everyone, and thank you very much to BIOS for asking us to present this session on fracture-related infection. It's obviously a very, very important topic, and it's often quite a challenging problem. So I think that the upcoming speakers will present us with some very interesting cases that we can look at and learn some lessons from. So we will start with Professor Deborah Eastwood, who, as you will all know, is the Vice President-elect of the BOA, and she's an honorary professor at UCL. And I will let Deborah take over now. She's going to talk to you about bone and joint sepsis in children. Deborah, thank you.
Thank you, Deepa, and always a pleasure to be part of this BIOS meeting. So I'm going to talk to you about musculoskeletal infection in children, an old enemy with perhaps a new bite. If we're talking about the limping child in this webinar, we're talking about sepsis until proven otherwise, but sepsis of what? The bone, the joint, or the soft tissues? And either of those infections can be primary or secondary. So one of the big questions is the joint swelling reactive to the nearby osteomyelitis or truly an infective process in its own right? So let's take Alice, aged 15 months, had chickenpox a few days ago and has now presented with pain and a limp, for which she was prescribed trimethoprim for a UTI, a little odd you might suggest. 4 days later, and perhaps not surprisingly, she's worse, with a temperature, white cell count, ESR, all raised. They phoned me on the Friday afternoon, as they often do, with an ultrasound scan, which showed a significant amount of fluid in the right hip, with the arrows there, compared to the left hip. I was told over the phone that the X-ray was normal, that she'd been treated for DDH, well, she'd been observed for DDH in the past, and the X-ray was normal. Mistake number one was she came over to me without the X-ray, and I took her to theatre based on the clinical examination and the ultrasound findings. Now, was it infection? Well, transient synovitis is just like sepsis, but qualitatively different. And it is not a diagnosis that you can make in those under 2. So although Cocker's criteria in Caird's amendment, which is the CRP, are very important, whatever they say, do not diagnose transient synovitis in Alice, who's aged 15 months. So she had clinically and on ultrasound a septic arthritis. So the question is, do I drain this with a needle, with an arthroscope, or do I open the joint up? Whatever you do, you have to wash the joint out well. The hip joint on the whole is a joint that we would open up via an arthrotomy. So I did a medial approach to aspirate and I got pus. So then I did an anterior approach to open up the joint. You must treat your specimens carefully and ask the correct questions. And I took an X-ray on table because I hadn't actually seen her X-ray. And in the frog leg position, her hips were well located. We grew from her, because this is a few years ago, we grew Haemophilus influenzae, which we are not supposed to grow now because of children having a vaccine against this. But if you ask and take a good history, she didn't have the vaccine due to frequent coughs and colds. So always make sure you've taken a full history. Currently, the bug of the day is Kingella kingii. So a 2-year-old now would have Kingella kingii until proven otherwise. We treated her with antibiotics. By day 7, she was generally much, much better, but did seem to have a local collection confirmed on ultrasound scan and an X-ray that was bad. So there's the collection that we did go back and drain on the superficial side, and then we had to deal with her subluxed hip. This was predictable and avoidable had I actually seen beforehand the initial X-ray from St. Elsewhere's instead of the frog lateral view that I did in theatre myself. So we drained her abscess, the hip was looking good, we stabilized her in a spica cast, which we should have done perhaps initially, and she had her PICC line in place. There is an ongoing debate about the duration and method of administration of antibiotics. So this child continued with a pyrexia low grade and a raised white cell count, but she was really very well. And eventually I persuaded the microbiologist that we should stop her IV antibiotics, and she got better instantly. She did in fact have a hypersensitivity reaction to the antibiotics as judged by her eosinophilia as a cause for her raised white count, rather than really a neutrophilia. And a recent paper suggested that PICC lines in children may be troublesome, and in fact more trouble than they are worth. So we have to find a way of treating her with antibiotics without the hassle factor of prolonged antibiotics unnecessarily and PICC lines. So this Finnish study from a little while ago now, but it's still very valuable, says that for a primary septic arthritis, pus in the joint, the duration of treatment in total is probably only 2 weeks, providing the clinical response is good once you've popped the abscess and the CRP has normalized. So IV to oral promptly following drainage within 2 to 3 days. So no need for your PICC line. But if we do need to keep a PICC line in place, we now have outpatient antibiotic teams that will allow that to happen. Is my septic arthritis of the hip in a neonate or a young child primary or secondary? And there's a question about whether all children should have a preoperative MRI to have a look to see for a focus of osteomyelitis. So this paper suggested that you looked at 5 factors, and if you had 3 of them, there was a high risk for an osteomyelitis as the cause of your secondary septic arthritis. And the more recent paper with Dave Skaggs as an author suggests that if the child has had symptoms for more than 4 days, that would be very suggestive of osteomyelitis. So young Alice fell into that category, but actually had no osteomyelitis present. What she did go on to develop was avascular necrosis because of the delayed drainage of her septic hip. Predictable, but thankfully recoverable, because nature is a marvelous thing. And she is now skeletally mature with a no leg length difference and a good quality hip, but not quite perfect. But there are atypical cases of infection in children. There are odd bugs. Young Daniel had a history of chickenpox again, with ankle pain and swelling, which was aspirated and grew nothing. So for a long time, he was treated as a juvenile inflammatory arthritis with steroid injections and disease-modifying drugs. This X-ray at 12 months was considered okay, and I hope that we would disagree with that assessment. 3 years after the onset, was referred to the orthopedic surgeons with an obvious soft tissue infection. We incised and drained it and got no growth. And there were continued discharges and several trips to theatre, to the extent that I was beginning to think that the fellows had no idea how to drain an abscess. But we took good specimens, and in the end, we stabilized the situation with an external fixator, did a wide debridement of the infected tissue, which included the distal tibial epiphysis and the talus, and we stabilized the bone and, if you like, the pseudo joint. Multiple dressing changes. And why did we have such difficulty? Because this child had Mycobacterium kansasii. I'm not expecting you to remember the bug. I'm expecting you to remember that when things don't fit together, start asking yourself why. And again, you have to make sure that you take samples and deal with the samples carefully and discuss in a multidisciplinary team manner with your infectious diseases colleagues and your microbiologists. 4 years on, the child does have a leg length discrepancy as expected, some pain, and the foot shape is not good. But an amazing amount of bone has regrown, considering I thought I'd taken it all out. What I think I did was leave a small shell of the talus behind, and I didn't actually see the clean cartilage of perhaps the talonavicular joint. So my learning point is that I did a good debridement, but maybe thankfully I left some bone there by mistake, if you like, which turned out to be a good thing and helped the end of the case. And they're going to have a lengthening nail to treat their leg length discrepancy. Yara had sickle cell anemia. So we always think of Salmonella osteomyelitis, but Staph aureus is by far the most common infecting organism. And again, we want to know these days whether it's got a PVL positive or negative aspect to that. So this child had a septic hip and aseptic osteomyelitis of the tibia. Required multiple surgical procedures, again, with problems with nutrition, problems with splintage to keep her comfortable and well aligned. And the future is predictable again, that there will be abnormal growth of the hip and of the tibia. So by 15, we'd corrected her overgrown and long right leg, and there's very little evidence of her previous tibial infection there. She has a bad hip and a short leg, so she wanted a new hip because it was uncomfortable. She had a new hip, and she remains unhappy because no one told her that her leg length difference would still persist. So she's got a good hip, but she's still got a short leg, and it makes you realize that perhaps it's the short leg that was causing her more problems than her hip. She'd also been labeled as having multiple recurrent infections because she'd had such a bad start to life. But in fact, there was never any evidence of multiple infections after the first bout. They were just sickle cell crises. So it's difficult to know whether you're dealing with infection or crises. So in osteomyelitis, why do we need to discuss something about osteomyelitis? Well, in general, one of the interesting things is we love to culture fluids. All of these fluids we culture, and discharging mucky wounds we culture. But we don't culture bone. So if the infection is in bone, we think, okay, we don't need to culture it. Maybe just because all the other samples can be taken without a general anesthetic, but the bone would require an anesthetic or at least some substantial pain relief. And so if it is an infection, an osteomyelitis, which is complicated, so it's either gone in through the bone and into the subperiosteal space, or it's gone through the bone and into the joint, that's when you can and should get samples for culture and sensitivity. But if it's an acute, uncomplicated osteomyelitis, there is no pus to drain and no pus to sample. Yes, you could aspirate the cancellous bone, and yes, you might grow something, but on the whole, we tend not to do that. So we reserve the biopsy in osteomyelitis to exclude malignancy, or maybe to identify the specific bugs in the atypical case, which I mentioned earlier. So again, in acute osteomyelitis, uncomplicated, the Finns feel that the probable duration of treatment is again shorter than many places would instigate. So 3 weeks in total, with again a prompt change from IV to oral, assuming the child is responding well to treatment and guided by the CRP level. And of course, exactly which antibiotics you give must be guided by local policies and local prevalences of infection. Infection of the muscle, pyomyositis, is much more common these days, or much more commonly recognized. It's associated with the PVL positive community-acquired MRSA, and a few years ago, every children's hospital would have a case about every month. Now it's perhaps not so frequent. Strep pyogenes can give you the same sort of appearance. It commonly affects the thigh, the pelvis, with a very high ESR and a very high temperature and positive blood cultures. The diagnosis is often on MRI with patchy, small abscesses in many of the muscles, but I mean small, maybe 2 or 3 millimeter abscesses, so not easy to identify via interventional radiology or the surgical knife. But if it is a PVL positive infection, it is more likely to require surgical drainage. And by that, I mean also drainage by the interventional radiology team, leaving a catheter in place. At the other end of the spectrum, there's this lesion, classically in the medial clavicle, with the chronic, relapsing or recurrent multifocal osteomyelitis, or what we now tend to call as chronic non-bacterial osteitis, because that's exactly what it is, non-bacterial osteitis. This is an autoinflammatory, not an autoimmune condition, and it's certainly not an infection. So this is in a different category altogether, but it might bring you to think about differential diagnoses. And if we're going to talk about differential diagnosis of a child with sepsis, for example, this child at 4 weeks had 2 weeks of symptoms. so was referred as a nerve injury and a possible brachial plexus problem, which shouldn't really have started 2 weeks after birth. So always think fracture, always think infection. So the child did not have a fracture of the clavicle, but did have a subacute osteomyelitis of the proximal humerus. If you're going to think infection, think tumor. And in the limping child, although we've been thinking infection, please always exclude trauma. And once you've excluded trauma, you should always think tumor. This child was running around happily when I was asked to see them with their, quote, rampant, unquote, osteomyelitis. By examining the abdomen, we found the mass, which was the primary neuroblastoma, and the secondary deposit in the femoral neck was a tumor, of course. So think tumor, think infection. And when you're thinking infection, think acute, subacute, or chronic. And if you're thinking that, then also just occasionally think of your CRMO. Thank you very much.
Thank you, Deborah. That was absolutely fascinating. I must say, I mean, childhood infection really is fascinating. The term the great mimic has been used for many different diseases like syphilis and tuberculosis. But really, I have to say, in kids, infection really is a mimic. I think we will leave questions until the end, if that's okay. So our next speaker is Mr. Badri Narayan. Badri, if you could start sharing your screen. So Badri is a consultant orthopedic surgeon in Liverpool, and he obviously has a specialist interest in infection and limb reconstruction. Badri also has a huge educational commitment. He's been on the committee of the British Limb Reconstruction Society. He's been a member of the SAC, and he's also an examiner. Thank you, Badri.
Thank you, Deepa. Thank you, Amit, for the invitation. This is going to be a huge step down from the intellectual to the very mundane problems of what happens when things just don't go too well, but fracture fixation. I'm going to be covering a few issues with a few cases, and then Om following me is going to talk about the reconstructive options. Oops, that's my advance. Yeah, there it is. A few declarations of interest, none of which are relevant to the cases I'm going to show. All these cases are from my hospital. I'm not picking anybody else's cases to show. And all these have been under my care in the last 2 or 3 months. So here's case one. This chap is in his 50s and he has a closed fracture of the humerus. He has an attempt at non-operative management, doesn't work. He then has a classic anterolateral approach with a lag screw and internal fixation. And this is a representative picture of him coming to clinic, but this is a screenshot of the clinic letter. Seen in clinic, has a sinus, blood's okay, we're not too sure. Currently, he feels okay. He's just reported the sinus. Let's just see him again. And he goes through this orthopedic cycle of being seen at 6 weeks and at 3 months. He says, listen, there's a wound that leaks, but I'm okay. People say, come back. Let's see what happens if you become really unwell. And this is him at about 12 months after the injury, referred for a full-blown infected non-union of the humerus that needs 2-stage reconstruction. Here's another case from my own hospital. This was a more challenging internal fixation in a woman in her 50s. A bicondylar fracture has been fixed with 4 plates. She goes on to be discharged. She comes back to clinic, and this is a tertiary referral. So she comes back to the orthopedic clinic at about 6 weeks, and that's a screenshot of the clinic letter. I understand she's been on flucloxacillin because she developed redness or the anterior aspect of her leg. So what happens then? She's told, continue with the fluclox for a few more weeks and we'll see you back. She comes back at about 4 or 5 months, and it says, had recent signs of cellulitis and inflammation, but these were settled completely through several courses of flucloxacillin. And you know what's going to happen next, right? suppress for another 3 months, and then we'll remove the plates when the fracture heals, and we'll see how you get on. And this is 30 months after the initial trauma, with full-blown raging osteomyelitis that is not settled after removal of the plates and screws. And she now needs a medial gastroc flap and very aggressive debridement of her osteomyelitis. And now here's another case. And those of you who've been actually paying attention will recognize that this is the same clinical photo. And in fact, the clinical photo that I showed of the arm was actually this patient. Look at this for a change. Same hospital. Here's a blue spear documented MDT discussion of somebody who has a post-op infection, admitted because the wound looks a bit dodgy at 2 weeks, CRP done, but people are concerned that the patient is not improving. Now, why is this so different compared to the other two? The age of the patient is the same, in her mid-50s. She has a similar wound compared to the first two, which were treated with flucloxacillin. It's only because this is an infected joint replacement and people's alarm bells are ringing and everybody is going crazy about a wound that doesn't look quite right. Why are we treating such similar presentations so differently? The patients are the same. The organisms are likely to be the same. The pattern of formation of the biofilm is likely to be the same. The treatment is established for a prosthetic joint infection, which is do not start antibiotics, aspirate if possible, get deep samples, and then decide whether you want to do a debridement and implant retention. Fracture-related infection costs a lot of money to treat. It costs at the minimum about 4 times the amount of money to treat a fracture-related infection as it does to treat a simple fracture or a simple non-union. We can't avoid fracture-related infection, but we can mitigate the enormous burden to a healthcare service by early and appropriate management of fracture-related infection, of early and appropriate management of suspected fracture-related infection, by following some simple guidelines just as you have in the arthroplasty world. What are these guidelines? The BOA came up with these guidelines about 18 months ago, and these are fairly simple. They are in many ways the same as the arthroplasty guidelines. If you have a problem wound before it's healed, you want a consultant level urgent review within 24 to 48 hours. If you have a problem with the wound, ideally in your discharge letter, the patient should know, or the GP should know what to do with the wound. There should be a referral pattern available for the GP or the patient to seek advice. If you see somebody with a problem wound, you should have a defined MDT management, including radiology and microbiology for the management of these patients. What does that involve? It can involve something as simple as an urgent deep ultrasound to check whether the collection is deep or whether it's superficial. Based on it, what should we do? This is not beyond our level as orthopedic surgeons. If the collection is deep, we've got to drain it. And while we're there, we should look for the stability of the fixation. If it's unstable, if it's a distal locking screw that's backing out at 4 weeks, there's no point trying to imagine that this is stable fixation. It's going to fail. We've got to look at the soft tissues and assess whether the soft tissues are amenable to tension-free closure with a 3/0 nylon or a 3/0 monocryl. It's not, it's particularly around the ankle and the anterior pilons and the proximal tibia, you're more likely than not to fail. You've got to have multiple samples, and we've got to have deep samples to check whether these are susceptible organisms or whether they are resistant organisms. And based on these three, stability of fixation, status of the soft tissues, and the pattern of bugs, we can then decide whether we can suppress the infection or whether we need to revise. Suppression will work about 50 to 60% of the time, depending on how you define your outcome. If your outcome is defined as, hey, I've got this fracture to heal, suppression works more than 80% of the time. The problem is you may then be left with osteomyelitis. So it all depends on how you define your outcomes. But if you're to suppress, be careful in these scenarios. So this is a chapter from the standards for the open fractures, but that's a QR code to the specific chapter on infection suppression. And this is extensively referenced. So in summary, if you have fracture instability, if you have an iron nail, if you have compromised soft tissues, if you have a poor host, if you have difficult organisms, try to avoid suppression, because the chances are you're not going to work. It's not going to work. It's not going to work. If you have somebody with the MEPO, do not try to simply debride the entry wound and the exit wound of your plates. A debridement means that you need to open the entirety of the plate and wash it out by connecting all the wounds, rather than trying to do minimal suppression by just washing out the entry wound of the plate and then landing up with a big problem that needs a big debridement. So debride and wash out, but make sure that the entirety of your plate is seen and access for you to clean it up. If you can't suppress, if you think you want to do an acute exchange of implants, this will work particularly in the upper limb. It will work particularly if you have plates covered with good soft tissues. It will work if you have susceptible organisms, typically your staph that's sensitive to multiple or antibiotics, but it's unlikely to work if it's a B host. It's unlikely to work if you have hospital-acquired organisms like enterococci, Pseudomonas, Klebsiella, and all the nasty bugs from the escape group of organisms. If you're trying to do an acute intraoperative exchange, simple common sense things work, like take out the original implants, give the bone a clean, assess the stability, re-prep, re-drape, and start afresh, and keep the patient on IV or oral antibiotics for at least 7 days until your extended cultures come back. This is where it gets a bit sticky. This is coming to the end of my talk. This is what the guidelines say, that if you fail in your treatment, you need a defined referral pathway within your trauma network for failure progress. So if you've tried suppression, if you've tried acute revision, and if it fails, you need a referral pathway. And that should be aligned with your orthoplastic network. There should be a regional bone infection unit that takes these patients for you within a few days. And that can be almost dismissed by the thousands of us, in peripheral hospitals, ivory tower thinking, saying this is impossible to achieve, and it's challenging in the real world to get bone infection units to take these patients within a few days of us calling them. But you have to remember that we have come on a long way, particularly in the last 10 years as an association. And if you can imagine people with major trauma, etc., 10 years ago being taken to peripheral hospitals, now being shipped directly to bigger units directly, I think it's worth us pursuing this as an organization, because as our current president said in an editorial, identifying problems in the delivery of care should stimulate progress towards delivery of care and not entrenched thinking, saying this is what I've done and this is the way I'll be doing it. So in summary, these are the BOA guidelines for the management of acute fracture-related issues. You should have a policy for the management of the problem. If there is a problem, you should ideally have consultant-level review of the patient within 24 to 48 hours. You should at least have facilities for an urgent ultrasound for these patients to check whether your infection is deep or whether it's superficial. Please, based on the guidelines, based on the patient host, based on the type of implants you have, consider suppression or revision, and every network should have a good defined pathway for failure of these patients to progress with suppression or revision in the treating hospital. Many thanks for your attention.
Thank you very much, Badri. That was really interesting. And certainly for the trainees in the audience, I would urge you to read the fracture-related infection boast, because certainly you will come across it somewhere in your exam. So we'll move on to our final speaker, Mr. Om Lahoti. Om, if you could start sharing your screen. Om is a consultant orthopedic surgeon in King's College, London, and a specialist in bone infection and limb reconstruction. Thank you. He's also the current president of the British Limb Reconstruction Society.
Thank you, Deepa, and thank you, BIOS, for giving me this opportunity. Because we're running short of time, I will probably skip through some of the slides, but there will be some repetition. Okay. Oh. Can you see my screen? Hello?
Yes, we can see. Thanks.
Yeah. Okay. So you've seen these numbers and the burden of fracture-related infections. I won't dwell on it. I'll move on. And these cases which I'm going to discuss, we decided beforehand that case-based discussion would be more useful. So I'll go through the details. But these are all the principles which Badri has nicely outlined, so I wouldn't dwell on it. But I'll show you some cases to just how we plan it. Okay, there are many ways of incorporating all the principles you have heard and all the methods of investigation. And I find this a little classification, although it's not well tested, but it gives the outlines of how to deal with this. These are ICS approach. It's a framework of management I tend to follow in my practice. So is there infection? Yes, there is infection with all the signs. And is that early or late? Why do you differentiate between early and late? Early is within first 2 weeks, and late could be anywhere up to 4 to 6 weeks. And that's the difference is biofilm. In early, there is not enough time for biofilm to form, so you can still suppress, so-called DIR approach. Whereas when it becomes late, the biofilm has formed and implant is probably causing first osteitis and probably osteomyelitis. Okay, then callus. Callus is hearing. Is the construct stable or the bone making any attempt to heal? So that's another factor you have to throw in. And then, of course, the stability of the implant. Is the implant holding it, doing the job, or is doing the damage? Intramedullary nails go from entry point right the way down to the rest of the bone and can cause trouble. So that's the framework, and we'll go through that. And that gives rise to that ICS framework, gives rise to these three sort of scenarios. Early infection, callus is seen or progressing, stable implant. Yes, you can go for maybe local debridement, superficial, give antibiotics, and retain until the fracture heals. But you should be prepared to change your tack anywhere. So this is where the consultant and the team should closely follow the patient and not leave it to anyone on the team. It should be consultant-led. And when the callus is non-progressive, here is a problem. You're watching, this is a common problem or common issue. You say, well, infection is not that rampant. Callus might form and the implant is stable. And again, here you could use some of these techniques to improve, particularly host physiology. But more importantly, in my tertiary practice, I get these infection, no callus, unstable fixation, and of course, all those signs of failing implant and failing bone, and sometimes failing patient. They've lost the patients. Okay, here is a story of a 30-year-old who fell off a ladder, peel on lower tibial. There were lots of blisters, skin very compromised, span and plan. After fracture blisters settled down, patient was taken twice to theater to have plates all around the tibia. But the wound broke down as soon as they closed the wound, literally. So it's an early case of early infection. So here is the sequence. The lower tibia, the skin was just, compromised here. It got better. And then first this plate was applied. And for some reason, the consultant thought they should go and do some more reconstruction and put that plate on. And soon after, we saw this, and that's when he was sent. So here is a situation where the implant is stable. It's early infection. Is pretty much clinically localized to the medial side. Lateral side looks good. So here I took an approach of, limited debridement, took out the medial plate, gave him IV antibiotics, and the construction was stable. So followed him up carefully, and here is his healing. And then we took out the implant. Then you should treat them with follow-up antibiotics to treat any residual infection like osteomyelitis through the screw holes. So that went on to heal with DIR approach. So the next case is, it just shows what all Badri had been saying. So this is a 23-year-old male with this kind of fracture, isolated injury, non-smoker, reasonably in good health, and had this fixation. So he went on to have an IM nail 3 days later. I looked at the operation note. It took them 4 hours, and they really struggled and somehow bailed out. And here it is. So he wasn't really happy. There was a lot of swelling. He wasn't feeling good, and he started having trouble. Somebody should have really started looking at, this is a difficult injury, and there's a high risk of deep infection. But all along, he was being treated for, he has never had an issue with his surgical wounds. That's what the word it said, but he was in a lot of pain and thigh was swelling. Then soon after, he formed a thigh abscess. I thought it would have just occurred to the treating team that it is much more than superficial infection. See, they again did the ultrasound. I don't know how they got to that, and just said it was superficial. And this was drained in theater, or they went on to say, well, this is superficial infection, give him antibiotic. So that's his sinus. Soon after abscess drainage, there was somewhere else, and then he started forming sinuses through those surgical wounds of locking sites. Okay, then further abscess formed. Again, they were holding on to him. They said, well, take oral antibiotics, etc. And then another dose of antibiotics, sinus more proximal, getting a lot of pain. And then they started worrying about no callus progression. This looked like a sequestrum, and that's when the CT scan and everything happened. That's when he was sent to us. And that was during COVID time. And ideally, this should follow implant removal, debridement, maybe single or two-stage treatment. So he had all the signs, and for trainees to just say confirmatory signs and suggestive criteria, you can read up, but he had all the signs. Okay, so can we predict the treatment in these cases? So I suggest you look up a BACH classification that divides the infection risk to straightforward infection to complex and no treatment option. So here it is. So uncomplicated is one group, complex, limited depending upon BACH, that is bone involvement, antimicrobial options, coverage by soft tissues, and host status. This is a good classification and a good idea good framework to work out whether there's a limited option or a complex treatment which is going to need 1 or 2 stages, or simply DAR would work. So in this patient, is segmental infection without joint involvement. So intramedullary nail is treated as B2, so that's the most severe of this classification stage, and the rest of them were reasonable. These isolated staph aureus, which was sensitive to antibiotic. So during COVID, access to specialist center was limited, so that delayed the treatment, which didn't help. Anyway, I had to go to the other hospital and do a 2-stage. I would have otherwise done single stage, but I had to do 2-stage. So first stage involved taking the nail out, draining it, taking the sequestrum or as much dead bone as possible, and fix it with an intramedullary nail. Don't leave it without stabilization on a pin traction. It doesn't do patient any good. And to add further stability, I added just an external fixator, specific IV antibiotics, follow it up with CRP. And as Badri said, this is no mean exposure. This is just a thorough debridement. This is second stage after 3 weeks, or 4th week when CRP was coming down, wounds were looking good. You could prolong this to another 2 weeks, but I was very happy with all the developments. So here is a problem. Whether you go back and put an intramedullary nail, some would say that, but if you see the preoperative or pre-treatment X-ray, there was deformity and there was gap in spite of the nail in that position. So you have to address not only the infection, create stability and an environment where biology will help this fracture. So local antibiotic delivery, intravenous antibiotics, and a stable construct without violating the marrow again. And a follow-up, that is the timeline. If you see, it started sometime in January, and now it is June. So I saw him last, and he started healing. And what is forgotten about this is that sort of delay caused a lot of stiffness of the knee. Quadriceps was other end, he could barely flex 30 degrees. But once we stabilized him, got the fracture going, fortunately, knee recovered. So, we tend to forget the function in these chronic infections. And it's very important to take that on board, because that is the single most factor which affects the quality of life, not just how well your implant is holding or how well it healed. Here's a story again of a case where we are lulled by a little bit of wound infection, a little bit of wound discharge. So there's a 40-year-old involved in motor vehicle accident, multiple injuries. He's a smoker, and he had a medial wound on the proximal third of the tibia at the fracture level, so it was just debrided.
Yeah. Don't panic, but the lights are going to go down.
Okay. Okay.
Just for effect.
So,
so it'll be like, thank you, and then the lights
I think someone just needs to turn their mic off, if that's okay. Thank you.
Yeah. Okay, so that's a non-union, infected non-union with the intramedullary. This is a different beast. There's a lot of bone, devitalized bone, and that definitely involves segmental excision and circular frame and acute shortening, because this fellow was not fit for plastic surgery. So we had to do all that using a circular frame. So that is frame, acute shortening with nearly 4 centimeters or 3.5 centimeter excision of bone, acute shortening on table, and bifocal treatment with distal lengthening, because it was very close to the proximal metaphysis. I couldn't have lengthened there. So that's its final function. Again, I just emphasize on this function is very important for limb recon surgeons or any orthopedic surgeon dealing with this problem to get in there to maintain function. We can control bone infection with clever antibiotics and other things, but if you start losing joint function, that has a very adverse effect on quality of life. So in a quick sort of wrap up, the fracture-related infection ranges from uncomplicated to very complicated, and BACS classification clearly outlines this at the very beginning. So you can advise the patient, create all resources, and maybe decide an early amputation or something on those lines. So try and get access to specialist centers if you're not in a specialist center. I have a liaison service, and it can be a single stage or 2-stage procedure. Thank you very much.
Thanks very much. That was a very strong message there.
Yeah.
Thank you. That was a really clear message to be careful of bone infection, make sure that they're caught early and managed early. And as you say, function is everything to the patient. Thank you. I think that because we have run over a little bit, in the interests of time, we won't be taking questions. I'm really sorry. But if you do have any questions, please do send them in, and I will try and answer them as best as I can. Thank you very much. Thank you to the organizers, and thank you to our speakers.
Is Kodali Sivaramakrishna Prasad from Prince Charles Hospital, Meditidville. On behalf of BIOS, I thank Deborah, Badri, Om, and Deepa for excellent presentations. And it appears the best for the last. Thank you all. We shall go for AGM after a brief lull. Thank you.